Robert, shall we begin?
Okay, yeah, for the presenters, I'm gonna give you a 1 minute warning. I'll just say, I guess I'll do it in the chat. Um, and then if you go on, you know, too much, each more than 7 minutes, I'm gonna just have to say, okay, it's time for the next one. So we wanna make sure James is last and we wanna make sure he's able to speak. Um,
Okay, and you might have to give me a verbal clue because I don't see the chat, yeah? If I go
oh,
over
okay.
7 minutes, thank you.
Okay, I'll do that. Um, all right, so let's get started then. So I'm Robert Dubrow. I'm a professor of epidemiology and also faculty director of the Yale Center on Climate Change and Health at the Yale School of Public Health. Welcome to this session on climate action for health, what's stopping us, which I will be moderating. Of course, those of us working to increase climate action for health have encountered many barriers. On a macro level, these barriers include lack of political will, inadequate funding, and insufficient high-level strategic planning and coordination. But it's important to delve more deeply and with specificity into barriers to climate action for health. And that is what we will be doing during this session, which will cover implementation research, non-communicable diseases to overcome this dark period in disaster settings, resilient health facilities, action by health professionals, data and evidence, and multi-sector action. In the interest of time, I will do only a brief introduction for each panelist. If you have comments or questions, please put them in the chat and we will try to get to as many as we can after all the panelists have presented. So our first panelist is Dr. Revati Falke, who will speak about barriers to implementation research. Revati is the head of the Climate Change and Health Group of the UK Health Security Agency, formerly Public Health England. Her main interests lie at the intersection of climate impacts and the challenge of operationalizing resilience within health systems. Dr. Falke is a contributing author for the IPCC Sixth Assessment Report and lead chapter author for the UNFCCC Adaptation Gap Report. Dr. Falke.
Thank you, Robert, for that kind introduction, and morning, afternoon, everybody. I am going to try in the next 7 minutes to outline some of the challenges and the barriers that we face for scaling up ambitious implementation research for climate change and health, and also kind of end with a thought of how we can address these inequalities. So next slide, please. I think the main challenge that we are facing in our current understanding of how risks are distributed and what is actually being done in terms of responses on the ground is the evidence inequity. And I think although the amount of research that has gone into understanding climate risks for health and the other way around has increased exponentially in the last couple of years, there are still significant gaps in high impact areas in the world. And if you see also that in terms of the distribution of the topics that are covered, there are some topics that are still neglected, and one of them which is close to my heart is of course the health systems resilience and how health systems are preparing and responding to the climate change and environmental challenges that we face today. Next slide, please. I think the first thing we, all researchers and practitioners should be thinking about is to move away from what is feasible now versus what is actually needed. And I think that majority of our work, of course, speaks to, and of course, without proper good quality data, it is difficult to conduct research. And of course, I'm not proposing we do data-driven research alone. But that combination is that where do I want to get in the next 10 years, and what kind of surveillance systems do I need to put in place now, where, so that 5 years from now we are in a better position to deliver the research that we want to and that we should be delivering. Next slide, please. This is really my almost my final thoughts. Is that what are the persistent challenges that global health researchers are seeing? And I'm speaking from a public health researcher's perspective, and I'm sure that colleagues from the environmental sciences and the climate sciences will have their own views on this. But I think the first thing is that we do, and this is my personal view, is that we do lack to some extent the level of ambition for implementation research for health, public health, and climate change. And the other thing is that, yes, we do talk a lot about co implementation, co design of research, but to a very large extent, we still see practitioners and policymakers as consumers of our research, as somebody who are uptaking or the end product is of value for them. And I think that there is a movement in bringing them back to the table to the conceptualization phase, where they are part of almost commissioning what is it that they need to know, when is it that they need to know, and then is the research community kind of catering to the needs of the people who are making the decisions on the ground. And yes, nationally these things are important, but more important from a adaptation point of view, it's about doing this at the local level, risk assessments and responses both. Of course, needless to say, financial barriers are there, but there are also barriers of data infrastructure. In many high impact countries, we still don't have the longitudinal data sets, the time series data sets that climate scientists would need, particularly for health, and also the data resolution. But majority of the impacts need to have a high resolution data, and we still don't have access to. So, what kind of systems can we put in place so that we can have that data at hand when it is needed? Needless to again say, the recognition of urgency. So we have been a bit slow. Climate change necessarily requires us to repurpose some of the methods from other fields, because of course the interdisciplinary science and the wide interconnectedness of health and climate change both. And we necessarily need to scale up the repurposing of existing methods in other fields that need to be brought into public health to look at how we can do that. Knowledge mobilization as well, that yes, a lot of knowledge is generated but not necessarily mobilized to the people who need it in a time that they need it. So that is another barrier that we need to do. In the last couple of years, things have improved, but we still overtly focus on understanding risks. And I'm not saying we don't need to do that. We need to do that on a continual basis, but we need to match that ambition with how the responses are being done, and what can we learn from those examples. Publication bias, definitely, that we have more often published successful case studies. And I think what we really need to do is to balance that bit, also bringing around evidence of what has not worked. Because only when we have the complete picture of what works and what doesn't work, we will be in a better position to prioritize the implementation work that we need to do. And of course, we need to have a united voice for scaling up financial support for implementation research in science. And I'll end with the last thought. Next slide, please. I'll end with the last thought, which says that there is a lot of problem with this phrase of what gets measured gets done. And I would like to have another phrase, which is also problematic, but different from this one, which would say that, you know, what is being currently done needs to be measured. And that needs to be shared out so that people can learn from their mistakes as well, because they're as valuable as successes. Thank you.
Okay, thank you, Revati, for a very nice and concise talk. Okay, so our next speaker is Dr. Saria Hassan. She will speak on barriers to the protection of people living with non-communicable diseases during and after hurricanes. Dr. Hassan is Assistant Professor, Department of Medicine, Emory University School of Medicine, and Hubert Department of Global Health, Rollins School of Public Health. Dr. Hassan is an internal medicine and pediatrics physician with a research interest in applying implementation science tools to address the needs of people living with chronic disease in humanitarian settings. She has worked in the Caribbean for the past 5 years. Dr. Hassan.
Thank you so much, Rob, for that introduction. So what I hope to do in the next 7 minutes is really build on that framework and challenge that Revity has given us to really use the framework of implementation science to think about how we can do better at addressing a very important gap, and that is addressing the health of people living with chronic disease during and after disasters. And so let me first kind of just set the stage with some definitions. I will refer to NCDs, or non-communicable diseases, and those include diabetes, heart disease, lung disorders, cancer, and mental health. I'll also talk about extreme weather events, and the most recent IPCC report that lists the ones that you see here as extreme weather events. But I'll be focusing primarily on storms, including both tropical and non-tropical cyclones. And I do that because in the last 5 years, we have seen significant devastation all around the world. Again, as Robin mentioned, I focus on the Caribbean. And 2017, Hurricanes Irma and Maria, the complete and total devastation and destruction we saw in the Caribbean. We saw it again in 2019 with Hurricane Dorian in the Bahamas, where Category 5 hurricane lingered for over 48 hours over the islands of the Bahamas. But it's not specific to the Caribbean, as many of you here know. Cyclone Idai in Mozambique, the severe floods we just recently saw in Kerala State in India. But what we're starting to understand is, what is the morbidity and mortality beyond the destruction that you see in these images? What is the morbidity and mortality that we're seeing after these events, and what are their causes? And we started to spend a lot of time and focus from a research perspective understanding this after Hurricanes Irma and Maria. And this is data from the United States, which showed that almost 90% of the deaths that we saw after Irma and Maria were indirectly hurricane related. And 35% of those were due to exacerbations of existing medical conditions. So what does this translate to? A lot of attention, and there was a lot of controversy around the mortality that we saw on the island of Puerto Rico after Hurricane Irma and Maria. But what we clearly saw is that there was a significant increase in the excess deaths due to Hurricane Maria in 2017 compared to the historical averages during that day. And further research has focused on what the cause of that excess mortality was, and clearly pointing to the NCDs, the non-communicable diseases, being led by an increased excess death due to heart disease. And so that brings us really to today, where we're trying to learn more about how these extreme weather events worsen NCD-related outcomes. And what does that mean to the world, not only just the Caribbean region? And there are several mechanisms that we know lead to this: extreme weather events worsening NCD-related health outcomes, limiting access to healthcare, worsening mental health, and what that does to NCDs, and causing displacement and migration with limited access to healthcare. A disclaimer that all of these citations you see here are data from high-income countries. And so what does this mean, though, for low and middle-income countries? Well, the IPCC report clearly showed us that what we're going to see in the future as a result of climate change is an increase in the amount of precipitation we see as a result of tropical cyclones all over the world, again, not just in the region I'm working in, that we're going to see an increase in the strength of these events, again, including these low and middle income country regions you see highlighted in the middle figure. And then perhaps a change in the wind speed as well from non-tropical cyclones. But what we also know is that there's been a significant rise in NCDs among the most vulnerable, with the most recent WHO data showing that at least 75% of mortality due to chronic disease occurs in low and middle income countries. This is data from the Global Burden of Disease study. The top one shows 1994. Blue is disability adjusted life years due to chronic disease. Pink, disability adjusted life years due to infectious disease. You compare 1994 in the top to 2019 in the bottom, you clearly see this epidemiologic transition from an increasing cause of mortality, or in this case, disability adjusted life years due to chronic disease. So what is this going to mean? Well, what this means is that I'm kind of positing that we're going to have a new double burden of disease for LMICs. The increase in NCDs combined with the increase of severe weather events that the new IPCC report showed us. But LMICs have weaker health systems and greater vulnerability for a number of reasons. And this is therefore going to cause worsening global health disparities. What can we do about this? How can we do better at understanding, again, responding to Revati's call, understanding what the challenges are to managing chronic disease during disasters? The scoping review that we did in Health Affairs highlighted some of those, as the disrupted healthcare systems, communication challenges, mental health challenges, the access to clean water, and the access to healthy food. And it proposed some solutions, that we needed better surveillance systems, better chronic disease self-management, more access to medication and healthcare service points, but importantly, again, in response to what Revati was saying, a call, a need for evidence to inform the integration of NCDs into disaster preparedness and response. And this disaster preparedness and response can occur at multiple levels, as we know, from the individual to the regional level. And so we've now started a collaboration with many of the organizations you see listed here to understand what we can do better to address that challenge of people living with chronic disease and disaster. The challenges and primarily that lack of integration between NCD and disaster divisions, but also the opportunity of today. And for what COVID has brought us, one thing it has is this opportunity to collaborate at a regional level. How can we leverage that now to address regional response to people living with chronic disease? And really this focus on NCDs and the Build Back Better movement, leveraging that again to show us how we can do better at integrating NCDs in disaster. And so I propose to you a way forward, acknowledging the urgency of now, and that's primarily why most of you are here today, acknowledging this new double burden of NCDs and disasters that will worsen both in-country and between-country health disparities. We need to leverage this moment, COVID-19 opportunities giving us an ability to focus on NCDs and regional collaboration. But we need to develop and test strategies for how to integrate NCD management and disaster preparedness at all levels. We need to build and improve upon NCD surveillance systems, build those resilient health systems that you're going to hear about more in a minute. And we need the evidence. There's really a role for implementation research in this area to generate generalizable knowledge on the approaches to address the needs of people living with NCDs in disasters that can be adapted to different contexts. Thank you.
Thank you, Saria, for a wonderful talk. Okay, so our next speaker is Major Clemens Buter, and he's going to talk about scaling up resilient and green health facilities. Clemens is the lead planning and operations advisor in the Health Emergencies Department of PAHO. Specifically, he serves as lead planning and operations advisor for the implementation of the Smart Hospitals Initiative in the Caribbean. In addition, as a member of PAHO's Regional Health Response Team for Emergencies, he has contributed to disaster response efforts, including those for Hurricanes Irma, Maria, and Dorian. Major Buter.
Thank you, Robert, for that kind introduction, and good morning to you all. And also thanks for the opportunity to present you the Smart Healthcare Facility in the Caribbean project during the next 7 minutes. I think this is a great practical example of what can be done in the area of climate sustainable and resilient systems. An example is the healthcare facility, the Baroli Health Center in St. Vincent. Later on in my slides, I will show you the before picture as well. The project is funded by the UK Foreign Commonwealth and Development Office in the amount of £46.3 million, implemented by the Pan American Health Organization, of course, in very close collaboration with the Ministries of Health. The Caribbean is hit by natural disasters every year, and in the event of an emergency, health facilities to treat the sick and injured are vital. Over 2/3 of hospitals in areas of higher risk of disaster and health services are frequently disrupted following storm, hurricane, earthquakes, heat waves. We recently had the volcano eruption in St. Vincent, and on top of that, of course, we have the current pandemic, and climate change will further increase this level of risk in the Caribbean. More than 67% of hospitals in Latin America and the Caribbean are in areas at higher risk for natural disasters and climate change. At the same time, hospitals represent almost 70% of the Ministries of Health national budget. In the Americas, 61% of the impact on health facilities is caused by earthquakes, 17% by hurricanes, 14% by floods, and 8% by health emergencies. These numbers are even outside the current pandemic. But it left millions of people without proper health care and resulted in billions of dollars of direct cost. In phase one of the Smart Hospital project in 2013, 2 demonstration retrofit projects were done. One at the Georgetown Hospital in St. Vincent, which was an older facility, and the second at Poxon Hospital in St. Kitts, which was newer, both of which proved to be successful. The retrofitting works included replacing the windows to meet higher design wind speeds for this region, strengthening of the roof to accommodate solar panels and ashfall in St. Vincent, improving the natural lighting and ventilation, and improving the fire safety and emergency egress of the facilities. 10 months after the completion of Georgetown Smart Hospital, the energy data was reviewed and there was an estimated 58% reduction in electrical consumption. Similar checks were done at the Poxon Hospital in St. Kitts, and that facility saw a 50% reduction in the electricity bills. So it's not only climate change adaptation, but also mitigation. Phase 2 of the Smart Healthcare Facilities in the Caribbean project started in June 2015 and is still ongoing as we speak until the end of December 2022 in 7 countries: Dominica, Grenada, St. Lucia, St. Vincent and the Grenadines, Belize, Jamaica, and Guyana. And what we are trying to achieve is really to enhance safety standards, to reduce the downtime and damage to hospitals from natural hazards. And I think the 2 facilities in St. Vincent recently showed that after the eruption of the volcano. Lower operating expenditure due to water and electricity consumption savings. Later on in my presentation, I will say something more about this because this is one of the things that is challenging us as well. And national and regional capacity building to apply smart standards. So what is a smart facility? It's both safe and from natural hazards, and it's green. There are several win-win ways to accomplish this, which in the process can be cost-effective, cause a reduction in greenhouse gas emissions, achieve climate change adaptation measures, risk reduction, and development benefits. The image shown in the presentation defines what it's meant by smart. It illustrates that improvement in safety or an A score on the Hospital Safety Index results in a safe facility. A score of more than 70% in the green checklist equals a green facility. The graphic presents safe and green factors to consider and where and when these are combined, help to create a sustainable smart facility. Other measures, such as use of eco-friendly flooring, paints, furniture, and furnishes, will further contribute to the increased sustainability and risk reduction. Health facilities can also improve their smartness by greening their operations. This includes using less paper, recycling, generating less and properly disposing of waste, solid and otherwise, proper disposal of pharmaceuticals, using environmental benign chemicals, and using more local sustainable produced food. So please allow me in the final few slides to give you some examples of what we have been doing. We basically have 3 outputs. Output 1 is assessments and training. Output 3 is specifically PR. Of course, you can find us on the internet, and we're on social media as well. But more importantly, we trained over 400 people in applying the Hospital Safety Index and Green Checklist. And this database that was generated, over 400 healthcare facilities were assessed. We actually trained over 1,000 people doing these assessments. And these 400 facilities, we have the data now available. The Ministry of Health have the data available. And that is very important to guide future decision-making and also to attract other donors. We put a lot of effort. One of the challenges in the Caribbean is, of course, maintenance. So we developed a preventative maintenance manual for healthcare facilities, and we provided many courses to maintenance staff and health staff. The importance of contingency plans, to rehearse these plans, to check these plans, to do simulation exercises. And finally, what we worked on as well is while patients, occupants, health staff, members of the community, when they're waiting in the waiting area anyway, it's a good moment to show them videos, show them posters, flyers, to teach them as well what they themselves can do at their own homes. For a simple example is, for example, the installation of LED lights. So the aim is to finish at the end of the project by December 22, 55 healthcare facilities. There's many more in the Caribbean. I heard a number of about 650. We've done over 400 assessments, so there's many more to do. And we're going to deliver 6 full designs to the Ministry of Health. By the end of this year, we should have 40 facilities done. And as I promised, this is the before picture of the Baruri Health Center in St. Vincent. Some challenges, of course, with COVID-19, the travel restriction, which is also a challenge for quality assurance. So we can't always send our inspection teams to check what's going on. I think very important building codes and standards. Sometimes they are there, but we need to make sure that the people and the countries are using those codes and standards as well. In our project, we work with design and inspection firms. We have technical consultants, but on top of that, we have the check consultants, which are really important for review, second opinion in the area of structural, mechanical, electrical, and plumbing, and even quantity surveyors is essential to the success of the project. 2 things I would like to highlight. We always worked on a saving maintenance mechanism. So the savings we generate by installing solar panels, we want to use those savings for maintenance. The problem is that the bill of the utility bill is actually paid by the Ministry of Finance from a consolidated fund. So we're looking at ways and discuss not only with the Ministry of Health, but also with the Ministry of Finance to make sure these facilities have their own budget and there is an incentive when they see that they saved money and that money can be used in their own facility. Another thing is the utility companies' policies. For example, when I are forced to deliver my electricity from PV panels to the grid, and they pay me back 25 cents. And when I use electricity from the grid, I still need to pay about $1, which these amounts are different in every country, but obviously is not something we desire and needs high-level commitment and discussion. Just to finish, very happy to see that, from smart concept, we became a smart movement in the region. We see increased engagement of national partners. We see a lot of interest from other donors, so not only our own donor, FCDO, but also, for example, the EU in BVI, in Belize, in Sint Maarten. BVI is using the concept even for the new courthouse. They're using it for their schools. We are working with the EU in Sint Maarten. We do not only do retrofitting, but we do 2 new shelters in Sint Maarten. We have a lot of interest from the private sector who really want to adapt as well. So we really see increased capacity building. And this is what I would like to present. Thank you very much for the opportunity, and back to Robert.
Yeah, thank you, Clemens. Very important work. All right, so the next speaker is Dr. John Kocher, who's going to talk about barriers to action by health professionals. John is a research assistant professor at the Center for Climate Change Communication, George Mason University. His work focuses on identifying ways to effectively communicate about the health implications of climate change and air pollution, and developing strategies to help a wide range of organizations more effectively activate and empower citizens to shape society's response to climate change. John.
Sorry about that. I was still muted. And now I can't control my slides. There we go. Thanks for that introduction, Rob. So I'll be talking today a little bit about a survey of health professionals that we conducted in the fall of 2020. These were mostly general adult medicine physicians spread across 12 different health professional societies in a variety of different regions around the world. Um, so when we talk about engaging health professionals on this issue, I think ultimately what we want to aim for is having more health professionals helping various decision makers improve their decisions, make more informed decisions about how to mitigate and adapt to climate change, whether it's government entities, civil society, industry, or even just individuals. And this can, of course, take place in terms of decarbonizing health systems, as Clemens talked about, or it could entail health professionals speaking directly to their patients about climate change, or health professionals might work through a variety of some of these intermediary organizations to influence government decision makers. So when we looked at how prepared health professionals are to take these sorts of actions, one of the things that we wanted to look at was whether they in fact already see climate change as an important health issue. And so what we found is that for a variety of specific health impacts, a majority of the participants in our survey already thought that climate change was making those health problems worse. And then a third to nearly half thought that climate change was already making a variety of other health impacts worse. But when we asked them whether each of these impacts would get worse over the next 10 years if nothing was done to address climate change, majorities of our respondents thought that all of these impacts would get worse. So the take-home message here is that many health professionals already feel that the impacts of climate change are already adversely affecting health in their country, and that it's only going to get worse if nothing else is done. When we ask them whether they feel that health professionals have a responsibility to bring the effects of climate change to the attention of policymakers and the public, we found that large majorities of participants felt that they had a personal responsibility to do this. And this is important because in other research, we found this to be a strong predictor of whether or not health professionals will actually take action. But as we know from many years of social science research, even when individuals perceive a threat as relevant to them and feel a responsibility to take action to address that threat, a variety of barriers can prevent them from taking action. And so what we found, perhaps not surprisingly, was that the most frequently cited barrier for health professionals to doing more public communication about climate change and health was a perceived lack of time, that they just don't have enough time to do this. Another 41% said that it was a lack of knowledge that was stopping them from doing more public communication about it. About nearly 1 out of 3 said that they thought it wouldn't make a difference if they did so. And then smaller proportions of respondents also cited a lack of support from their peers, perception that the topic is too controversial, or that it's too risky for them professionally or personally. When we asked them what resources might be helpful to them, we found that majorities of the respondents felt that continuing professional education on climate change and health would be useful, guidance on how to make their workplace more sustainable, like Clemens talked about. They were interested in action alerts on how and when to advocate with policymakers about climate change and health, as well as more training on how to communicate effectively about it. Finally, a majority were also interested in additional patient education materials on the issue. So just briefly to sort of talk about how to address some of these things, in terms of the time constraints, right now it's not entirely clear to what extent this is a perceptual barrier versus a real barrier. It's probably some combination of the two. And so right now, I think it would be good to try and figure out whether there are interventions that could be provided that could sort of calibrate health professionals' perceptions of the actual time required for some of these actions. So for example, it may only take a few minutes to actually send a letter to one's elected official. And so one potential solution that's been proposed is providing people with a menu of different actions with actual estimated time required for each of those actions, so that they can see that perhaps it's not as much, it doesn't require as much time as they originally thought. But I think it's also critical here to develop programs that really incentivize health professionals to do these sorts of actions, so that they're actually rewarded for these sorts of efforts. In terms of lack of knowledge, clearly there's a demand for more continuing education and medical education about this issue. And I want to stress that it's not just about helping them better understand the impacts of climate change, but also the benefits of solutions to climate change. So in some of my other communication research, we found that talking about health solutions to climate change is potentially even more important in terms of raising people's awareness and concern about the health effects of climate change, more so than talking about the impacts. But really, it's the combination of these two things together that is optimal. And then also, just to underscore that continuing education should involve not just information about those two things, but also training health professionals on how to communicate clearly about this to a variety of different audiences. So obviously, talking to one's patients is going to be very different than, for example, testifying before government leaders. And then finally, how to address the lack of efficacy, the perception that it wouldn't make a difference if they took these actions. So one way to do this would be to use role models who have actually had successful experiences and have a track record of making an impact by taking these sorts of actions. And it may be in climate change and health, or it may be from other health-related problems, right? And so using those prior examples to show how health professionals can make a difference could be useful, and we need to do more research to figure out how best to formulate those sorts of interventions. So I'll go ahead and stop there. I'll just let you know that the study that I talked about today was published in Lancet Planetary Health, and this was a collaboration with the World Health Organization, the Global Climate and Health Alliance, as well as the World Medical Association. Thank you.
Thanks, John. Very nice work. Okay, our next speaker is Dr. Georgiana Gordon-Strawn, who will talk about integrating multi-sector data and evidence for action. She's director of the Tropical Metabolism Research Unit of the Caribbean Institute for Health Research at the University of the West Indies. Georgiana specializes in epidemiology, health policy, health services research, research methods, and biostatistics. She's a member of the Essential National Health Research Committee, Jamaica, which has now developed a national research agenda and is working on a national health research policy as a part of Jamaica's Vision 2030 strategy. Georgiana.
Thank you for that lovely introduction, Robert, and good day to all joining. So I'm going to be looking at integrating multi-sector data and evidence for climate action in the Caribbean. What's stopping us? So I'll start by just looking at the lay of the land. And in looking at the lay of the land, I will just look at data governance in terms of the laws that exist within the Caribbean. So I'm happy to report that all Caribbean countries have a Statistics Act, and that there are 15 Caribbean countries with data privacy laws, Jamaica being the most recent of these countries, Bahamas being the first to start and to enact their data protection and data privacy law. So we can start by saying that the legal framework exists for the protection of personal data and the integration of data for the provision of national statistics. We can't talk about data without looking at the ICT infrastructure. And in the Caribbean, all countries have comprehensive ICT infrastructure for business processes. If we look specifically at health data, what we will find is a mix of sources and ways of collecting and archiving data. These include purely electronic database systems, and some are hybrid systems, which are some of it is paper-based and the rest is electronic. Now, an unfortunate thing is that our patient medical records are mostly paper-based. As you all know, health is not just the freedom from disease, it also includes environmental and social determinants. Within the Caribbean, these data are collected by several different agencies, and so it can present as a fragmented type of ICT infrastructure. On the weather and climate side, our meteorology and hydrology data are all electronic, and this is in part due to the Caribbean Institute for Meteorology and Hydrology and also the country meteorological offices. So we all know that if we're going to be integrating this system of data, we will have to look at the basic components. And the basic components, everybody knows, would be health and climate change. From the health perspective, the sources that we have are varied. So we have clinical sources in terms of disease data, we have environmental data, there's agriculture, there's data from planning agencies, and the list goes on and on. For climate and weather, we have meteorological data for most of our countries, but we also use some remote sensing sources, such as NOAA's satellite, for getting our weather data. We're obviously not just satisfied in getting real-time data. We also want to be able to project our weather data to build climate models using different scenarios and using predictive mathematical models. And we have been doing this. We've also downscaled our data so that our projections can be more specific to our vulnerable areas and our vulnerable communities. There are several projects going in the Caribbean which are trying to build climate resilience. And I'm just going to mention this one because its first objective and primary objective is to improve regional processes to acquire, store, analyze, and disseminate relevant climate data. And under the Caribbean regional track of the pilot program for climate resilience, funded by the Climate Investment Fund, implemented by the Inter-American Development Bank and the University of the West Indies, we have been able to improve our LIDAR data, which would be our bathymetry and topography data. So it's all good on the climate front. So what's stopping us? In our situation, where data exist, the integration of the two basic components requires the sharing of data across agencies. And not just the sharing of the data, but the synthesis of these data into reports on useful indicators. Now, it may seem simple, why not just draft up some data sharing agreements across these agencies? But our experience has shown that this is not as simple as it appears. There's also an issue of trust in handing over data and the misuse of data. So mechanisms for integrating data of different types and architecture is also necessary. Improving and maintaining our ICT infrastructure where data exists is also quite necessary. But where we do not have data, it gives us a great opportunity to decide on which indicators matter to us from a climate and health perspective, and to build the systems and mechanisms for collecting these data and for testing these interventions for integrating systems. Now, what we're doing is not new. The Lancet Commission has been reporting on indicators for climate and health since 2015 and launched their 2021 report in October. So as we look towards the future and look towards the horizon, we see that we have several opportunities, and I'm only highlighting 3 in the interest of time. So the launching of the Lancet Countdown, so regional center, for small island developing states, for tracking the progress of health and climate change is an excellent opportunity. And this will help us to build on existing frameworks for integrating multi-sectoral data for tracking the impact of climate change and health in SIDS like the Caribbean. The University of the West Indies is hoping and has secured some funding for the development of a climate health observatory for the Caribbean. And this will start first with one country and then will be built out. It is also good to note that efforts towards data digitization have increased, and this is now a major component of funding for several of the multi-development banks and agencies who have recognized this as an important effort. So I will close with 2 points. The first is that it's very important to integrate multi-sectoral data for climate and health, and we all know why, so I don't think it's necessary to reiterate that. But after sharing this data, there is still a lot of work to be done to understand the outputs and to understand how to use the results for climate action for health. Thank you.
Thanks, Georgiana, for that great talk. Our final speaker is Dr. James Hospitalis, who will talk about joining up the silos for climate action in health. James is the founder and CEO of Earth Medic and Earth Nurse Foundation for Planetary Health. He founded Earth Medic and Earth Nurse to mobilize health professionals and others to address the climate and health crisis. He chairs the Defeat NCD Partnership Executive Committee, addressing NCDs, non-communicable diseases, in low-resource countries. He also was inaugural executive director of the Caribbean Public Health Agency. James.
Thank you very much, Rob. Good morning to everybody who's joining us. I hope you can see my screen. So I will be talking about joining up the people in the silos. A point I make that it's not the silos that cooperate, it's people in silos that cooperate. And we really need to do more of that to be able to act at the speed and scale that we need in climate action. Now, if you look at the policies and plans to address development challenges, such as climate change, they typically contain phrases such as multi-sector collaboration and public-private partnerships. But is this just rhetoric? In our conference on climate change and health last month in the small island states, we heard the need to join up the silos every day, every session. But as one former minister told us in the conference, people are not wired for collaboration. Around a cabinet table, each minister is thinking of his or her needs. In public-private partnerships, the private sector values time and money differently from the public sector and academia, which can lead to misunderstanding and breakdowns in collaboration. Often there are constitutional or legal barriers. I heard that in a One UN, One Ocean webinar in the COP a couple of days ago. The language of one sector may be very threatening to another sector, and so on. And so joining up people in the silos has many levels, and it's been touched on in several of the previous presentations, including Georgiana, who just spoke. First, within the health sector, more collaboration is needed between hospital and primary care, between public health authorities, and between practitioners who are operating in the private sector. In Trinidad and Tobago, there are hundreds of private GPs. So Clemens, I think your greening system could work very well there. Second, between health and other key sectors, environment, planning, agriculture and food. Saria made the point of the importance of health linking up better with disaster and emergency management systems, transportation, media and communications to reach people, academia, South-South-North collaborations. I would note that there are some industries and sectors where you have fundamental conflict of interest from a climate and health point of view, such as the tobacco industry and fossil fuels. If we think of the climate and health movements, and if you do a Google search on climate and health, there are many organizations, initiatives, partnerships, and alliances, only some of which are shown on this slide. Most of these alliances are based in the global north. There is no single go-to organization for doctors and nurses. So the question I ask as a physician is, are we like a heart in atrial fibrillation, with a lot of muscles contracting and nerves firing, but with no effective cardiac output? How do we establish more sinus rhythm? Do we need a climate and health leaders meetup for better collective impact and action? Now, what works in joining up the people in the silos? This is an area that's really ripe for research. In a recent UN meeting, I heard one person from FAO said, money works because if you put money on the table, if the Green Climate Fund and others specify that people need to work together, it's a big help. Having one overall idea or compelling vision is another way to try and join people up. And I think that climate change increasingly will become an alarm bell that hopefully will pull people together. Joint meetings and joint sessions for planning and for working together. Mandates from the Dominican Republic in our conference last month, we heard the representative say that mandates work very well if the government says, you know, you need to work together. Georgiana was talking to me that going to the other sectors with health arguments and showing the data that health is touching everything is one way also of bringing people together. Reframing. I worked for years trying to get attention to the problem of diarrheal disease in the travel industry. They used to call me Dr. Diarrhea. But when I reframed to talk about improving profitability through attention to health and hygiene, I suddenly had a much more receptive audience. Training is needed in climate matters, in health diplomacy, and specifically in negotiation and partnership. What are the skills that we need in the health sector to be able to work more effectively with others? Maybe we need some aggregators. I recently came across climatesavers.com, which is about how do you decelerate the climate crisis by accelerating collaboration. This slide focuses on something that I've found useful in my own efforts to build alliances and partnerships. It's interest-based negotiation training, such as that based on the books of Roger Fisher, Getting to Yes and Getting Past No. The stick man on the left is my summary of an easy to remember diagram of 7 key points in any kind of negotiation or partnership building. And the two at the top, relationship and communication, are really key. I call them the keys to the circle of power, to really understand people's interests and come up with, explore options that could be win-win for different parties. And it's more difficult in the remote world of that we now have to inhabit, virtual meetings, Zoom meetings, to build relationships and communication. A lot of communication is nonverbal. So how do you do that in a virtual way is a different kind of challenge. And you see at the bottom some publications that have looked at if negotiation improves performance, and a website that in Cambridge, Massachusetts, that does a lot of this training for the UN and WHO system. Building on the negotiation skills training is partnership building skills. This cartoon attempts to put some perspective on different complex challenges. Everybody is consumed by COVID, but the economic recession is a contingent on that, is a big problem that's coming along. And as most people on this webinar should know, climate change is going to be a much bigger problem than COVID is per se. The partnership initiative based in the UK is one group that specializes in partnership skills training for multi-sector action, and also works with a number of UN and WHO partnerships. So I hope in this talk I've given you a few ideas for how to join up people in the silos, as that's a common symptom or common complaint in all these sorts of sessions on how to achieve better collective action. Thank you very much.
Thanks, James, for really pulling things together there. I think a common theme across many of the talks was the need for partnerships, the need to work together. Another common theme was, or a barrier that we're facing is the need for evidence. So we have about 5 minutes left. So let me open it up to the panel. Maybe, and participants should feel free to put questions or comments into the chat. But let me actually start by asking Saria in terms of, you identified the barrier of lack of integration between disaster management and people working on NCD control. How do you see ways to try to overcome that barrier?
Yes, absolutely. And I think it's already starting. And that's probably what's most exciting. Organizations that are primarily responsible for disaster preparedness and response in the Caribbean have started to train their own disaster response individuals on mental health management, for example. So SEDEMA has done a lot in training their response providers on mental health. Similarly, the World Diabetes Foundation has funded training to integrate disaster and NCD preparedness course, so that now people who are interested in being responders can actually have training on NCDs. So the conversation started, and what we now need to do is to evaluate these interventions so we're able to scale them up and scale them out.
Great, thanks. Another, I think okay, so actually I'm seeing a question come up, so maybe let's see. Okay, it's question, can you speak to the role politics, special interest influences, and disinformation, misinformation can influence regressive no action on climate and health? Are there ways in which political gridlock denialism can be overcome? Wow, that's the big question. So let me open it up to the panel.
That is a big question, Rob. And we live in a world where disinformation and misinformation spread faster than the virus can spread. And some folks live in one echo chamber and other folks live in a different echo chamber. And how to get around that, one climate scientist that I've seen, Catherine Hayhoe, has published a really nice book called Saving Us that focuses on identifying not the differences, but what are the common values we share with others, and build a relationship with them around those values. And then perhaps you have a better chance of having a discussion that's productive rather than one where we're just fighting each other. I think I don't have the complete answer to this. There will be more pandemics to come. And so we actually need to be better prepared for the waves of information, misinformation and disinformation that are likely in the future.
Yeah, thanks, James. John, I don't want to put you on the spot, but as a communications person, do you have thoughts about this?
Yeah, so I really can only speak to the US context since that's the focus of my research. But, actually part of the strategy of talking about climate change as a health issue has historically we found a lot of evidence that it actually resonates across political viewpoints. And that's part of why we advocate for it as an effective way to talk about climate change, because as James talked about, one of the common values that we share is an interest in protecting health, right? And so I think that's really one of the ways to do it. The other is to find effective messengers, right? So that's also part of our interest in talking about the health effects of climate change is health professionals tend to be one of the most trusted sources, even more so than climate scientists in some cases. And so that's really an opportunity there. And in some cases, if a health professional isn't the right source, finding other speakers who can speak to the issue in terms of, say, for instance, a religious standpoint, or even a member from one's own political party who just happens to have views that are counter to the dominant view within that political group can also be effective.
Yeah, thanks, John. So our hour is up. I think this was a wonderful panel, and thanks to all the panelists and also to all of the people who attended.
Thank you, Rob. Thank you, everyone.
Goodbye.
Thank you.
Good morning, everyone, from COP26 here in Glasgow, in Scotland. My name is Mark Major from the Partnership on Sustainable Low Carbon Transport, and it's great for me to be moderating this session today on transport policy that delivers for health and climate. We only have an hour, so we need to be careful with our timekeeping. And what we're trying to achieve today is thinking about, like, how do we assure policy coherence between transport and health. We're going to present the idea of the avoid, shift and improve framework as a way to ensure this coherence, and also reflect together a little bit on how potentially the wrong transport decarbonisation pathway could be really disastrous for human health. So if I can get my slides, please, that would be great. So I'm going to give a brief introduction, and then we'll have 5 brief contributions. And if you can go on to my slides, please, I'll introduce the people later. Next slide, please. You need to catch up. Okay, so the way that we're looking at this is, transport has dramatic impacts on human health, through road accidents, for example. 1.2 million people a year killed but also the issues to do with the reductions in activity, air pollution, and the cost as well of congestion and activity. But transport can also make a very positive contribution to human health. So if people are more active, if the air is clean, if people can move safely, this has tremendous benefits. So it's like possibly negative aspects and potentially positive aspects. Next slide, please. So we've put together all this information in an infographic to make it really simple to communicate. And this slide is purely just to give you the QR code. So that information graphic summarizing this positive and negative aspects is available online, and we'd be very happy to use that. And we're very grateful to the Wellcome Trust, who has supported our engagement in the Health and Climate Network and made this work possible. So thank you for that. Next slide, please. This one is really important, particularly for health people that are not so familiar with the transport sector. So this is the paradigm for reducing environmental impacts of transport. We call this the Avoid, Shift and Improve network framework. And many of you will understand that there's a huge focus in many of the discussions, particularly here at COP, about decarbonising the energy of vehicles. So the whole discussion about electric cars, okay? So this is improving energy, but there's other ways you can improve transport as well. You can improve the design of vehicles, you can make them lighter, better materials, more recyclable. So there's many ways that you can improve vehicles. You can also improve fleets, you can improve operations, the way they're driven, that you can improve them being full. So that's the whole improve area, which tends to dominate the transport conversation. But there's another part of the policy which is to shift to more sustainable modes. So we'd also say that actually another priority is to shift from higher carbon modes, unsafe modes, more expensive modes to more efficient, cleaner, safer modes. So there's the shift paradigm as well. And before that, even there is this whole question of avoiding unnecessary transport. So what people don't need transport, they need access. So if you get an access to watch a film online, if someone sells me a water filter so I don't have to buy bottled water anymore. So there's many ways I can have access to the things I need with actually reducing transport demand, like an online meeting. So actually in our work, we're really trying to kind of capture that you need to do avoid, you need to do shift, and you need to do improve. And improve can be about operations, it can be vehicles, and it can be about fuels. So be careful. Don't just think about transport as clean fuels for vehicles. Think about this broader framework. And this broad framework also kind of delivers for health as well. So if you're avoiding unnecessary transport, getting people onto more active modes, people who use public transport walk a lot more than people. So active mobility is not just walking and cycling. So this is the framework which, if you're in the health sector, is a good way to guide your thinking about transport. Next slide, please. The last thing we want to do is just give you a little bit of a teaser of some of the work that we're still ongoing and will be coming out with next year, is we're looking about the system level impacts of different kind of transport solutions. So thinking about health, or climate or congestion. So like we're kind of ranking these according to their impacts on system level impacts. And this is, we think this is a good way to kind of bring together thinking about transport policy, health and climate objectives together. And so this is just like a heads up of this kind of framework that we're developing. And my last slide, if we come to it, is also taking that to the individual level. So we're looking at different types of users, maybe someone who's kind of like a worker in a suburb city in a middle-income country, or someone who is kind of a young person in a high-income city. So thinking about different types of users and how these policies can actually have different impacts on them, whether transport is affordable or safer or cleaner, or good for the climate. So this is just teaser for some work we're doing now, and this is a way that we're going to try and practically bring together these different elements, climate, health and transport, at system level, and for different real kind of archetypes of users. So look out for that coming at the beginning of next year. So I'd like to stop there with that brief introduction. Hopefully that kind of helps you orientate yourself in the discussion and links to what others are going to say. We have 5 speakers, and I'd like first to introduce Olga Lucia Sarmiento Dueñas from the Universidad de los Andes in South America. If she's in South America, then she must have got up very early to be with us today, so thank you for that. Olga, you've got 6 or 7 minutes, so you have the floor.
Which is also funded by the Wellcome Trust. And I don't know if you can share my slides. Or I can share them. I don't know. Thank you. So, as I said, I'm presenting on behalf of the Salverbal project, and you asked me to present on some best practices related to transport, and I am bringing 2 best practices from the region of Latin America. So one is the one that you see on this picture, which is the open streets or ciclovías, where we close the streets for automobiles at least once per week or during Sundays and holidays, and we open those streets for individuals, basically for leisure activities. And the other one is what you see here in this picture, which is the cable car that is linked with the mass transit system to provide transportation. It's an electric car for the poorest population that we have in the city. Next, please. So as you said, Mark, transport has a lot of benefits for health. And in this graph, we see some of these benefits that you actually were talking about. And the first one is that we have seen that transport really affects the city. So we really need to, in our countries, in low and middle income countries, we really need to place health and health equity at the center of the planning and at the center of those policies on transport, because as you said, transport is related with mental health. We have seen, for instance, that individuals that use public transport in Latin America have less depressive symptoms than individuals, for instance, that use other modes of transport, like, for instance, private cars. We also know that transport is associated with road trauma, non-communicable diseases, promotes physical activity. We also know that it's associated with respiratory diseases, infectious diseases included COVID-19, and heat stress. Next, please. So I want to underscore that as you probably know, that Latin America is one of the most urbanized regions in the world. And while this urbanization led to economic and social development, it also brought along of challenges related with social inequality, climate change, and population health. But as I said, we also have some innovation on transport interventions. One is the one that you see again in this picture, which is the Ciclovia program. in which, again, as I said, we close the streets for automobiles and we open the streets for individuals so they can do leisure activities on Sundays and holidays. So we are worldwide, we have documented, as you see here in this map, at least 500 programs in 20 countries. Most of these programs are, as you see also in the map, in the Americas. And importantly, most of the regular programs, which are the ones that have more potential impact with health, are in the region of Latin America. Also, I want to underscore that during our pandemic, we saw that at least 90 cities in 20 countries, including the city of Bogota, where I live, and the city of Mexico in Mexico City, also use some of these roads that were for the Open Street program to create temporary and then permanent bikeways for decreasing, for instance, the congestion on the public transport. So we're seeing how many of these programs are integrated with transport also to, in this case, to decrease agglomeration and decrease, for instance, in this case, the possibility of transmission of the virus. But especially in Mexico City, in Bogota and Chile, we have evidence also of other co-benefits of this program. So we have seen, for instance, reduction of air pollution on those segments that are closed. We also have seen that individuals have higher quality of life related to health. Obviously, we see physical activity promotion, and through physical activity promotion, we also have seen that we can prevent some premature deaths. Next, please. And the other best practice that I wanted to highlight is this one, which is the cable car, another innovation in the region of Latin America, but now this innovation is through the air. So these are cable cars, electric cable cars that are linked to the mass transit system, to the BRT or to the metro system, and they provide transport to the poorest populations that live on self-built settlements, slums, and most of these programs are in Latin America. We have also documented 25 cities, and as you can see in the map, most of them are in Latin America. The highest expansion was in 2004, when for the first time in the city of Medellin in Colombia, we saw that it was linked to the metro system to provide transport to the poorest population in the city. And we have specifically evaluated the new cable car that we have in Colombia, which is Transmicable, which is what you see here in this picture in the city of Bogota. And we have seen, or on our natural experiment, that the cable car is associated with reduction of air pollution in transport microenvironments due to the decrease of time and the fact that it's an electric vehicle. We also have seen that this urban transformation related with a transport intervention is related with quality of life, specifically among women. The individuals who use the cable car, these are individuals who live in poorest areas, who are not likely to have cars, that are more dependent on the public transport. And we see that they are physically active, and those who use the cable car are more active. And we also have seen that violence in those areas where these programs are implemented decreases, especially violence during homicides. Last one, please. So just to summarize, what we have seen on these programs that are out of the health sector but are totally related to the health because they are social determinants of health, so that we have seen that they are associated with potential impact on the environment, health outcomes, and health behaviors, especially on vulnerable populations of these urban settings. Now, there's little evidence that we have of those potential impacts just from a few cities. But more importantly, on our evaluation, we have seen that working with multiple sectors has been important because policymakers out of the health sector, especially from urban planning and transport, now recognize the importance of health and livability indicators on these programs. And as I said, this is funded by the Wellcome Trust, and it has required this multidisciplinary group. Thank you.
Thank you very much, Olga, for that, being up early in the morning to be joining us for Colombia and sticking to your time. Much appreciated. We have about 20, 25 people here in the WHO Pavilion at COP, as well as the people following online. Please take advantage of the chat for any questions you might have. Olga might be able to respond to some of the questions online immediately. But now I'd like to turn over to Carly Gilbert-Patrick. She's with the Sustainable Mobility Unit at UNEP, joining us, I believe, from Nairobi. Carly, you have the floor.
Great, thanks. Thanks for having me, and happy to be here to be part of this conversation on the critical link between health and climate. Next slide, please. So for those who don't know me, nice to meet you all. I'm Carly. I am a pedestrian, a cyclist, a mum, and also the team leader for active mobility, digitalization and mode integration at UNEP. Next slide, please. So I think what's really interesting is we talk quite often about not having enough evidence, but the science is actually really clear that we're in the midst of this triple planetary crisis that's affecting climate, but also nature and pollution. And, you know, I really think the common thread is there's this unsustainable production and consumption, and it's impacting not just the health of our planet, but also the health of us as individuals. And at the Sustainable Mobility Unit at UNEP, what we're trying to do is really to break the link between this increased mobility, but not also having an increase in emissions. And that's really what we're doing to support the governments that we work with. Next slide, please. One of our critical programs is Share the Road, really focusing in on prioritizing the needs of pedestrians and cyclists, because of course we need zero emission vehicles. They are part of the solution, but to meet all of our climate goals and all of our health goals, and to achieve the SDGs, as well as decarbonizing private and commercial vehicles, we also need to retain and increase the share of trips by public transport, by cycling and walking. And I think active mobility is a really clear example of how transport impacts health and the environment, and that's where Share the Road comes in. Next slide, please. One of our priorities geographically is the Africa region. So non-motorized is the transport of the majority in Africa, on average 78% modal share for walking and cycling, but also 33% of road fatalities in Africa are pedestrian. So it's one of our real kind of focus areas. Next slide, please. This is an example on this slide of modal share for 3 cities in Kenya, and it's mirrored across the continent. In fact, in some cities, modal share can be as high as 90%. So whilst the majority of citizens are using walking and cycling to get around in Africa, investment does not match demand. Next slide, please. And actually, walking and cycling is also really uncomfortable and not very nice. So we talk about the modal share in Africa as captive mode. It's nothing to be proud of when 70 to 90% are walking as their main mode of transport. It's actually because it's their only choice, because it's what they're able to afford. And you can just see from these IRAP stats really that it's not a nice experience, often no footpaths, no crossing or unsafe crossings, poorly signed and maintained. And it makes it not only difficult and uncomfortable, but also unsafe. Next slide, please. There's also a really strong dependency and relationship between walking and cycling and public transport. They go hand in hand. So lack of walking and cycling infrastructure means also lack of access to public transport, and lack of public transport means cities cannot optimize walking and cycling. Next slide, please. So we're really working with governments and other partners all over Africa to try and change this reality. In Kenya, we've supported development of the Nairobi City County walking and cycling policy, where they have ring-fenced 20% of their transport budget at city level to invest in pedestrian and cyclist infrastructure. Next slide, please. In Rwanda, we have supported development of the national transport policy, really beefing up the chapter on urban transport and making sure that increasing investment for walking and cycling is centre. And we're seeing lots of really good advocacy and car-free days and lots of investment in Rwanda. And next slide, in Ethiopia, we've also developed the national walking and cycling policy in partnership with them and with UN Habitat. And again, we're seeing change on the ground now. Next slide. So quite often something that I hear is, oh, policy, that's the easy bit. The policy is nothing without implementation, which is of course very true. But we do, where we're working with governments who are really not thinking about the needs of pedestrians and cyclists, just coming up with the policy can take a few years of focused engagement to get to the point where there is a commitment and we can sign off a policy. Next slide, please. And actually, policy does really matter. And we tend to see sort of three types of city, very car dominated, lots of road infrastructure, highways, lots of parking on street. Then we see cities moving towards more sort of thinking about mobility and walking and cycling. And what we're really aiming for is city of places. But cities come up with policies, and those policies then impact the investment and the financing and eventually what the cities look like. Next slide, please. So what we've really noticed in working with cities is and national government is there are a few things that matter. One of them is having the right leadership. So leaders who are happy and willing to try and do things differently than had been done in the past. And also leaders that realize that that policies and budgets is about more than the holding place of the budget, for example. It's also about where the budgets lie and the impacts those budgets have. So yes, the budget might be with the Ministry of Transport, but if everyone is dying on the streets, then it's impacting Ministry of Health as well. So they need to be in the loop and bringing in those different types of leadership. Also on policies, they tend to have to sit somewhere, but we're finding where the real success is where the policies might sit somewhere, so with the Ministry of Housing and Planning, but actually there are cross-cutting sort of working groups or steering committees that bring in ministries and city leaders looking at tourism and education and transport and health. So really allowing that kind of cross-population of prioritization to happen. We're seeing a lot of work, for example, in Nigeria that's being led by parks and recreational spaces rather than by the transport team. So there's a real link, but across those areas, making sure that citizens are part of the process and consulted throughout, and also how important collaboration is. I think, my last point is really that COVID has really shown us the link between transport and health and climate. We saw so much collaboration between those different governance links. And I think it would be fantastic if we could build on that momentum as we go forward after the global pandemic. Thank you.
Thank you very much, Carly. That was really great. We're here in the World Health Organization Pavilion, so it's very important we have this kind of global perspective, and you've really highlighted how important it is to look at the reality on the ground where you are to work out. And also, I liked very much how you're kind of talk about how you can affect change. So from Latin America to Africa, we're going to now kind of switch completely. I'd like to introduce Valerie Davidson from the Strathclyde Partnership for Transport. So this is the area really here where we are in Glasgow, so a real local person. Valerie, you have the floor.
Thank you very much. And could I just extend a welcome to Glasgow as somebody who has lived and worked in Glasgow for a long time. The presentations to date have looked at international and looked abroad, so I want to just give you a flavour of a bit of what is here locally in Glasgow. So maybe just, if I could have my slide, please, that would be helpful. To introduce myself, I'm Valerie Davidson. I'm actually the acting chief executive of SPT just now, and I have been working within public transport field for over 20 years now. In that time, I'm actually very pleased to say that I have seen a real growth in the recognition of the hugely vital role that transport plays in not just getting people from A to B, but also in the role that it plays as an enabler for everyone to access people, places, and the pursuits that are really important to us all. Next slide, please. If I could just maybe give you a bit of an overview of our area. Our region, Strathclyde, covers a large part of Scotland. It has more than 50 towns. We cover rural, and we cover urban, and we cover everything in between, including islands. We're actually home to more than half of Scotland's population. So it is a huge area that we cover. And Glasgow, where you are just now, is the economic centre for Scotland, effectively. And we are a major cultural and educational and retail city. It feeds many, many other parts. But we do have key issues in our region, and we do have significant health problems. And many of them relate and are linked to transport. And that does actually include, we've got high levels of car use for our area, which does lead to lower physical activity. And there are no doubts about that, with lower levels of walking and cycling. We have, and it is well documented, poor air quality in some parts of our area. And actually that is also shown to contribute to approximately 300 premature deaths per annum. The impact of air quality and pollution and the impact of transport on communities also limits cohesion within some of those communities, and that's really important. And actually, the way transport has been developed in the past often links with serving as a disconnect to communities. It can actually run through communities and make it much more difficult for communities to keep connected. So SPT, my organisation, has got a really important role, and we recognise that role in improving the health outcomes of our citizens. We're working very hard just now to align our own strategies with some very ambitious national strategies and targets, which is actually including reducing road vehicle kilometres by 20% by 2030. That is a significant target to achieve and will be very difficult, but we're aligning all of our own strategies and our own plans and deliveries to aim to achieve that. That will also clearly assist with reducing the net zero target as well. The environmental health benefits of achieving such targets have a huge impact on both communities and people. But I want to focus just now on the improved built environment as well, because that actually does affect how people's health is, and transport is part of that. There is no doubt that more pleasant places to live, work, play, more space for people to walk, wheel, cycle, and more road space for quality bus services and light rail are really important. And that all adds to the health agenda. If you're improving the physical infrastructure of where people are living and working, that will improve their health. But let's be clear here, for that to happen, we need decision makers at all levels and who have a greater recognition of that accessible and affordable quality public transport can and will help reduce those inequalities. That will in itself improve people's health, and to do that we need some serious investment and commitment. Next slide, please. I would like to just share with you some work that we've already done in this space. So SPT has already started to make a difference, but we know we need to do more. A good recent example that I'd like to share was the development of the National Healthcare Facility, which is not that far from where you are actually here at the moment. The Queen Elizabeth University Hospital. It is one of the largest healthcare facilities in Europe, with over 10,000 daily visitors a day. It's a huge complex and actually was built in an area where it's also classed to be socially and economically disadvantaged. It has had at that time limited public transport infrastructure around it. And when we took all those things together, we knew we had to take a different approach to it. It needed a public transport intervention that would allow access for staff, visitors, patients who can get there, while reducing the use of car. It has deliberately been built with limited car space and car parking. So we worked with many partners here, and we worked with Glasgow City Council and the Scottish Government and the Health Board of that area. We delivered what's called FastLink, and you may actually have seen FastLink outside, which is a bus transit route from the city right to the hospital. This required significant partnership working with all the stakeholders across local, regional and national agencies. And we worked with the private bus operators as well to deliver this service. As part of that project, we also delivered an integrated transport facility on the route called Govan Interchange. And that interchange, that hub, is where bus, subway, bike, taxi and fast-linked services meet all in one place. And that allows an interchange and access to the hospital for a wide part of citizens from all across the area and the region. In delivering the interchange, we improve the local public realm as part of that, and a quality of place, and as well as adding improved physical space, as well as improving the journey experience on better quality vehicles and reducing the journey time. In doing this, we needed everyone to genuinely work collaboratively. And yes, it was really difficult, and difficult discussions about detail and about funding had to take place because there are many agencies involved. In future, we need to drive more of that same approach, and we need to make those difficult decisions about the quality of what we're delivering and the road space and the affordability. And that is where some really tough conversations will need to take place. Over the next 10 years, transformation and investment in high quality public transport is essential to reducing the carbon emissions from transport and improving the health of our communities. There is no doubt about that. We're working with our national and our local partners to set out bold and transformational plans for the region, and investment in electric vehicles, reallocation of road space for bus, light rail, cycling, improved integration with better ticketing, and facilities for passengers in using that will all help that health agenda. So yes, progress has been made, but we've still got a long way to go. And that's a challenge that SPT relishes, and we're looking forward to delivering that transformation as our region requires, and helping the people and the communities of our area and the health of our citizens.
Thank you very much, Valerie. That's great. Great strong theme in your work about this shift part of transport policy, getting people onto public transport, taxis, walking and cycling. That's great. Also a good reminder that the health sector itself is a major part of the economy. So how those services are provided and organised is actually an important part of shaping transport demand. That shouldn't be forgotten as well. So great. Thank you very much for that. So real pleasure for me now to turn to my Tran from another SLOCAT member, Icle, from the World Secretariat in Bonn, who's going to share with us about her work with cities around the world.
Thank you, Mark, for the invitation, and thank you for all your time, for taking the time to listen to us, and thank you for the presentation. I have the very hard task to give you a bird's-eye view on what our global organization is supporting and how they are supporting with the cities in transitioning towards integrated, equitable and climate-neutral friendly mobility systems. In the next slide, my name is Tumi. I'm the head of sustainable mobility at Icle, Local Governments for Sustainability, and we are a global network of 2,500 cities and regions that are committed to sustainable mobility. And why cities and regions are important. In the next slide, you can see that the world is rapidly urbanizing. And when there is a growth in population, there is a growth in demand of mobility. And it seems to be, and of course, the space in cities is very reduced. And so if we don't want to be stuck in traffic, then this is very important. And the trend is growing, and especially in Africa and Asia. In the next slide, we can see that, of course, that could be a potential future for us. Some numbers, 27% of the energy consumption is related to transport. Out of this, 40% is related to urban transport. And then there is a staggering number here on US, 1 trillion of US dollars are related to unintended consequences on health and transportation. And of course, these are some of the major drivers for cities: air pollution, noise pollution, GHG emission reduction. And then the end goal is not only reducing road safety, but also increase in the urban quality of life. And we need also to highlight the importance of making sure that our environment is very nice to live in. In the next slide, you will see that of course, in the transportation and health, the key role is with air pollution. And here there is a quote from the WHO on the number of mortality, and it's one of the top agendas for citizens. So the culture on transportation today seems to be a bit, although there is advancements, it's not enough, it seems. What we are doing at ICLE. At ICLE, we have two main initiatives. They are aligned with the Avoid, Shift and Improve and Integrate framework that Mark has shared before. And we have two main initiatives. One is eco-mobility that gives priority to the most sustainable mode of transport, and ecologistics is related to urban freight and logistics. Next slide. In the eco-mobility part of the work, essentially, we not only look at integrated transport planning and policies, but also and harnessing technology, but also at looking at how we can change habits. How do you change the patterns? Because if you click next, then you can see that this is an old classic, of course, but sometimes the conversation is stuck with electrification or autonomous vehicles, and then there is no real change in addressing the underlying issues of cities, and especially on the problem of space that was highlighted by the speakers before me. So how do you connect ambitions to action? In the next slide, you can see that one of our iconic or flagship events has been like the World Festival, in which 3 car-oriented cities have tried to pilot a neighborhood for 1 month that is car-free. And sometimes this has created, this simple idea has created a transformational change, especially in Suwon, where we could also evaluate the impact after 5 years. The neighborhood was not car-free, unfortunately, but it has improved a lot with all the alternative options that were deployed during the festival. And in the next slide, you can see also a tool. One of the first steps that we advise to cities is to start to assess your mobility, and then essentially towards acting. And one example from Scotland is Dundee City, and they did it back in 2013, and this assessment has helped them improve or inform their policy on air quality and road safety, for instance. In the next slide, you can see the underdog of transportation to a certain extent is about freight, and some of the numbers are quite staggering here. 50% of emissions from the ITF report in 2020 was transportation-related GHG emissions were equal. Freight transport was equal to transportation of our passengers. This was for the first time. Of course, it was a special year because it was COVID-related and because, of course, there was a lockdown, but it's still showing the growing trend in urban freight. And why urban freight is so important is because it's the sector in freight that has the most potential to be reduced, because essentially 20% of freight-related GHG emission are attributed to urban freight, and it represents only 3%, for instance, and it's equal to the maritime shipping, which is representing instead 70%. So what ICLE is doing to address this is that, as mentioned before, many cities are not tackling urban freight, so there is such a great untapped potential here. And we have created a community of practice, which is chaired by the Italian city and with first mover cities, and essentially where they can learn from, for instance, other cities that have already done the journey. For instance, London that is known for smog, and essentially they created the first urban low emission zone. Next slide. And this is a journey. This is a journey, and it's not just a sprint for us. And so, for cities that don't know where to start, then we have created a set of principles for them to just see where their actions are fitting in the different principles that we have, and some of them, for instance, Portland has used it as a scavenger hunt to a certain extent to see which of their policies have been are within the different principles, and then we have the Italian city, which is the chair, that has also used these principles to inform their upcoming sustainable urban logistics plans. And so I can only conclude by saying that, cities are where the battles will be for climate change, health, and also transportation. Thank you very much.
Okay, thank you very much. That's just so great that you're working with thousands of cities across the world on these topics. That's really great. And I particularly like the way that you're condensing things to like to simple, pragmatic tools or messages or guides. That's really, really great. Oh, so in this kind of tour of the different parts of the world, Latin America, Africa, Strathclyde, now we come to Asia, and it's my pleasure to introduce Bjarni Pedersen. I'm from Clean Air Asia. Bjarni, you have the floor.
Thank you, Mark. And hello, everybody. It's nice to see actually so many here. It's a pleasure for me to be here and talk a little bit about transport systems in Asia and some of the work that Clean Air Asia is doing. And next slide, please. For those of you who do not know Clean Air Asia, we are a organization, an NGO based in Asia, headquartered out of Manila in the Philippines, with offices in China as well as India and country networks across Asia. We do what it says on the tin, as in aim to clean the air and reduce greenhouse gas emissions. We do so by informing for action, build capacity, and do policy guidance, as in try and help city and national level governments implement policies. Another way of looking at Clean Air Asia, we exist where the rubber hit the road. We try and help cities and government implement real solutions that deliver a real impact. We work on a number of issues, including stationary resources, but also transport, and I'll stick only to transport in my presentation here. I want to give you some highlights of some successes that's happening in Asia at the moment. I see quite also pre or post-pandemic, some quite progressive interest in the transport agenda across Asia. Some of the work that we've been doing and has been, in my view, quite successful is working in Cambodia with formation of official working groups driving the e-mobility standards forward. And the previous speaker talked very much about the need for coherent governance. In my second example, in Pasig City in Manila, we are working with city officials and Philpost and have created a overall governance committee for the city in promoting e-mobility in the area of freight. So that is Philpost together with UPS Foundation. I also want to highlight Indonesia, where we have developed an eco-driving program. Eco-driving is something that comes and goes, and we really focused on institutionalizing the eco-driving program within the public utility sector, so that a driver, to be able to drive a public utility vehicle, must have taken eco-driving training. Sounds fairly simple and not a great sort of earth-shaking thing, but actually it does save around 10 to 15% greenhouse gas emissions from that precise sector. Back to the talk about transport systems. E-mobility is all the rave at the moment, and rightly so. And it is, for me, also one of the areas where we at Clean Air Asia see a real, how should I say, sweet spot between greenhouse gas emissions, public health benefits, environmental justice, and clean air. And in order of what drives governments in Asia, and especially cities, towards e-mobility, we see very much the public health agenda, clean air, climate goals, energy security, access, and justice as the main drivers. We ourselves is actually going to deliver a roadmap for the Philippines for e-mobility by early next year. Again, a sign of a country actually taking quite seriously the e-mobility agenda. There's also some concerns about the e-mobility agenda, especially in Southeast Asia. Many talk about Southeast Asia at the third and final frontier for coal in Asia, and we do see post-pandemic coal expansion in countries across Southeast Asia. And there's a real concern about just displacing pollution by introducing e-mobility without at the same time cleaning up or making sure that there is a clean energy transformation. And right now there is actually a increased interest in coals in quite a lot of countries in Southeast Asia. In the short term, the table on the right shows the need to, as a first step in moving towards mobility, e-mobility, is introducing tighter standards for coal-fired power plants to ensure that at least in the near term we have lower emissions from the energy used to power vehicles. Now my final slide, all the way back to what Mark talked about in the beginning, avoid, shift, improve, and the work that we do with cities. I should say in the beginning we work both with governments but also especially with cities. I want to give you a slight different take on how we work with cities, especially smaller cities in Asia, especially Southeast Asia, in a holistic approach, working on the avoid, shift, improve. For us, the key steps is really improving the data to inform the policy and the planning, making sure that we understand what the emission sources are so we can reduce and control the emissions. Secondly, capacity building. It's about building expertise, facilitate the skills, and develop peer learning between cities in Asia. And the two last points especially speaks to the environmental justice and equity agenda, making sure that we strengthen and formalize stakeholder engagement in developing and implementing solutions on city level, because otherwise you are simply not going to get the uptake to the solutions once implemented. And then also finally, and often forgotten, make sure we proactively disseminate and reach out to the public to raise awareness of the chosen solutions as well as their implementation. Thank you very much.
Thank you very much for your contribution. So you've all been listening very patiently online and here in the pavilion. So we want to have a moment here where people can make any comments or questions. We're looking at also for contributions online. Yeah, please. I think I'm going to have to put my mask on. Let me pass you the microphone. Please, can you give your name and your organisation?
Thanks very much. My name is Colin O'Hare. I'm from the Ministry of Health in Ireland. And I suppose one thing that I'm particularly interested in the views of the panel would be a lot of the challenges about changing people's mobility patterns involve changing behaviour. And I suppose with COVID and the onset of e-working and that, there's kind of an opportunity here at the time we're at now where the link with I'm used to driving 5 days a week, I'm used to that type of commute, length of time, etc., is kind of broken. And maybe there's a dual challenge of one, the transport system is maybe more equipped to carry the numbers of people you're dealing with now that are coming in and out every day, or two, the disadvantage that people might feel it's easier to drive than it was with full capacity. And I'm just wondering if there's any thoughts about how to take advantage of any opportunities that this presents, or if anybody's had a go at that yet. Thanks.
Thank you. I don't know whether Carly or Olga or anyone on the panel wants to try and answer this question. Valerie?
Thanks very much. Clearly the pandemic has completely changed the travel patterns, and not just how people are traveling, but when they're traveling. So the whole routine of the morning peak and the evening peak has completely disappeared. However, even through our own subway we monitor daily, we are starting to see a peak reappear. So people have adjusted, but maybe there's a period of time when things will kind of swing one way and they'll swing back a wee bit in a bit of a pendulum. I think you're right, people's behaviours have changed as well. And I think what we need to do as partners in all of this is make it easy for people to use public transport. You have the morning peak and you have the evening peak, and in between you've got a lot of fresh air that you're moving about, and we need to make it easier for everyone to actually use that fresh air, basically, because the road systems will be jammed. People have naturally gone back to their cars. And therefore, I think all partners at all levels need to engage with that behavioural change mechanism. And I know we all talk about it, but we need to make it easy for people to do it. And I think that's something that all partners are currently having those discussions about. including how do you campaign to demonstrate the safety of public transport, the health benefits of public transport, and that's something that we're all engaged in at the moment. But it's a really valid point.
Thank you. I think Carly would also like to contribute. Carly.
Yeah, thanks. Completely. I mean, as horrendous as COVID and the pandemic has been, it's also given us a disruption. And I feel like any disruption gives an opportunity, but that opportunity is only as good as the kind of decisions and the investment that come with that opportunity. And like you said, we have to make things easy for people. And if we've had this disruption and everyone's been home and now people are going back to the office, if their transport options are as they were before, people will still jump to private car if that's what they were doing before, if there's not another better, easier option. So it's a great opportunity, but it's only an opportunity for decision makers to kind of take that moment and step in and increase infrastructure for bikes, put showers and lockers in the workplace, provide those opportunities to make people make better choices. Thank you.
Comment or a question here in the room. Please, can you introduce yourself?
Hi everyone, I'm Omneel Amrani. I'm from Cairo, Egypt, a young medical doctor and also with the Global Youth Coalition for Road Safety. So my question for you, thank you for demonstrating your efforts. I'm curious to learn how have you engaged youth in the efforts that you have led, either on a policy level or on the implementation level. And at the same time, I also would like to highlight the importance of sustainable mobility, but also I'm curious to learn whether you have thought about safety when it comes to ensuring or the opportunity to transform the transport system and to increase its safety as well. Thank you.
Thank you very much, and great to have you with us and helping us link into that young medical community. That's really, really important. And I think, my sense in the work we've done this last year is that there is a bit of a split. Like the people working on safety in transport, particularly road safety, is like one particularly big community. And then another community is kind of thinking more about the respiratory disease and those kind of active health things. And bringing those two perspectives is really crucial. So does anyone want to try and respond or comment on this involvement of the youth? Yeah.
Thank you. I think the involvement of youth is critical. Our youth work across Asia is linked. We try and link it in a way that we actively engage the youth as part of the implementation of the solutions of transport. To give you a very practical example, in cities in India, we work with city-led youth groups to do perception surveys on city level prior to working with the local governments in actually generating solutions. And the youth groups are part of the whole journey from conceptualization of ideas to improve transport to understanding and going out in community and understanding what the transport needs are to be part of the governance structure. That is, of course, not the whole youth groups. We then work with the youth ambassadors within the youth groups to do so. And we have found is incredible, powerful. Our work in China with youth is slightly different. There we engage youth online, making sure that whenever we put forward policy suggestions or guidance on capacity building, that we create online forums where we can engage youth or young net citizens, as they call them in China, has proven incredibly successful. And we will be trying to do that even more and more. We're planning to start a Pan-Asian youth network for clean air in the beginning of next year to ensure that we really take that agenda forward and listen to the voices of the ones who would be most affected if we do not cut greenhouse gas emissions and clean the air very quickly.
Thank you. I'd like to give the floor to Olga now, please. Olga.
Thank you, Mark. Another example for youth is related, and I'm going to give you just an example in Latin America, is with active school transport. We have seen, I mean, before pandemic that we have the schools are open, the importance of walking and biking to school for children and their voices for promoting biking, especially in these areas that are not safe. Now that schools are going to open again, we're also promoting biking. And I think also related with the first question on behavior change, this also has to be very cultural specific, context specific. So we have to take into account their voices, but we also have to take into account the voices of the boys and the girls, which are sometimes very different. So I think the other thing I wanted to underscore is that we need to understand the preferences by gender, by different groups. And one example for children that you were asking, active school transport is one component that will be very, very relevant if we want to work in the future promoting more physical activity and more active transport.
Thank you. Tume?
So from cities, usually the policymakers are a bit older, so youth is not always like the target group. But that said, with the stakeholders engagement and participatory approaches, there is a lot of youth movement, and also with the Friday for Future, then that has really sparked the importance of including also youth. And in particular, when we worked with the host city of Montreal, they had a really great participatory governance in which they had a youth council, for instance, to just train the next generation of policymakers. And then for all our festivals, the most enthusiastic were the children, of course, because they are so open to the new changes and more livable neighborhoods. So that I think it's important to take into consideration of the different type of stakeholders, and not only youth and children, but also as it was mentioned, also the disabled, and make sure that all the vulnerable groups are included so that we take into consideration their input.
Thank you. I think now we have a comment or question online. Oh, it's Carly. Sorry, misunderstood. Carly.
Are you asking for the question that I had for ICLE and Clean Air Asia?
Sorry, I didn't hear you.
I had a question for ICLE and Clean Air
Yeah,
Asia.
go ahead. Yeah, go ahead.
Great, thanks. I wondered how you support or advise cities with prioritizing limited funding and with so many competing demands on their city budgets. Thank you.
I'll do it the other way around. Maybe go to my first and then go back to Bjarne.
Yeah, that's a very interesting question. It really depends on the location, in the sense that like the first question is really how the budgets are structured and which department is the most relevant, because sometimes it's a transport sector, but sometimes actually oftentimes it's the environmental sector, or department, or sometimes it's also the cultural one, because having the tourist department is the one that advocates for active mobility, for instance, and pedestrianization of the city center. So it's really, I think the starting point for us is to identify the a good vision and mayor or leader that is able to drive this, and having the staff members to be able to follow through. And in the same time, it's also to identify which departments need to be integrated in the governance structure for the interdepartmental collaboration, so that they can pull together the different resources. And at the same time, it's the alignment with the other level of government to identify what is the governance structure from the implementation perspective, but also from a funding perspective.
Bjarne?
Two levels. As part of when we start working with city, as part of creating the baseline, we do an emission inventory and a cost analysis of the worst public health outcomes from transport. In other words, simply putting the figures on the table and say this is actually the cost of inaction on transport vis-a-vis the cost of implementation of solutions. That's number one. And number two, we then also work as part of our capacity building with building in financing of implementation of solutions right from the start. Financing is often where the stumbling block are in real implementation, and it's critical for us to help with that.
Okay, thanks. We're coming to the end of our time now. One last, hopefully short question or comment, really, so please be brief.
Thank you. Yeah, I'll try to be short. I'm Kurt. I'm a young feeling physician and public health scientist. And my question is, are there any experiences from seasonal differences? I mean, I can assume that in some places, perhaps like Glasgow, but also from a global perspective, there may be major differences between pleasant weather and not so pleasant weather. Any ways to overcome that in winter? Biking is active mobility.
You've obviously been in Glasgow this week, and if you arrived at the weekend, last weekend, you will know that it rains very heavily in Glasgow on some days. And yes, there is absolutely a seasonal element to it. When the weather is fine, people are happy to cycle, they're happy to wheel, they're happy to walk. I think what we need to do is make the alternative to that for poor weather. Cannot always be jumping in the car, and I think that's part of the issue. It's not a one solution. You're not a walker or a wheeler or a cyclist. We need to get the message about the adapting to the environment that we're in and accommodating. So take me personally, I walk to work for part of my journey, even in the rain. Okay, there's no such thing as poor weather. It's poor clothing. It's being not prepared for the rain. It's not having an umbrella. The messaging that we send out has to accommodate those issues. It's not cycling or the car. It's cycling or the bus or the train or the metro. It's what's relevant to that day. And those are the kind of messages. It's not a one-size-fits-all everyday approach. And I hope it didn't rain too much on you.
Thank you very much. So we've come to the end of the time now, so I'm sorry for that, but lots of very interesting topics and threads in this conversation. We could have spoken a lot more, and certainly we'll be looking forward to the Health and Climate Network to be picking up some of these topics in the months ahead. So thank you to all the people here. Also, particularly thank you to Carly and Olga for joining us online and making that effort, and also the technical team. It's not a super easy thing to make all this work. Thank you very much for your attention.
Welcome everyone to our panel on climate, health, and migration. First, let me just take a check to make sure that all of you can hear me. You'll need to put your headsets on. You can hear me? Great. Okay, you will need to wear the headsets because many of our speakers will be speaking from screen and you'll only be able to hear it through there. And I will ask the people who are here in person, if you'd like to ask a question after the panelists begin speaking, please put your hand up and Olga, my colleague, will bring the microphone to you and you can ask the questions so that it can be heard by the panelists on screen. So with the logistics out of the way, my name is Eric Redding. I'm the Division Vice President for International Development of Apt Associates. We're a consultancy that's working around the world on issues in health, climate, and other areas. I'm joined today by a really terrific panel that's been focused in on the issue of health, migration, and climate, and they'll be joining us online. But as I think all of you know, climate-related events are really driving vulnerability around the world. And in particular, in the area that we're going to focus in on of Latin America and the Caribbean, there have been a large number of climate-related events, whether those are storms or droughts, that are driving very significant amounts of migration in the region. For example, the hurricanes Eta and Iota last year displaced more than 1.7 million people in the Caribbean from their homes. That was quite a significant event that drove people to migrate. There have also been droughts in Venezuela and Central America recently that have fueled the driving of migration. And a robust humanitarian response has occurred to many of these events that has helped to mitigate it. But that humanitarian response can only go so far in an emergency situation. And as these migrations are getting larger and longer, it becomes very important to think about the long term and think about how migrants are being integrated into health systems that are already stressed and strained from operational and technical difficulties. So what we'll look at today is approaches that have been taken to this issue of migration and how that can be integrated into health systems. As I said, we have a terrific panel, and let me introduce them first, and then I will hand off to them to each introduce themselves and say a few words. Dr. Joy St. John is the Executive Director of the Caribbean Public Health Agency, or CARPHA. CARPHA is based in Trinidad and Tobago and serving 26 member states, mostly the small island nations of the Caribbean. The agency is the Caribbean's collective response to strengthening people-centered and evidence-based health systems and approaches, and addresses the nature of the changing public health challenges. Dr. Alexander, and you won't be able to see the faces of the people until they begin speaking. Dr. Alexander Arnikov is the International Organization for Migration's Regional Migration Health Specialist for the Americas. He's based in San Jose, Costa Rica. IOM provides effective, coordinated operational responses and policy advice to complex and shifting dynamics of migration in Central America, North America, Caribbean through three lenses: resilience, mobility, and governance. And then two of my colleagues from Apt Associates, Dr. Miguel Padillo, is the head of our program in Colombia for the Local Health System Strengthening Program. This project is supporting the strengthening of Colombian health system to absorb Venezuelan migrants and Colombian returnees, and to increase the resiliency and respond to the current and future shocks, including the COVID-19 pandemic. And Dr. Paulina Maria Gusti is the head of the LHHS program in Peru. This program is helping the government to address the additional HIV-related health system demands from the influx of Venezuelan migrants and to strengthen the government of Peru's COVID-19 response. So each of the panelists will present for a few minutes, and then after that we will take some questions from the audience, and I'll have some questions of the panel to discuss with one another. So I turn it over first to Dr. Joy St. John.
And it's a pleasure to be here. Just a quick word about CARPHA. It's an amalgamation of 5 regional health institutions, and it's all things public health. And as we have an intergovernmental agreement with a specific mandate for serving the CARICOM countries, and our member states are actually wider than CARICOM, we have been very proactive about a lot of the things that you're discussing today. Next slide, please. And This gives you a little snapshot into the public health imperative. We are about assisting CARFA member states in developing migrant health policy, in the delivery of universal health care. And initially, the focus was on Venezuela, but we've discovered, and especially through COVID, that many other countries, and not all related to the region of the Americas, have been coming into the CARICOM space. And also to implement epidemiological profiling so that there can be good planning. So we have had a systems approach because if you are serving 26 member states, you have to do it in a systemic manner. And we are also a region which is heavily burdened by NCDs. And a lot of our migrants also have NCDs. So the issue of acute care, chronic care for communicable and non-communicable diseases is part of what we're trying to support member states in planning. Next slide, please. But we could not be doing this without the major donors for climate and health. And we've got the EU CARIFORUM project. We've also been collaborating very closely with PAHO on that, as well as the Caribbean Institute for Meteorology, Hydrology, the 5Cs, and the University of the West Indies. So the CARICOM institutions and CARICOM cited institutions are working with international and being supported by EU also for a climate project specific to climate and not just climate and health, which is managed by the 5Cs. And we have support as well for IDB. And there is also a specific project on vector control because climate change is not just about hurricanes and droughts, it's about effects on existing disease. And we've noticed that the life cycle of the mosquito has increased. Next slide, please. And one of the greatest collaborations, which is allowing systemic health sector strengthening, is the Health Climatic Bulletin. So what we do, we get together with the Caribbean Institute for Meteorology and Hydrology. They forecast the weather for a quarter, and then CARFA and PAHO supply what could be the effects of that climate and the variations in weather on disease. So we've been able to continue this even though we're in COVID. And it's a very critical tool for systemic work and also an excellent example of multi-sectoral, multi-agency collaboration. Over.
Thank you very much, Dr. St. John. Next, we are going to hear from Dr. Alexander Arnikov from the International Organization of Migration.
Good morning from Costa Rica, and thank you for having me. It is an absolute pleasure to be part of this panel. Today, I am going to be speaking about the link between climate change and migration and health. And I'm also looking forward to our discussion on how we can move from a reactive to a health system strengthening response. Next, please. To begin, allow me to share a few important pieces of information about the scale of movements in the Americas. So a total of 55 million people in the Americas were on the move in 2020. And this number includes those migrating to the north, mainly to the United States, then those in the inter-regional migration flows, transit flows, and return migration flows. Also, irregular migration across the Americas, as shown in this example slide from South America, has significantly increased in the recent months. Again, mainly towards the United States and Mexico as a stop before the United States. As you can see, different nationality groups may use different routes, but they do have a few things in common. And one is that they all use the irregular border crossings that expose migrants to increased health vulnerabilities and extreme risks, including violence and gender-based violence, exploitation and abuse, extortion, and death. Next. While in transit, migrants, especially those in an irregular situation, but also families with children, women, girls, and boys, find themselves in situation of extreme vulnerability. So this is exacerbated by limited access to basic services such as healthcare services, shelter, food, water, hygiene products, psychosocial support. Language can be also a major barrier for some of the migrants to obtain information on migration regulations, aggravating the risk of exploitation and abuse, while also limiting communication with authorities. So the flow of migrants, large flow of migrants, have also stretched the capacity of many host and transit communities, some of which have become hotspots for rising incidents of xenophobia and violence between migrants and host community members and between migrants themselves. Therefore, IOM is mainly focusing its response with regards to migration and health to access to high quality health services for migrants, promote evidence-based migration health policies and migrant-friendly and migrant-inclusive health systems, following the principles of the Global Compact of Migration, Agenda 2030, universal health coverage, and many, many other instruments that support safe, orderly, and regular migration. Next. The maps you see are very compelling and have a lot of details that I'm not going to discuss now, but they do show the key climatic risks and impacts, like increased or decreased precipitation. They show the main consequences, like reduced water availability and related social challenges like vulnerable indigenous populations or megacities. But they also identified climate change hotspots, that is the areas that experience a combination of several extreme climatic risks. So what is the link between these maps and the health of migrants? So climate change indeed affects human health, and there is no doubt in that, directly and indirectly. Directly, it increases morbidity and mortality, including heat-related and disaster-related injuries. And indirectly, it affects health through changes to social and ecological systems, food security, availability of fresh water, changing distribution of disease vectors, and different pathogens. As we diminish biodiversity by cutting down forests and building more infrastructure, the risk of diverse pandemics, such as COVID-19, is increased. We are witnessing the struggle of the health systems, even in the most developed countries in the world, to respond to the needs of the population to COVID-19. But even before the pandemic, migrants had a greater vulnerability to diseases due to often inadequate living and working conditions and limited access to health services. Evidence shows that the pandemic has exacerbated many of the existing health vulnerabilities faced by migrants. And it is often the poorest, those who find themselves in irregular situations, those who are displaced by natural disaster or conflict, or those who do not have equitable access to health, including immunization services. Next. So the COVID-19 pandemic has only emphasized the need for a coordinated response. And these 55 million people that I mentioned earlier were on the move alone or in large groups for multiple reasons, fleeing poverty, violence, discrimination, and increasingly leaving behind disasters caused by extreme weather events that have devastated their communities. For this reason, climate change and health nexus need to be urgently prioritized, as many migrants experience increased health vulnerability. In this context, IOM is intensifying its efforts to develop joint action across its climate migration and migrant health work streams, with the institutional strategy that you can see at the slide being only one example of a comprehensive and evidence-based approach to this great challenge. In summary, and I'm finishing now, we need to indeed roll up our sleeves and find solutions for people to move, people on the move, and people to stay with regards to climate change. Also, we, the public health and migration officials, must use the experience of COVID-19, Ebola, SARS, and MERS outbreaks. We learned that values such as equity, solidarity, and collaboration are central to resilience and essential to drive effective response. Therefore, we must build on this experience to restructure our health systems, set priorities, shuffle available funds, support the health workforce, restructure the disease surveillance system, communicate properly, this is very important, and above all, work together. Thank you.
Thank you very much, Alex. Next, I'd like to introduce my colleague from APT Associates, Dr. Miguel Padillo, who's speaking to us from Bogota.
Thank you, Eric. So glad to be part of this event. Colombia is a country well known for immigration of its people. Now, however, is being known more as a receptor country of migrants, mainly from Venezuela. Next, please. Colombia and Venezuela, countries that share a 2,219 kilometers of border. This situation is having serious effects on many social and economic aspects. One of these is the healthcare sector. Let me start with sharing some data with you. Approximately more than 1.8 million Venezuelan migrants living in Colombia right now, but almost 3 million Venezuelan migrants are expected to be residing in Colombia in the next few years. We have different types of migrants, status. It is important to say the status, not the people. We have regular status with a special resident permit. We have irregular undocumented migrants and pendular migrants, migrants that are going back and forth between this border. Something that is very important to say with you right now is that the government of Colombia made an historic decision early this year to regularize Venezuelan migrants, called Temporary Status of Venezuelan Migrant Protection. Under this scheme, Venezuelan migrants can get access to education, health, official employment, and other benefits. Next, please. We, as a project, we are not a humanitarian project. Our project is a technical assistance project here in Colombia. Something important, we start almost 14 months ago in the middle of the pandemic and also in a peak of the migrants in Colombia. All our actions have been taken into consideration the issue of long-term sustainability, because it's important to be reactive in some crises. However, it's better to strengthen systems. Creating and working is one of our philosophies here in our program. We are co-creating with other USAID projects and also with other international cooperation. We have four different aspects that we are working. Public policy tools. We are working in the roadmap for the inclusion in the general social security system here in Colombia. And also, we are working and helping the government in the 10-year public health plan that is going to be implemented between 2022 and 2031. We are working in the sustainability financing enrollment in general social security system. So far, we are helping more than 6,000 migrants, Venezuelan migrants, to be enrolling in the health system in Colombia. And also, we are developing package for healthcare services. Next, please. We are helping more than 170 healthcare workers training in quality improvement. Is not only just to get access to the health sector, is get access but receive quality in all the attentions. Working in the middle of the pandemic, we start to help the Ministry of Health and some secretaries of health in the strengthening the public health surveillance. More than 50,000 people between health professionals and community leaders were training in COVID-19 prevention. We create more than 30 rapid response teams that each team was conformed by an epidemiologist, a doctor, a nurse, and nurse assistant to face and work in the middle of the pandemic. More than 40% the territorial entities have been supporting in the development of a SPAN immunization program. now that we are working in the vaccinations COVID-19. More than 3,005 health professionals training on the national vaccination COVID-19 plan guidelines. Next, please. We have big challenges for the next year. We are working and supporting the government to reduce the financial barriers to care and the treatment. We are also helping the government to the implementation of the roadmap for the inclusion of Venezuelan migrants in the general social security system. We are helping the support and develop a strategy for digital transformation in the healthcare system. We are trying to improve the quality of the health system by increasing the number of healthcare workers training in quality improvement. We are strengthening the health sector in aspects now that we are facing the pandemic, but we are having new issues. Maybe we are not working in intensive care unit, but now we have to start to think about mental health response, and that's something that is important for our project. Next, please. Thank you so much.
Thank you very much, Miguel. Our next speaker is my colleague, Dr. Paulina Maria Yusti, who's speaking to us from Lima, Peru.
Thank you, Eric. Good afternoon to everybody there in Glasgow from here in Peru. Peru, as Colombia, used to be a country who produced migrants to other countries, and now we are receiving migrants in a bigger scale. Our project in Peru is focused on Venezuelan migrants living with HIV. Next, please. Peru has received in the last few years 1.2 million of migrants. After Colombia, we are the second country in Latin America receiving the most amount of migrants from Venezuela. When migrants arrive the country, they come with chronic and non-communicable diseases, mostly with asthma and hypertension. About 10% of migrants came with chronic diseases, but we went look for if they receive treatment for their chronic problems. We find that most of them don't receive treatment. You can see in the graph in the right that almost 80% of migrants who have chronic conditions that do not receive treatment for them, with the complications that could be that could generate. Please, the next, please. The project, as Eric said at the beginning, is helping and providing assistance to the government of Peru to address the additional HIV-related system demands due to the influx of Venezuelan migrants. In the graph on the left, you can see the increase of Venezuelan migrants receiving treatment for HIV in the country between 2018 and 2020. And they increased from 200 at the beginning of 2018 to 3,200 at the end of 2020. We have two main objectives in the project. The first one is to improve the availability of comprehensive and high-quality HIV services for Venezuelan migrants, and the other one is to support planning for cross-border continuity of care for migrants. We have just begun this year, we began in May, and we are working with the Ministry of Health to do a health system assessment that we have just finished. And we are going to share some of these results with you. Next, please. Here we can see the situation of Venezuelan migrants that start treatment with antiretrovirals in Peru. More than half of Venezuelan migrants already have been diagnosed in Venezuela. and a big percentage of them have interrupted their treatment for more than 6 months when they arrive to the country. So probably result of this abandon is that out of 4 migrants living with HIV are already in 8th stage when they reach the health service in Peru. Now, in the right graph, we can see the percentage of co-infection and abandon of treatment in persons living with HIV that are in treatment in Peru. In the blue color, you can see the percentage for all the people who are in treatment in Peru. And in red, you can see the percentage of Venezuelan migrants that are in treatment. We can see that the abandonment of treatment is lower in Venezuelan migrants, but the co-infection with TB that we are finding is 37 times higher in Venezuelan migrants than in people living with HIV in the same territory. And that is something that is shocking and what we have to face with. Next, please. Here are some the few barriers to access treatment identified by the health personnel who works in HIV services. I have to say that in Peru, treatment for HIV is free for everyone, no matter your migration condition or status, as Miguel said. And government pays for treatment and pays for diagnosis tests. However, there are some costs that the people have to afford if they don't have a health insurance. Costs like lab tests previous to begin treatment, and that is a big barrier for Venezuelan migrants who many times that don't have the money and they have to wait to obtain the money. Sometimes they are helped by international organizations or NGOs that work with them, but sometimes they don't have access to that aid and they have to work many days or delay the beginning of treatment. The other barrier, main barrier observed is the access to health insurance. In Peru, the public health insurance is free for nationals and residents. But if you are a foreigner, you are a resident if you have a resident card. But many of Venezuelans does not access yet to that. And then we can find some other aspects linked more to the health services, like inconvenient hours or waiting times and others like that. When we ask people, Venezuelan migrants that are already receiving treatment, besides the economic problem, they talk us about discrimination. They feel that they are discriminated mainly because they are HIV patients, and less is the claim that they are foreigners and they are discriminating because of that. With these results, we are working with the Ministry of Health, developing a strategy to capacity building and developing strategies to overcome these barriers. And there we are in this. I think that migrants share problems with all migrants in all regions. And we are working with the ministry to deal with these things. Thank you very much. Over to you, Eric.
Thank you very much, Polina. Thank you, Polina. So now we have time to take questions from the audience for any of our panelists. If you're interested in asking a question, just put your hand up and my colleague can bring the microphone to you.
Okay.
Over here.
Hi, my name is Megan Kircher. I'm with the Yale Center for Environmental Law and Policy, and I focused on climate migration from a refugee and asylum perspective. So I was wondering what you think, any panelists, what you think the role is of regional immigration agreements in lessening the burden on any individual countries health and infrastructure.
Great. Joy, would you be interested in taking that question first, and maybe Alex after that? Did you guys hear the question?
So that's a great question. Did you want to see it again?
Sure, I can paraphrase it. What are your thoughts on regional agreements and kind of regional integration around health services in a way that would benefit migration? Is that the gist of it?
Right.
Well, regional agreements and regional integration is the reason why I have a job. And it has worked for the CARICOM region in COVID-19 because there was the secretariat infrastructure that also allowed for convening groups and coming to agreements on combined action, changes in policy, changes in legislation. So what is required as we have listened to such interesting presentations is a type of coalescing of agreements of many sectors to really get this to work. So yes, in a nutshell, you're correct. This is what is required. Do we have the appetite for it? Then someone else can answer that.
Thanks, Joy. Alex, did you have anything to add to that?
Yeah, actually, I would say that maybe the free movement agreements are crucial to enable persons displaced by disasters to seek. So this was the case with in the 2017 hurricane season in the Caribbean, when we had this more than 10 or I don't know how many hurricanes, cyclones in the Caribbean. But it's also important that free movement is complemented by contingent rights, enabling migrants to access health services abroad as well. Also, I think that we had this very similar intervention in Costa Rica after the Hurricane Mitch, I think, when they granted visas for people. So, I mean, these regional approaches are exceptionally important, not only for emergency relief, but also for sharing the experiences, sharing the knowledge. And, you know, I mean, especially for the Caribbean, for example, because in at certain point of time, either the whole region or at least one or few islands will be affected. So not only for the coordination purposes, but also to for better distribution of funds available, human resources, financial resources. This is exceptionally important, especially when the time is key to response. So yeah, regional coordination is absolutely important for provision of timely and well organized response.
Thank you very much. Paulina, Miguel, did you have anything to add, or should we move on to another question?
I think we should move.
Okay. Great. We have a question here in the audience.
Hello there, thank you very much. I'm from the Royal College of Psychiatrists. So my question is to those of you organising healthcare provision, how are you able to either assess or meet the needs, the mental health needs of migrants? And I'm particularly interested in children and young people, whether that's looked at or whether you have any capacity to provide for this area.
Great. I think Miguel might be in a good position to answer that one from the Colombia example.
Thank you, Eric, and excellent question. Yes, it's not only start to work with the problems from the migrants. Here we are working also in mental health of the healthcare workers. If they are in a good shape, if they are healthy, if they have the capacity and the ability to support these people, we can integrate all the action. Of course, it's important, you know, the things, the mental health with children, women, all the migrant population. And we are starting now for in this year, working with healthcare workers. And also, you know, in parallel, some actions to provide healthcare services to the migrant population. Not only vaccines, not only the emergency attention. We are strengthening the local providers in mental health.
And Miguel, if I'm correct, the migrants are receiving the same care in all areas that Colombian citizens are provided, correct? So any mental health care that's provided to Colombians would be included for migrants as well?
That's exactly the situation here in Colombia. Yes, Eric.
And anything else to add on the mental health question?
If you don't mind, I am of the view that we have to use the COVID-19 pandemic as an opportunity to reset how we look at migrants, as not as them and us. So I was really impressed that access is at the same level and rate for nationals as for migrants. And I think this is part of the reason that we in CARFA have worked with first our own staff. We do constant mental health checks on groups and also the staff as a collective. And we have also been trying to work with the ministries of health to encourage them to do this. I think we need to get away from the stigma of mental health. And if the provision of services to migrants can help in that elimination of the stigma, it's going to help these societies as well. The mental health effects on children are documented. We have instances of children during the Dominica event when there was rain after that severe flooding event in 2014-15. There were children who would start screaming when it rained. There were children who asked, why is God doing this to us? So more focus on the children and more recognition that migrants are people too, and they need to have access.
Thank you, Joy.
Well, mental health big issue in our countries, in not only for migrants but for the nationals in each country. In Peru, the government is expanding community mental health services, but it is also extended for migrants. But migrants face this in access to these services face the same difficulties as nationals, and that has to be keep in mind, because when we talk services for migrants and you have a country that has problems to give services to their own people, you can't divide. This is for migrants and this is for nationals. This is for all the people who is in the territory. So you have to keep this in mind. When we talk about migrants in our country, we are talking about the same problems that the nationals face. And we are talking about strengthening services for all of them.
I just want to add one point, Maria Paulina. Yeah, if we are doing that, we also are working to prevent xenophobia, because we cannot have different plans and different things, because you are migrants, so you are a local. No, when we are talking about system, we all are part of the system. That's a good point, and thank you for bringing.
I would just add, I cannot agree more with my colleagues, and I would just add that mental health is always part of the response of IOM as overall health response, and we have many different programs that are addressing these issues among migrant population, also women and children. But what I want to say is that sometimes mental health is seen as a separate aspect, separate area of overall health response, which might be good, but also might be contributing towards xenophobia and then stigma, because it's in some areas migrant health is perceived as a very peculiar problem for migrants, and in many cases this can be assigned only as a migrant health issue. So maybe if we approach to this as an overall health problem and improve the access to health services, not emphasizing only that this is a mental health support, maybe we can be having better achievement in this area.
Thanks to all of you. We have another question over here on the side. It's on as soon as you begin speaking.
Sven Harten from Germany's Development Corporation. I have two questions. So the first one is, sorry, that's better. So the first one is, in your experience, and thank you for those excellent presentations, is there anything particular about climate migrants? Because like the example, for instance, from Venezuela, I guess part of the reasons are also political, economical. So what are you seeing in terms of climate migrants? What is special about that that problematic? And then the second one being from the bilateral cooperation. In your view, what can international donors do to better respond to climate-induced migration? Thank you.
Yeah, I think with the Caribbean being particularly vulnerable to climate migration, and obviously Venezuela has a lot of roots in drought, maybe we'll start with you, Alex. Want to speak to that question? On specific climate migration and what it's meant in the region?
Yes, specific climate migration. Yeah, first of all, we need to realize that basically there is still not much evidence, and research is very exceptionally important here in this area. So therefore, we need to. Sorry, there is some echo. I don't know if you can hear me well. So yeah, as I was saying, research is exceptionally important in this area. So therefore, I believe that providing more information and evidence-based information to inform the decision making is maybe the key to the solution. So basically, what we do specifically is we for example, in Peru, we conducted a very detailed literature review on the patterns of migration closely related to migration, to climate, sorry. And also the same case in Caribbean, specifically with gender and environmental movement. So, I believe that maybe the key to this response would be the research as well. And in terms of the donors, I would say that not all the donors are very interested in. I mean, sometimes it's really challenging to find the appropriate financial support to provide the programs to support the stay or help to move. That we should also focus on the how do you say this, the people on the move, people to move, and people to stay. So this kind of programs needs to be also supported. But again, it's quite a challenging issue because of the lack of maybe evidence-based information that can support the decision making. So maybe we can start from there.
Joy, in the Caribbean island nations, you've seen increasingly frequent and devastating hurricanes, and that's really caused an enormous amount of displacement. I was in the Caribbean after one of the recent major storms, and maybe you can speak to that sudden displacement that happens in the case of hurricanes and major storms in the Caribbean.
Okay, so the Caribbean has always been an area of internal migration. And there were two instances that I would like to speak to. One is post-hurricane, and then one is post-volcano, because don't forget, we had a volcanic eruption as well to deal with. What happened post-hurricane for Antigua and Barbuda is that the whole country of Barbuda, although it's subsumed as part of Antigua and Barbuda, it's a separate geographical island. That whole country migrated to Antigua. And it meant, therefore, the need for an expansion of normal services like water and so on, electricity and so on, as well as the public health issues that could have arisen because of sheltering and that and the like. It demanded also that there should be regional solidarity because Antigua needed support. Then when we had the whole issue of the volcano, we had a whole section of an island that it was thought would need to evacuate. CARFA moved in quickly at the request of the Organization of Eastern Caribbean States to develop protocols which would have minimized COVID spread during the evacuation process and the shelter process. In the end, very few people, I don't even know if 100 actually evacuated from St. Vincent, but they evacuated from a part of St. Vincent to another part. And so we had this whole issue of trying to deal with shelter situations and to minimize COVID spread in those situations as well. And also because a hurricane is not a volcanic eruption is not a finite event like a hurricane. We also had to deal with a slow burn, not a sharp and sharps happening and stop, but a slow burn, and what that meant to the retooling and re-equipping of the health services and also the surveillance of disease. So we have had to think on our feet in the Caribbean and get things done. Yes, we have a lot of support, but the support is sometimes not experienced with the kinds of permutations and combinations that small, under-resourced health systems have had to deal with. And so a lot of the help has to be brought up by Caribbean brains who have had to deal with that kind of lack of resource. It's been quite a rough ride.
And I know that all emergencies are complex emergencies, but it was an interesting facet to me that while a lot of the dynamics are political and economic in Venezuela, the drought has been a really significant part of what has driven migrants away. I wonder if there's any particular dynamics that Miguel, you or Paulina have faced because of the drought situation and seeing particularly rural migrants coming to Colombia and Peru. Anything to add there in that area? We can take another question from the audience then.
Want to start? Paulina, you want to say something?
Be my guest, Miguel.
Yeah, just here in Colombia, and actually our program, LHSS Colombia, is helping the government to think, not only to respond to the event, is how prepare for future events. It's not only we are not working only in COVID. We have also internal migrants because we have climate different effects. We have two oceans, we have volcanoes, we have different things. But the most important thing that the program is conducting right now is working together the central government and the regional government, because this country is a very multicultural and different. It's like having 32 different countries in one. And we are preparing for future emergencies, for future possible events. not only just to add and react. Is more thinking in the long term. This is something like I just want to add about that program here in Colombia.
Yes, in Peru, we also have internal migrants due to climate changes. We have a major earthquake about 10 years ago, or something more, and we have floodings in the north of Peru that make us to deal with emergency, and that is a big deal, a big thing to deal with. No, as Miguel said, we are preparing. We are always preparing to improve our strategies to deal with these major natural disasters. No, and as a project, we are also working to improve the preparation of the country because we are working also with COVID just now to deal with future emergencies. No, and that is always a long process to deal with after a disaster. And about migrants, I wanted to say that migration, as we are receiving in Colombia, in Peru, not for natural disasters, but the problems in Venezuela in this case, has to move from humanitarian assistance to integration to people in the country. No, but at the end of the day, migrants will, most of them will remain in the country and will be part of the country or will contribute to, will be an asset to the country if we can see them in that way. No? And our policies should be directed to understand and implement that.
Great. Thanks, Paulina. I think we have time for one last question from the audience. Up here.
Thank you. Paul Faith, APP's Technical Director for Climate and Energy. I'm wondering, there's a lot of climate modeling, and that analysis has been downscaled to show for different, particular places how the climate might change in the future. And I'm wondering if any of that analysis is used in this sort of regional or country planning. I'm just wondering, as the comment was made about, planning for future events, but there's also the magnitude of those future events could be considerably larger than the magnitude of current events.
I wonder, Joy or Alex, that might be in your court.
Zoe?
Okay, let me start the tennis game. So, yes, the part of the presentation where I spoke about the health climatic bulletin is that kind of modeling. And apart from what we do in collaboration with the Caribbean Institute for Meteorology and Hydrology for weather and its effects on climate, that is short term. But we've also been forecasting on the longer term and also recommending and training health care workers and leaders on how they can adjust the health sector to project for what will be needed. That kind of forecasting is also being used for urban and rural, but more so urban planning. And urban planning with a lens to the health status of the citizens. So urban planning that tries to prevent or deal with NCDs. So yes, the kind of forecasting that I mentioned with the Climate and Health Bulletin is being done in other sectors, which makes sense. Climate is going to be affecting all sectors, if we like it or not. We haven't yet got to the kind of forecasting that is done in the Pacific Islands, where they've actually bought land for countries to move to because of the issues of sea level rise and so on. But we may need to think about that because we've started to see saltwater intrusion into our aquifers. And this will require some quick work on the behalf of the water authorities and also the health services, because more salt means more hypertension.
Thanks, Joy. We're running a little short on time here, but Alex, anything to add in about 60 seconds?
Yeah, 60 seconds. Yeah. I would say that yes, we are relying on technology, and absolutely we are open for any suggestions for any kind of modern and innovative approach that can help us better planning and better distributing the resources available for any kind of support that IOM as an organization and with our partners we can provide. Therefore, yes, modeling is absolutely important, and I would say that any kind of collaboration in this area would be exceptionally beneficial. And again, we are very open for this. And yes, we are using, and we will be probably not probably we will be using it in the future. So this is my 60 seconds. Thank you.
Great, thank you, Alex. Let me lose my earphones here. Well, thank you all for joining today. Just a few key points to think about as we close here around climate migration and health. First, I think it's important that all of us keep in mind the OECD principles for migration and health from 2018, which is to streamline and integrate migrants into care, and in the short term, providing migrants with some sort of medical screening and clear links to the coordination and different kinds of health systems and stakeholders. In the medium term, removing barriers to access to care. And then in the long term, as we had the comment here, anticipating those future influxes and other long-term needs that will happen with migration as patterns of climate change, as conflicts cause migration. It's important to support health system resilience in a way that balances that response to immediate emergency needs, as well as those long-term solutions, which can be achieved by integrating migrants into the regular health system rather than creating new programs. And in that long run, a system strengthening approach is likely to prove more cost-effective to governments than providing those emergency services, which are very costly to stand up and exclude migrants from the regular healthcare systems. And finally, that system strengthening approach includes both migrants and host communities in decisions and processes, and it could also be helpful to diffuse the political and social tensions that begin to emerge in host countries and improve outcomes for tailored, sustainable responses. So in the long term, that systems approach can really help eliminate the inefficiencies and build the required strategic redundancies, surge planning and other things that allow influxes of migrants to be absorbed as we see these occur more and more around the world. So we thank all of you for joining today, and we thank our panelists who were incredibly informative, and we look forward to seeing you all again.
Thank you.
Thank you. Bye.
Bye-bye.
Hi, we'll start again. Hi, my name is Omar Benyed. I'm the group publisher at African Business Magazine. I'm here today to support the African Risk Capacity with their event on health and preparedness and adaptation. So I've known the Africa Risk Capacity for a few years, but I knew them as key players in the agricultural space, helping the most vulnerable in times of droughts, floods, and tropical cyclones. So it was interesting when I spoke to the African Risk Capacity team, who told me that actually they wanted to extend their remit to now cover health outbreaks and pandemics. And really my idea was, or my question to them was, why are you going into something that's completely different to what you've been doing since 2012? And the answer that I got is actually our remit is to help the most vulnerable in times of distress, you could say. And what we've seen is we've seen the vulnerability of a globalized world to fast-moving disease. And we've seen it with SARS, we've seen it with Ebola, and we've seen it in the past year and a half. So actually, when the African Risk Capacity mentioned that they wanted to get into health outbreaks and pandemics, it made absolute sense to me. And obviously, prioritizing public health is as important to economic resilience as anything, and we've seen this past year. So it's my delight to welcome Ibrahima Sheikh Diong, who's Under-Secretary General at the United Nations and a Director General at the Africa Risk Capacity, who'll make some general remarks, welcome remarks, and talk to you about what African Risk Capacity is doing and the nexus ultimately between helping vulnerable people and making sure that we've got the right preparedness when it comes to health. Thank you, Ibrahima.
All right, can you hear me? Excellent. Good afternoon to all of you. You can just wave if you can say good afternoon. All right, so we're connected now. Let me extend a warm welcome not only to you, to those who are watching and listening online from around the world, to this extremely important event at COP26. Let me begin by thanking WHO for welcoming us. And I like the slogan they have in the background there, Climate for Action and Action for Health, which is quite timely because it's important to mention. Even though we all come here for climate change, it's also important that outbreak and epidemic affects many people across Africa. So the opportunity to link the two, it's a great opportunity for our organization. It shows once again our commitment to supporting vulnerable communities across Africa, and that's why this event is extremely important. The organization that I have the pleasure of leading at the group level, it's a mandate given to us by the African Union with the sole purpose of helping African countries to prepare themselves, to plan properly and respond to disasters, whether it's climate change, but also outbreak and epidemic. And that's why for us, the link between climate change, outbreak and epidemic, it's a natural link because it has one purpose, is to protect Africans across the continent. The conversation we're about to have is also very much in line with our belief as an organization. The only way we can address the impact of climate change and outbreak and epidemic is through smart and strategic partnership. That is why I'm delighted we have GCA on board here today with us, with whom we have an MOU. We have also other partners, UNDP, with whom we have signed an MOU. And we are in advanced discussion with WHO and WAHO. So therefore, we're among partners here today to make sure that we can demonstrate together we can join forces and making sure we can protect Africa. For us at ARC, we believe in the importance of early warning because by having that information, government can make the sound decision so they can actually decide if to return the risk or transfer the risk if they choose to do so. But for ARC also, we believe in building the capacities of African countries to make sure they can respond to disasters as appropriately, be it climate change, but also outbreak and epidemic. So I can assure you the commitment of our organization, whatever comes out of here, as recommendation and ideas to go back to our countries and make sure those recommendations are not left unattended for, so that we can improve what we do for Africa. So I am looking forward to the conversation. I'm looking forward to your great ideas. I'm looking forward to the innovation that we expect from all of you, so that together we can make Africa more resilient, beat climate change, beat outbreak and epidemic. And as WHO said, climate health for action, or health for climate health, climate change. So we are in the right place to have this conversation, and I look forward to the next step. So on that note, Omar, over to you, and thank you very much, and I look forward to the conversation. Thank you.
Okay, thank you. Thank you, Ibrahima. And ultimately, undoubtedly, climate change will lead to more outbreaks, which means that we definitely need to build a resilience in terms of our health preparedness. I'd like to call upon Dr. Amadou Ba, who's the Senior Public Health and Country Liaison Officer at the Africa Risk Capacity. He's been there for about 5 years, and prior to that, he was actually in Geneva at the World Health Organization. So he understands the nexus both between climate change, health, and helping the most vulnerable. So Dr. Ba, for a short presentation, thank you.
Thank you very much. Can you hear me? Excellent. So good afternoon to everyone. My name is Amadou Ba. I'm the Senior Public Health and Country Liaison Officer at the African Risk Capacity. So in few slides, I will try to provide an attempt to provide just a quick summary of what we are doing in the Outbreaks and Epidemics program, and the need to invest in early preparedness and response to address the problem of disease outbreaks in the African region. Next slide, please. Okay, so the first slide is related to a recent study from the World Health Organization showing in the past decade what was the trend in terms of frequency and severity of disease outbreaks in the African region. So we can see from that publication that the top row in the figure is the year 2016, and the second and third row is 2017, 2018. So we can see for different African countries, as compared to 2016, which is a benchmark in that study, we can clearly see that there is an increase of disease outbreaks, but also a quite a significant increase in terms of severity of the outbreaks by the bubble represented here. Next slide, please. So here as well, another example from the World Health Organization using the joint external evaluation, which is a gold standard method to assess how well a country is prepared to prevent, detect, and quickly respond to public health emergencies. So we can see from that figure, countries in red in the African region are countries where there is quite significant work in order to better prepare those countries to address the issue of disease outbreaks. And the one in yellow are the one which have made progress, but still very significant work needed in order to better detect, prevent, and respond to disease outbreaks. Next slide, please. Okay, in terms of financing options for disease outbreaks, so we can clearly see when we have, from the declaration of an outbreak to an end, so there are different financing mechanisms in place available either to countries or available to agencies. So for example, for agencies, for example, we have the WHO Contingency Fund for Emergency, which is released quite early, immediately, let's say, at the beginning of an outbreak. And in terms of mechanisms for countries, we have the Catastrophe Containment and Relief Trust Fund, for example, but which is coming at a later stage during the evolution of an outbreak or an epidemic. So here we can see that there is a gap for countries to respond early to disease outbreaks. And this is where the African Risk Capacity would like to position itself to provide early funding to governments in order for them to act quickly and manage further transmission of a disease. Next one, please. Okay, so here we can see where ARC would like to position itself, providing early financing mechanisms directly channeled to countries. Next one. Okay, so just to recap briefly on the Outbreaks and Epidemics program from the African Risk Capacity Group. So we have piloted this project in 2 countries, Guinea-Conakry and Uganda, and we have selected disease of epidemic potential in the first phase. So these are mainly hemorrhagic fever disease, Ebola, Marburg, and Lassa fever. And also we have included, from consultation with countries, Africa CDC, and other partners, the meningitis outbreaks. So in terms of work streams, we have developed risk management tools to better equip countries to better respond to disease outbreaks. So the first one is the risk profiling, where we are assessing the level of preparedness of countries. The second component is the contingency planning. This will allow countries to effectively respond to disease outbreaks. And the last one is the modeling. So here, in that work stream, it is to anticipate and to estimate the level of risk that countries are facing. And all of this work will lead to the design of a financing risk transfer product, which will allow countries to quickly use the funds in order to enable early response to a corresponding outbreak. Next one. Okay, just to conclude, so in order to address the issue of outbreaks, epidemics, or pandemics, it is twofold. We need adequate structures which are responsive and linked with contingency planning, and also adequate funding. So within the African Risk Capacity Outbreaks and Epidemics Program, so we are aiming to provide to the continent a sovereign risk transfer product in order to mitigate the financial losses. And also this product will improve the preparedness and the response capacities of countries. And finally, we are aiming at, once the product will be ready and for launch, we are aiming at providing coverage to around 50 to 40 million people, and in terms of coverage, and protect around 200 to 700 million people in few countries over the next years. Thank you for your attention, and looking forward to that session. Thank you.
Hello. Yes, excellent. Thank you very much, Dr. Ba. I think you're going to be joining us on stage as well, actually. So, look, I was reading the report by the WHO, and they said that preparedness costs about $5 per person per year. And the cost of COVID, they estimated at $11 trillion to date, and a further $10 trillion in lost earnings. That's $20 trillion. That's a quarter of global GDP in a year. That's incredible. So, but ultimately, I think one of the messages in my previous conversations with you, Dr. Ba, was all about building that culture. And it's very easy to react to something, but it's a lot harder to anticipate, prepare, and have that right culture and mentality. And I'd like to pick up on one point that you said. It's about partnerships, and I know we've got a partner here with us, and we've got some partners online. But again, from the WHO report said, you don't hand out your business card during a crisis or an outbreak. You hand it out in times of peace to prepare, plan, so that when something does come, so when there is an outbreak, we're prepared and we can act at speed altogether. So I'd like to welcome one of our partners here from the Global Centers for Adaptation. If you can join us on stage, Eddie Jorge Vasquez, who's a Senior Advisor Africa at the Global Center on Adaptation. But if you don't mind, Eddie, I'm going to call upon one of our virtual speakers, Dr. Kutsia Houdet, who heads the Disaster Risk Management and Resilience at the WHO, who's going to join us online. And Houdet, I actually would like to ask you one question, because ultimately in terms of vulnerability and the globalization of diseases, let's say, diseases are fast moving today. I had a question to you in terms of Africa's preparedness compared to the rest of the world, especially relating to this particular pandemic, because of what we suffered back in, I think it was 2014 to 2015 in West Africa, in Guinea, in Sierra Leone, in Liberia. So would you say that there were lessons from Ebola in West Africa in terms of our preparedness and how we responded to this particular outbreak? Or do you think the lessons were learned, but there's still a lot to do? Houdet? Dr. Houdet?
Okay, so good afternoon, everyone. Thank you very much for the question, Amor. So I think that this question is quite pertinent to ask today, and then I think that it should have been asked quite earlier to the whole world, not only Africa. So I know that you are asking this question to me to reflect on Africa, but I would like to answer it, to take it from the global level, because it's important to do so. As my previous speaker and also Ibrahim has said it quite nicely, that we all need to work together in this, and we all need to come together. So this is where I would like to pick up my answers to your question, because this question is of paramount importance to us in the future, because so far, pandemic preparedness has received very insufficient political priority globally and has largely been confined to the health sector, while the impact of COVID-19 is quite widespread, particularly affecting socioeconomic sectors worldwide. So this very sentence would differ from the preparedness for a pandemic and preparedness for Ebola viral disease, which is within a country or within few countries, but not pandemic. So that's the reason I say that I will allude my answers to the pandemic so that we can get to the point that what are the countries need to do and what's happening at the national and subnational level. So I would like to highlight a couple of issues here. One, the extent of pandemic use has not been appreciated in financial decision-making or whole of government or organizational priority setting at all levels, be it subnational, national, regional, or global. Then multi-sectoral coordination for pandemic risk management has been visibly lacking. So for example, while the Sendai framework for disaster risk reduction includes pandemic risk in its purview, the risk management capacities have largely been separated from health sector actions for COVID-19 preparedness and response. Again, this is the global scenario. Let's see what the evidences are out there to shape our actions for better preparedness. I think this is the time we should discuss what would be better, taking the lessons learned from what happened before. Several reviews of the global response to the pandemic spotlights on some critical areas, of which I would like to allude to four. Firstly, we need better governance at all levels, a governance that is guided by risk. As we call it, risk-informed governance. The existing global health security architecture is very complex and fragmented, and voluntary mechanisms have failed to create the level of commitment and actions needed to consolidate our approach. As our DG says, there is a need for solidarity and an international instrument of consensus to ensure an operational global cooperation. Why I'm saying that? Because when you particularly focus into any region or some countries, it's important to bring that solidarity, because neither the health sector alone nor a country alone can manage the risk the country's communities are exposed to. My second point, I think that Dr. Ba has already mentioned about it very nicely, giving a lot of evidences, and so I wouldn't go there. I would just highlight some strategic things here. We need better and sustainable financing for pandemic preparedness. Though I'm saying it's for pandemic preparedness, but this is not only pandemic, because pandemic doesn't come to a clean community or clean world. It comes accompanying with many other risks countries and communities are potentially exposed to. So sustainable financing for pandemic preparedness or any public health emergencies means substantially increasing domestic investments and international financing to support low and middle income countries, which means building upon existing financing initiatives and consolidating the global health financing architecture. The third point, we need better health system and tools which not only reacts but also withstand risk through gaining intelligence across the sectors. Our health system needs to be resilient and equipped enough to be able to detect, prevent, respond to risk from all hazards. We need to build synergies, connection to other sectors, particularly animal health, for risk-informed preparedness. We need to integrate approaches to improve health system resilience based on a primary healthcare approach with a right-based risk-informed manner. Resilient health system is key for universal health coverage and health security. We need to leverage also all innovative technologies to do so. My last point would be everything we do needs to be grounded in communities. They are the first aid, they are the first responders, so we need to do everything in our power to facilitate community. They're the key to a robust pandemic preparedness, not to mention any other public health emergency preparedness. Their actions led the ways in harnessing the local knowledge to scale strong pandemic preparedness. We need to listen to them. They know what's best for them. We need to design all strategies, policies, plans, everything with the communities and not just for the communities. Well, the opportunity is knocking at the door that post-COVID-19 recovery is opening for the world. We need to use every learning from this current pandemic and other public health emergencies to design a sustainable and green recovery together with communities, making sure that no one is left behind. And this needs strong to achieve in all sectors to ensure effective community engagement with an enhanced focus on equity. We must use all hazard risk management approach to prepare the world. We have seen this in the current COVID-19 pandemic, and also we have seen this in the Ebola outbreak in the Africa region, that how concurrent emergencies and disasters like cyclones, storms, floods, protracted crises, population movement impede our response to any public health emergencies, not to mention this current pandemic. They jeopardized our efforts and overwhelmed our health system. So preparing for any public health emergency is preparing for multiple risks countries and communities are exposed to. Here, I see that AS is doing a great job in bringing that risk discussion on the table, which I think is a gap in whole preparedness action that we do. The world has progressed since the Spanish flu pandemic, some 100 years back. We need to use all those progress development to build a new world where our children will not be afraid of having another pandemic and lose their school years, lose their childhood, lose the moments to be careful. To be honest, Omar, I'm waiting for the time when you will not ask what we can do, but we must do to prepare the world for any public health emergencies, any adversity such as this pandemic. Our resources are limited, but as a human race, we have unlimited potentials. We must build a better future. We just don't have any choice anymore. There should not be any excuse not to do what we must do. The reason I'm raising all these issues, now we can look back and we can see that what we have done better, we build on that. I think this is what I need to say for African region, and then also what they have done better. Till we speak today, 9 countries in Africa only this year developed their risk profiling. And I see that risk profiling is your first part for your risk management approach. I'm very helpful, taking the lessons learned, building on that, things will happen. And we can prepare the health systems in Africa region. We can make them resilient, not only the health system, but whole of society in support of the health system. Thank you.
Dare, thank you. So, I mean, you raised a lot of points and there's a lot to unpack. We haven't got the time to go through all of them, but I mean, there's one thing that stood out from my perspective is there's a clear financial risk, and government isn't always the best person to assess that risk, nor to take the measures to measure the risk and to deal with the risk. And the second point that I think I I took home is ultimately when there is an outbreak, we need to act quickly. And it's important to respond very, very quickly and to have everything in hand to be able to respond, which is, I think, what the Africa Risk Capacity is trying to do. We're going to go to, before we go to Ede, we're going to go to Stan, if you don't mind. So Mr. Stan Quain, who's a director at the Regional Services Center for Africa at the UNDP. I mean, we mentioned a little bit governance just now and capacity building at government to be able to, as we said, risk manage and risk assess. So maybe you can tell us a little bit about at the UNDP what are you doing in terms of strengthening governance and local governance around disaster risk management. Stan.
Thank you very much. And I'll build a little bit on what the previous speaker, I mean, as I said, pandemic response, preparedness is probably only as good as preparedness in other areas or in other sectors. And I think the work that we do as UNDP takes that into account in strengthening capacities for disaster risk management and preparedness. And I'll share with you a number of examples which I hope can be useful to highlight that we do recognize, in fact, the ever-increasing complexity and scale of risks on the continent. And we have a whole resilience hub out there in Nairobi that is helping us pull all of that together. We are indeed one of the leading UN agencies on disaster recovery, and we offer expertise and resources in building national and local recovery planning and coordination capacities for risk-informed development. And we support governments and local authorities to develop institutional and governance structures, policy tools, and including strategies and legal frameworks. And some of the policy tools we are working to support on the continent, I'll take a couple of country examples. In Cote d'Ivoire, for example, we are supporting the PM's office in conducting a post-COVID-19 review of the crisis management system as a whole. And we are providing assistance to the development of a national crisis management plan. Without that kind of policy framework at national level, things get more difficult to manage. In Niger, as well, we've been active in disaster recovery planning with the development of the National Sustainable Recovery Strategy, building national capacity, the post-disaster needs assessment methodology that brings together the bank, the UN, and the EU with the establishment of a recovery funding mechanism. And in Senegal, UNDP is helping the government develop its very first national disaster risk reduction strategy. We are not limiting, we don't limit our work, of course, to the country level. We are also supporting ECOWAS in West Africa in developing a regional resilience strategy for West Africa that aims to provide policy guidance to member states in building resilience to shocks, including pandemics, of course. Continuing on these policies and strategies, we also work with our partners to build operational capacities for disaster and crisis preparedness and response. Depending on the country's needs, these policy tools can vary and include setting up national or local emergency operations or crisis management centers, helping design emergency early warning and risk information management systems, facilitating preparedness and contingency planning exercises, developing standard operating procedures for disaster or crisis response, and advocating and enabling the integration of gender and diversity markers into preparedness and risk management instruments. And a couple of country examples in these areas as well, in Liberia and Sierra Leone. In Liberia, for example, we are supporting the establishment of the National Emergency Operations Center, which has so far significantly enhanced the capacities of the National Disaster Management Authority, and another vital national policy tool in coordinating major emergency and disaster responses. So in Sierra Leone, we are supporting the Environmental Protection Agency and the Sierra Leone Meteorological Agency with equipment for establishing functional networks of coastal climate and sea level rise monitoring systems. And at regional level in this respect, we also have been supporting the African Union Commission in developing a continental framework for multi-hazard early warning and early action, bringing together systems and processes and actors engaged in monitoring natural hazards. And this may also lead at some point to the establishment of situation rooms at the continental and regional levels. Another policy tool, which is also a challenge, has to do with data and the establishment of data platforms. We know that all disasters, including those triggered by biological hazards such as COVID-19, do impact people differently. And when it comes to decision making for pre-disaster preparedness, early warning and early action, sometimes the data that are needed are often hard to obtain. So we're therefore working to support national and local authorities in data collection on risks and disasters, risk analysis and mapping using GIS tools, and monitoring and evaluation and disaster registers and disaster management tools. And some examples in this area of data include our partnership with ECOWAS at regional level to support countries in Western Sahel and the Lake Chad Basin, 7 countries in all, Burkina Faso, Chad, Mali, Mauritania, Niger, Nigeria, and Senegal, to strengthen national disaster loss and damage databases, disaggregated by sex, age, disability, and many other subcategories. And at sub-regional level, in the Lake Chad Basin Commission, for example, working with the Lake Chad Basin Commission and our partners at the African Development Bank to support adoption of a multi-risk approach, critical to inform the implementation of the regional stabilization strategy. In Niger, for example, a policy tool in this area, we are partnering with the government of Niger to equip and train staff of their vulnerability monitoring observatories. These are important policy tools at national level, as well as early warning and emergency response systems established in various municipalities. We also find that communication and advocacy are critical policy tools to inform the general public on risks to safety and health and disaster preparedness, and on the right behavior to adopt when the disaster occurs. And we have examples of this in Kenya, where we are strengthening the capacities of the National Disaster Operations Center and the National Drought Management Authority to improve virtual communications. We're working with local authorities on the development of country hazard profiles. We're also active in the field of public sensitization in various countries of the continent. An example in this area is Burkina Faso, where we trained some 15,000 volunteers as communication agents on COVID-19, as well as journalists and influencers in order to better communicate and inform the population on COVID-19 prevention. There are a couple of other examples, but I think I'll just probably end with a few challenges that we have in this area. Several challenges that we face, as you can imagine, but I'll just probably cite 3 in the areas of technical capacity, financial support, and the political space. Technical level to start with, there are often capacity shortfalls to lead and effectively manage many of these structures at national level that I just referred to manage risk, early warning, and early action platforms. It's a lot easier. This is a lot easier as a challenge to handle through the capacity development work that UNDP, that we are doing with many of our donor and technical partners. One of the biggest and most specific challenges in the technical area, as I mentioned earlier on, has to do with the scarcity of data, critical for defining the problem, assessing and managing risk, and establishing baselines for change. A second challenge, of course, is funding. A lot has been said about funding. Just on a general level, the tendency of funding partners to focus almost exclusively on response rather than anticipation, risk management, prevention, and capacity building outside of disaster events and their visible impacts. So here, the broader funding perspective would be most helpful if we want to make a difference in risk management and climate change adaptation for better health outcomes. A third challenge is political in nature and has to do with sometimes the inadequate or not sustained national buy-in and ownership and leadership, often difficult to come by after the immediate response phase of a crisis subsides, and attention starts to fade, and then governments in general tend to resort to default business as usual approaches. With COVID-19 is a little bit different in that this has gone on for much longer than I think was anticipated, but the tendency is still there for governments to have a very short attention span and to resort to business as usual. Third, final challenge I think, coordination. And I think that this is where we actually feel that the regional and sub-regional institutions that we have, such as the African Risk Capacity Agency, have a vital role to play at regional level in terms of the credibility they bring to help countries adhere to some of the regional instruments that have been put in place. And the institutions like this can play a vital role in continuous advocacy. And thus, our regional work in this area also is very critical. So let me end there. We put all of this work within the broader framework of risk-informed development, which of course includes a lot of what we do also in support of COVID-19 recovery and other areas. Thank you very much.
Excellent. Thank you very much. Thank you very much, Stan. I mean, again, you've said too much to unpack in a few seconds. But basically, if you can't measure it, you can't manage it. That's for sure. And I used to think as a young child 15, 20 years ago that I was living during the best history of humanity. 15, 20 years later, I'm not so sure anymore. But Ede, sorry, if we can come to you. I mean, we've heard a lot ultimately in terms of what needs to be done. And what we do know, I think, is there's going to be an increase in outbreaks and, importantly, in the severity of outbreaks going forward. So you've just released a report on adaptation and on Africa. So what are the key take-homes and what are your thoughts in terms of what we should be doing as well?
Thank you, Omar. And thank you so much for the African Risk Capacity for the invitation. I think that the last message of partnership becomes critical into this process. We just released the most comprehensive report on the state and trends of adaptation in Africa. And on the health side, there are three important messages. First, given the tremendous challenges of the health systems in Africa, the most important measure is really to strengthen them. Only 45% of the population has access to strong health opportunities, and therefore a population that doesn't have a strong health, any shock really throws them, and 15 million people in Africa every year are thrown back into poverty because of expenses related to health altogether. Second, the trends are slowly changing, but they're going to get far more serious. As Africa's health indicators begin to improve, then the importance of the health impacts of climate change become more and more critical. So as malaria expands their areas, as the undernutrition caused by crop failures increase, as you have more vulnerability on floods in low-income communities, then those factors become more and more important. And the solution is not always in the health sector. For example, in inner Kampala, when you have a 1 in a 10-year-old flood, which happens actually quite frequently, the people generally have, under dry conditions, everybody can access a health facility in 15 minutes. With that flood, actually a third of the population cannot be accessed and picked up by an ambulance and go back to a health facility within 60 minutes, and that's the golden hour into this process. So the solutions to the health challenges in climate are also in many other sectors. Finally, to conclude and to connect to the conversation today on outbreaks, there are important tools that may need to be looked at in a combined way. The report looks a lot about adapted social protection systems, how to help individuals and households, particularly those are the poorest and most excluded, to deal with this crisis and these shocks in a way that doesn't throw back either into poverty or that don't throw the children into health impacts for the long term. Remember that 40% of the stunted children in the world, those who have been stunted, are in Africa. Therefore, health impacts like either a pandemic or a climate shock need to have adaptive social protection system that allows. Second, early warning systems. Many of the other speakers have talked, and it's easier said than done because it's not only to be able to have the system for understanding the warning, is to give the information to everybody in the population, and it's for every individual and household to know what to do with that information, how to protect themselves, how to move into this process. And then finally, as Africa strengthens its health systems, that strengthening needs to account the shocks that they're going to have due to climate change, where to locate them, how to get ready for crisis, how to make sure that that planning takes place. And Africa Risk Capacity is really building a lot of the systems and helping African countries build that capacity of early warning systems. That tends to happen with the Disaster Risk Management Agency. That integration into health systems is fundamental. Thank you so much, Omar.
Thank you, Rick. That was fantastic. Thank you very much. And so, again, some worrying statistics ultimately. I mean, 50 million people going back into poverty because of outbreaks is tragic. So we'd like to call upon Dr. Virgil Lokusu, who's joining us again virtually. He's a team lead for health emergencies and disaster management for WAHO, the West African Health Organization. So he oversees the ECOWAS region, so the Economic Community of West African States. So, Dr. Virgil, I'd like to ask you really, I mean, Dr. Barr earlier mentioned that there are various mechanisms in place to finance outbreak and outbreak responses. But I mean, from talks that I've had, not all mechanisms are predictable and can be slow. But I wanted to know at the ECOWAS region and within WAHO, are there any current mechanisms in place to finance outbreak responses? And if so, how do they work?
Yes, thank you very much for the questions, Omar. First of all, let me start by thanking the organizer of this conference and especially WHO and Africa Risk Capacity for inviting WAHO on this important panel to discuss how to strengthen health outcomes through risk management and adaptations. With regard to your concerns about the mechanism in place to support the funding of outbreak response, I have to recognize that we have several mechanisms in place. First of all, most of the member states in the region try to establish a domestic line, a budget line to support outbreak response. But the problem we are having is that most of the time, countries are facing a lot of challenges. So it's difficult in a scarce, when facing the scarcity of resources we are having this region to save some resources in case the outbreak will come, because we already face a lot of emergency situations in West Africa. That's number one. So the amount the country are able to save is not substantial to address the needs of the immediate response during the outbreak time. The other big challenge the countries are facing, the regions also, is about the administrative procedures to access these fundings. It's also really a challenge, especially in the early stages of the response. And many countries experience a huge delay at the critical time of the response. I remember I was deployed in the Guinea in 2014, 2015, and it took almost 11 or 12 months for the country to mobilize domestic resources to address the situation, while international funding were already deployed in the country. So that's always the case in many countries when dealing with outbreaks. We also have some multilateral mechanisms, especially coming from WHO contingency funding, very useful for countries as well. We also have World Bank, with the country having to have a contingent emergency response funding as well, where countries can mobilize immediate resources to address the needs in case of an important public health event. We also have a mechanism in place with with bilateral cooperations, I should say. We have U.S. government, French government, and German cooperation also providing direct support to member states through bilateral mechanisms as well in the regions. And ECOWAS, as a regional health organizations, also are providing a direct response based on requests from member states coming from the regional solidarity funds. But all that put together is not enough when you look at the number of the public health events the West Africa is reporting, and even disaster we are having in this region actually. So there is really a need to innovate, to reinvent the way the system is right now to be more efficient. And also, there is also, that's the reason why, actually, we are collaborating with Africa Risk Capacity in the new products they are developing to support the countries. I'm talking about the insurance systems, especially with priority diseases in the system based on our own risk profile. So we are really optimistic that these systems will bring a new era of outbreak response in our regions. So we also have partners like Africa CDC, Africa Union, and other non-governmental organizations also coming to support outbreak response. But it's really coming time to time on the ground. But in general, what I want to come out with from this talk is that there is a lot of fragmentations where we are lacking resources to deal with health emergencies. That's my takeaway from this question. Thank you.
Thank you very much, Dr. Virgil. So, Dr. Ba, we'll come back to you if you don't mind. So I know that you work very closely with these different organizations, and obviously we need to work in a cohesive manner, as Dr. Virgil just said. But moving forward, what are the key milestones for ARC in relation to its outbreaks and its epidemics program, which I think you're helping to coordinate?
Yeah, thank you very much, Omar. So, as mentioned earlier, the aim of this product is really to address situations of epidemics which are of high severity but not so frequent. So this is the reason why we have selected in the first phase of those four disease of epidemic potential. So for now, what we have done so far, we have developed the different risk profiling, the different risk management tools in order to support the design of the product. So the product itself, there are few steps which are required in order to have it fully functional and available to our member states. So we need to work closely with structuring agents in order to design how best the product could be. We need also to model the risk. So as mentioned, the work was done in 2 pilot countries to date, but we want to expand our offering to the African Union level. So we need to conduct some risk modeling work, and this will be done with the support of a modeling agent, which will be on board very soon. And this will allow us to estimate the risk of epidemics in those different countries. And I think the last point as well is really to define the contractual agreement between ARC and the various member states in order for them to be enrolled in this program and to benefit from this product. So these are the next steps which are in the pipeline in order for the African Risk Capacity to offer this risk transfer product to African Union member states. Thank you.
Thank you very much. I was checking my phone just to see if there are any questions from the live stream. There's just comments, I'm told. So Eddie, maybe we'll go back to you. So Dr. Ba mentioned it earlier on, but about creating the right culture around disaster risk management. So how do we create this? So how do we establish this culture of disaster risk management to make sure that we have those early warning systems, those prevention and the right response mechanisms?
Absolutely. I think that there are 3 elements that are important in that process of transformation. One is to have enough of the infrastructure for those early warning systems to work, meaning the data collection, the ability to project and predict what may be happening in the future, and then the mechanism to have that information in the hands of everybody that needs to have it. Now that requires first an infrastructure of data collection. There's much to be done. Unfortunately, in Africa over the last 5 years, for example, surface-based weather observations have gone down by 50%. WMO is now working really hard to make sure that that problem gets solved. So you do need the data. Second, you need to be able to have enough of the transformation of that data into information that is usable, so that a farmer gets a text and knows what are the implications in terms of crop that they need to select and the farming that they need to do in that process, so that the cities and the mayors know what is it that is going to be the risk that they have. So the Ministry of Transport, for example, has prior contracts to repair certain roads that they know are going to be happening to this process. And then the final is a behavioral change. And that's not unique to Africa, that's everywhere around the world, to be able to be prepared so that every households know and think through, look, what are the risks that are going to happen? If this happens to us, what do we do? Our house is in a high flood area, and therefore, how do we know that we move the furniture from the first floor to the second floor to be able to save our assets? Or there's going to be a major storm, what are the documents that we need to take? That kind of preparedness is a change of behaviors that, I repeat, is not particular to Africa, it is globally that needs to happen. And so infrastructure, from infrastructure to information, from information to change of behaviors. Thank you.
Perfect. I don't know if we've still got Dr. Virgil online. Is Dr. Virgil still there?
Yes, of course.
Excellent. Dr. Virgil, so look, we've got exactly 3 minutes before I need to hand over to the chair. But my question to you ultimately is about the difference between rural areas and cities. I mean, I know that ARC has dealt a lot with farmers, and ultimately these farmers are generally in rural areas. But in terms of health outbreaks, my instinct will say that the bigger risks is in urban areas. So what's your experience ultimately between the difference on the risk front between the urban centers and the rural areas?
Okay. Thank you so much for the questions. I will be looking at this question at saying that urban areas are facing more risks than rural areas. I think each context has different risks and have different capacity to address those risks. So we need to make this analysis in an holistic manner, taking the context quite differently. Urban cities have more capacity, have people more equipped with more knowledge to change behavior, as by just the previous speaker explained, have more information, more data from the urban area. But where remote areas are hard to reach, and people there have less access to relevant information to protect themselves from the risk. So I will be a bit, I can say, moderate to conclude that one area is facing more risk than to the other.
Excellent. Thank you for your brevity as well, Dr. Virgil. I'd like to thank all my panelists, Dr. Hude from the WHO, Mr. Stan McQuain from UNDP, Dr. Virgil from WAHO, the West African Health Organization, and Eddie George with us from the Global Center on Adaptation. So I'd like to hand back to Mr. Ibrahima Sheikh Diong, who the Assistant Secretary General at the United Nations and the Group Director General at the African Risk Capacity Group.
Well, thank you very much, Mr. Moderator. Can I ask you just to give a big round of applause to our moderator, all of our speakers from different parts of the world. A big thank you from the entire ACT group for honoring us with your presence, but also for your great contributions. And let me start also by thanking WHO. We could not pick a better place to have this conversation with that great logo, but also the great actually slogan about climate action for health and health action for climate. That is really quite timely, but also quite fitting for the conversation which gets hard. There are a couple of takeaways that really speak to us at the African risk capacities. And let me just volunteer some of them, because this is something we'll take back to our headquarters in Johannesburg and make sure we can get inspired and energized at what we do for Africa. I think number one, I was quite impressed by the fact that many of the speakers have underscored the importance of building the culture of disaster risk management. If you wait till it happens, it may be too late. If you wait till it happens, you may actually lose some life. So therefore, I hope all of us get that message loud and clear so we can go back and continue to build the culture. But we at ARC believe that you can't build a culture without evidence. And that's why we have many great stories to tell, whereby we've seen what we do saving lives. So hopefully it will help to build that culture by having that base and real stories where lives have been saved. I think second, we're very much comforted by the holistic approach you've all talked about. And that is to say, for us to be effective in disaster risk management, there are a couple of pillars that are extremely important. Number one, I heard so many people talk about the importance of policy making. It is important that what we do is embedded in the policies of African governments so they can begin to have an ownership about what we do from a policy perspective. Second message is extremely important to us. It is important that what we do is build around a good framework and a good strategy. And in this case, a national strategy of disaster risk management. We at ARC believe that the only way we can actually intervene in a much sustainable way and make sure that countries have a national disaster risk management strategy, so what we do fits with the overall strategy of the country. We heard so much also about the important building capacities, early warning system, preparedness. These are things that speak to us at ARC because it's really at the heart of what we do and make sure that the African countries themselves have the right capacity to deal with their own disaster situation. So therefore, from GCA, from WHO, from WAHU, we look forward to learning from you and make sure we can avail that capacity to our member states so we can continue to build. You also talked about funding. This is something that's extremely important at the African risk capacity. How do we build innovative funding mechanism so that part of the response, we can have the necessary funding that allows us to respond to the needs of African continent. That is something that I believe that we can do together as entities. Last but not least, 2 points extremely important. You all talked about the importance of strategic partnership and smart partnership. All the challenges that we talked about cannot be addressed by one institution alone. So I have no doubt we'll join our forces to make sure we can address the different challenges you highlighted. The good news, we already have an MOU with UNDP. We have one also with GCA, and we are working with other entities, WHO and WAHU, to make sure we can build also a partnership. And I have no doubt all of us will go back to our respective countries inspired, energized by the work to be done, but also by the fact that together we can be successful in making Africa more resilient. And as we do so, let's think about the communities across Africa, the vulnerable communities that we need to protect so we can continue to adapt, make Africa more resilient, but to mitigate the risk and make the connection between climate change and health. So on that note, on behalf of the entire team, on behalf of our great moderator, which I ask to give a round of applause, Mr. Omar, for having done such a great job. And I look forward to seeing you on our lecture series where we can begin to bring all the partners together so we have a great, constructive, action-oriented conversation so we can make Africa more resilient. So thank you very much, wherever you go back, and have a good day. Thank you.
Okay. Are you ready? Is it working? Yeah? No? Is it working now? Yeah? Okay. Perfect. So good afternoon to you all, and thank you for joining us today for this afternoon's Climate Classroom on climate change and health. My name is Colin Hastings. I'm a green economy and climate change consultant at the United Nations Institute for Training and Research, which, as it says in the name, is the training arm of the United Nations. And I'll allow her to introduce herself more fully in a moment, but with us to be our teacher for today's session is Elena Villalobos-Platz, who is a technical officer at the WHO. So many of you are probably wondering what a climate classroom actually is, and we like to call it our espresso shot of learning. We all have an increasing number of demands on our time, less and less time to spend and devote to learning. So the climate classrooms are a short and sweet interactive learning experience that is designed to help those of you that are attending, so everyone that's here today, get quickly up to speed on a range of climate change issues. This is now our 8th edition. We'll be running a total of 16 classes over the 2 weeks of COP. This is now our 6th class, I think. Most of them this year are online. We do usually run them in person like today, but most of them this year, because of the exceptional circumstances, are online. We will have one more in-person class next week, and I'll give you the details of that at the end of today's session. So after this short intro, today's class will be 45 minutes long. It will be broken down into 3 parts. The first part will look at the substance of today's topic, so climate change and health. In the second part, we'll try to bring that substance to life through a practical illustration, a case study, an example. And then in part 3, we'll hand the floor over to you with an interactive Q&A. Now, we want these classrooms to be interactive. We want them to be dynamic. So we'll really be relying on you to kind of take over in part 3 and really bring your questions, bring your ideas, your thoughts, and bring the class to life. So just before I hand over to Elena, we do have a few class rules today, which I could quickly share with you. This is supposed to be a classroom. I know it's very different probably to the classrooms we all spent much of our time in growing up. But those of you that have made the decision to come here today, if you could stay here until the end, that would be absolutely great. If you could avoid skiving off, as we say in the UK, it would be absolutely brilliant. And we do have a small memento to give to those of you that do make it to the end. The second part relates to your mobile phones. I'm always a bit worried about asking this. If you could minimize your phone activity during the class, I know there's a lot of other things going on here, a lot of other distractions. If you could try to avoid checking your emails every few minutes, and even better, if you could turn them off, it would be absolutely great. It'd be great if we could all be involved and focused on the session just here. And then finally, just a couple of administrative points. We do have a registration list, which I'll be handing around, so if you could all sign that, that would be brilliant. And then, as I said, this is also our 8th edition. We're constantly looking at ways to improve the series, so we'll also have some evaluation forms at the end, which I'll pass around. If you could also fill them in, let us know what you thought of today's class, if there's anything we can improve, any ideas you might have for future editions, we'd love to take them on board. But that's everything from me. Now I can hand over to you, Elena. The classroom is yours.
Thank you very much. I think I will try to be as fast as possible, because I think the most important part of this session is going to be to basically hear from all of you. I will not go into details. Yeah, basically there are 3 parts, as you mentioned. I think we are all more or less aware of the impacts of climate change on health, and that is something that is becoming more and more evident over time. I remember when I started joining the negotiations 11 years ago, usually when we were basically talking to representatives, even from the Secretariat, from other ministries, they were raising the question, what is the health sector doing here? Because this is an environmental issue, it's not related to health. So it was a little bit difficult for us to basically try to explain where health community was concerned about climate change. And unfortunately, it is becoming clear that climate change is impacting our health. It is evident, for example, in the number of extreme weather events and the direct impacts that people are suffering. For example, flooding, death, accidents. It is also clear the linkage between heat stress and cardiovascular diseases, even stroke. It's also evident nowadays that climate change is impacting also vector-borne diseases, and the dynamics that allow basically infection. So there is a change in the way these infectious diseases are spreading. For example, if you think in highlines, before it was not possible for vector-borne diseases, for malaria, for dengue to be found there because it was too cold, and now it's spreading there. And there is also a clear linkage between climate change and undernutrition, mainly malnutrition, but in some cases also, if you think about the Pacific Islands, also with regards to obesity. What you see in the right part of this slide is basically self-reported health impacts from climate change. So basically, over 100 countries in the world respond to the WHO Global Survey on Climate Change and Health. And there, they prioritize which are the concerns at national level with regards to climate change and health. So you can see again that vector-borne diseases, dengue, malaria, chikungunya, are a priority. At the same level, they perceive everything related to water and foodborne diseases, for example, cholera or overall diarrheal diseases. Also injuries and deaths from extreme weather events, and then heat-related illness and mental health issues. This represents the survey results from 2019. Next Monday, we will launch the results from 2021. And there are a little bit of a change in the perception of priorities at country level. So mental health is coming much prominently now. But I will not disclose all the results. Next slide, please. This is a slide that I really think is very important, and is very important in the context of the negotiations, because everything you are seeing there is equity. So basically, a sticking point, I think, in the negotiations is everything related to the equity principle, no? Of common but differentiated responsibility. As you can see in the top part of the slide, basically the size of the continents and of the countries is related to their emissions. Up to 2002, we have to make an effort to update this slide. But as you can see there, basically Africa is very small. Some parts of Asia are very small, and same with Central and South America. Because basically the most developed countries, Europe, North America, are the most responsible of their emissions. When it goes to impacts, then the picture is basically the opposite. You see that Africa is huge, Central America and South America are huge, and then some bits of Asia and also the Pacific are very impacted. And I think this is a very important point because it is related to everything that is being discussed here. And I think we have to make sure that this is taken into consideration when it goes to finance, when it goes to understanding which are the impacts, when it goes to deciding which are going to be the policy options that are going to be implemented, the interventions that are going to be promoted, because we really need to design those for those that are more vulnerable, not only between countries, but also within a country. Because again, maybe people with less education, with no social insurance coverage, with basically no access to health care, will suffer much more the impacts of climate change. And the same applies to those health systems that are not ready to protect their populations. We saw it with COVID, and we will continue seeing this if we don't really make sure that those health systems are ready to support their people. Next slide, please. I think the health community was very happy when we got to Paris and when an agreement was reached, because we thought that this is really the most important health treaty that will basically promote the health of our health and the health of future generations. Of course, the Paris Agreement is not legally binding, so we just need to make sure that it is implemented and that the objective to keep the temperature up to 2, hopefully 1.5 degrees, it is effectively achieved. Next slide, please. This is an important year for the health community and for all of us here, I think, because it's the first time that under a COP there is an official health program that is being promoted by the presidency. So basically the UK, as the president of the COP, they've promoted a full health program under their leadership. This slide summarizes all the priorities for the COP presidency team. Basically, you can see there adaptation and resilience, energy transition, clean transport, nature, and finance. And for all of them, they've defined a health argument or a health action that can be implemented for all of those. Something I will go more in detail for the adaptation and resilience one. I think something that is very important is also the energy transition, and just make sure that we are informing a fair transition to renewable energy and clean energy sources to basically save lives, mainly related to exposure to coal and to energy sources that are not clean. Again, if we think about equity, we also need to understand who is being exposed. Because if you think about women cooking inside with coal or not healthy energy sources, basically they are going to be the ones bearing most of the health burdens associated with exposure to these pollutants and particulate matter. And the same applies for children that are staying at home with their mothers and basically just inhaling all these pollutants. Next slide, please. The key initiatives included in the COP26 health program relate to climate-resilient health systems, health leadership in emission reduction, basically low-carbon health systems, promoting healthy end disease, and mobilizing the health voices for climate action. We've been working very closely with FCDO and the COP26 presidency team, basically and the Healthcare Without Harm, basically to socialize these initiatives. And I cannot say the number, but several countries have committed already to these initiatives, mainly the ones on climate-resilient health systems and low-carbon sustainable health systems. And they've committed to the COP26 presidency. And basically these countries are saying that they will promote an assessment to understand vulnerability to climate change and the impacts of climate change. They will develop comprehensive plans to address those vulnerabilities and try to strengthen the resilience of health systems. And then they will try to mobilize funding, for example, through the Green Climate Fund, the Adaptation Fund, to try and strengthen the resilience of health systems. Under the Health Leadership in Emission Reduction, basically low-carbon sustainable health systems initiative, countries are committing to first understand which are the emissions from health systems, basically assess which is their carbon footprint and overall greenhouse emission footprint, develop a roadmap or a plan basically to tackle their emissions and reduce them as much as possible, of course without compromising the services they have to provide. And then also try and make sure that funding is mobilized for lowering the carbon emissions of health systems. Some important considerations for that is basically everything related to energy efficiency in healthcare, waste management, water and sanitation, and basically looking at all of the sources, procurement, and green procurement. Energy sources related to healthcare and trying to reduce those. maybe I will stop here and I will invite my colleague Antonis to make an intervention. He's working for the WHO country regional office of Africa, and maybe just a little bit of all the progress made in Africa with these commitments, and then I will continue later.
Thank you so much, Elena, and thank you so much to all those distinguished attendants of this lesson of this session. So I would like to take the relay from one of the starting slides that my colleague presented, and just to highlight that the African continent is one of those continents most highly vulnerable from the emissions and the impacts of climate change on health. So some of those outbreaks that are related to climate change and are apparent in the African continent relate to malaria, cholera outbreaks, diarrheal outbreaks, but also some other upcoming challenges such as dengue fever outbreaks, chikungunya outbreaks. So the challenges for health based on the climate change consequences are very high for the continent. Now, considering this year's high-level commitments on building resilient and sustainable low-carbon health systems, we can say that Africa has been, let's say, one of those continents, one of those regions having indicated a very high interest. So far, I could give a number. We have received 15 signed commitment letters on these two key priority areas. And this is a very encouraging figure, a very encouraging indication on the level of interest indicated by the ministries of health, but also this should be understood also under the, let's say, a more holistic approach at the policy level of each country. I would like to stand a bit on this last comment and say that the process that we have used at, and we have encouraged at the country's level is to engage first of all with those relevant focal points for climate change and health. We have been tremendously assisted in many cases by the Foreign Commonwealth Development Office colleagues in operating in several of those countries, and of course our WHO colleagues to bring together all those actors and all those important stakeholders and elevate the issues of climate change and health to such an important event as the COP26. I would also like to highlight the importance of linking the health sector with the environmental sector, and also highlighting the ecosystemic linkages that are needful to understand how climate change impacts health, and those coordinated responses that are needed at the different country levels. So one of those key, let's say, key objectives that we are trying to encourage and achieve in countries is to elevate the importance of the health sector in the national adaptation plans, and also identify those entry points for finding those health co-benefits in the national determined contributions, and all those actions that can achieve those improved health outcomes at the different countries level. Since we have been very lucky to have the participation also of several colleagues representing different African countries, I would very highly also encourage them to share with us more details on what have been their challenges in achieving those commitments, but as well as what are, let's say, the opportunities opened through these commitments, and what are, let's say, the prospects in front of us after the COP26. So maybe I would stop there, and thank you so much.
Thank you very much, Antonis. I think it was very nice to see the leadership of the African region in getting these commitments, and hopefully now in leading also the implementation and then the knowledge building and exchange of lessons learned. Because basically for us, these commitments are just an opportunity to scale up intervention and action at country level. Another initiative that is very important and has been included in the UK COP26 presidency basically is related to ensuring that NDCs integrate health. So it is called the Healthy NDCs. And basically what they are trying to do is basically to ensure that health is integrated not only with regards to informing on adaptation priorities, financing, but also making sure that the health co-benefits, as mentioned by my colleague Antonis, are basically considered and maximized when deciding which is going to be the way they are going to basically reduce emissions, for example, in the energy sector, in transport, and so forth. And I think the most important maybe initiative is the one related to the health, mobilizing the health voices for climate action. Next slide, please. This year, basically, a very important report has been presented to the COP and is related to the health argument for climate action. You can see there that it has WHO logos, but it is not a WHO report. It is a report that has been produced by the whole health community and with inputs from all of them. And basically, it includes 10 key recommendations and concrete steps to deliver an ambitious renewal of the Paris Agreement and strong biodiversity agenda in line with the WHO manifesto for a green and healthy recovery from the COVID pandemic. It was released on October 11th, and the most amazing thing is that basically it has been endorsed by over 45 million health professionals and workers, and signed by more than 400 health organizations that basically convene all these health professionals. Of course, Dr. Tedros, the head of WHO, also signed it, but I think the most powerful really is to see that over 45 million health experts and workers are basically backing up and trying to promote these prescriptions. Next slide, please. The 10 recommendations that are included in this report are basically there. Build back healthier from the COVID. Just make sure that you commit to a healthy, green, and just recovery from COVID-19. I think we were all happy to see that, for example, emissions with the pandemic were decreasing, no, due to less travel and less commuting to work. But I think we are now a little bit concerned that things may come back to pre-COVID state or even worse. So basically, we have to ensure that this is not the case, and that we take this opportunity to basically make sure that we end fossil fuel use, and health is not negotiable. Prioritize those climate interventions with the largest health, social, and economic gains. Again, both for adaptation and mitigation, there is always an opportunity to promote health. And those interventions that maximize the health gains should be promoted by all sectors: water, sanitation, transport. Let us build health resilience, and this is basically what we discussed before: build climate resilient health systems and support health adaptation and resilience across sectors, but also do so while reducing the carbon footprint of our operations. Let us breathe clean air. guide a rapid transition to clean renewable energy to save lives from air pollution, particularly from coal combustion. Again, if you think about indoor air pollution and all those people that are inhaling all these pollutants and the impacts in their health, then it is clear. And we think this can be scaled up quickly. Reimagine mobility, promote sustainable, healthy urban transport systems, including active and public transport in a safe way. I just live in Switzerland. There is, it's normal to see people cycling to work because it's a small city, it's more or less safe. But even there, we have to cycle in the same place where the trams are. So I fall down twice. I broke once my my shoulder, and it is Switzerland. So imagine in other countries if they don't really promote healthy and safe ways of active transport. Restore nature as the foundation of our health, protect and restore nature and ecosystems, the foundations for healthy lives, sustainable food systems, and livelihoods. Again, due to the COVID pandemic, we all became more aware of the interconnection of nature, health, and environment. And I think it's very important to make sure that everything that we promote takes into consideration this interconnection and tries to promote nature-based solutions that will also promote the health of the population. Promote healthy, sustainable food systems. Again, there is an opportunity to reduce the burden of disease related to food and obesity if we promote more plant-based diets and reduce a little bit the intake of meat. If not possible all, at least a little bit more. Stop funding pollution. This is the most important one and the most difficult to get, but basically ensure that all public spending promotes a well-being economy and make healthy climate commitments. This is related to the NDCs, but basically place health and equity at the heart of the UN climate talks. And lastly, prescribe the climate action, mobilize and support the health community on climate action. Next slide, please. This is my boss, Dr. Diarmid Cambilendro. Well, my two big bosses, Dr. Diarmid Cambilendro, who is the head of the Climate Change and Health Unit in WHO, and then Dr. Tedros, who is the head of WHO. And basically, Diarmid came by bicycle from Geneva to London, approximately 850 kilometers, to hand over a signed copy of the healthy prescriptions to a group of NHS workers. So basically 30 pediatricians and child healthcare providers who then took over this signed version of the prescription signed by DG, by Dr. Tedros, and then they cycle to Glasgow, 800 kilometers. Just passing the message that we need to take action, we can lead by example, and requesting all the negotiators and the people who is here to basically listen to our prescriptions. Next slide, please. This year will be the fourth time that we have the opportunity to organize a global conference on health and climate change. It will take place on Saturday at the Glasgow Caledonian University. And basically, well, you can register online. It's a nice collaboration again between, it's mainly organized by the Global Climate and Health Alliance, but then nice collaboration with the London School of Hygiene and Tropical Medicine, the Wellcome Trust, the UK Health Alliance on Climate Change, and then the Glasgow Caledonia University, of course. And WHO is just part of it because we are collaborating very closely with the whole climate change and health community. Next slide, please. And now coming back to where we are and what we are all doing here. Basically, WHO, together with UNITAR, as part of the UNCC Learn program, we developed an online training on health in the negotiations. Again, we've been following the negotiations for a long time now, And we've sometimes met health representatives that are here with the mandate to negotiate for health or to integrate health within their positions of their delegations. And it is difficult when you come first to one of these monsters, no, to navigate it, because you have all so many negotiating streams, adaptation, mitigation, all these groupings, and then Article 6, Article 1, that is a nightmare. Basically, you don't know what you are doing here. And for us, it's the same. I mean, it's just so slow and so many things to negotiate, finance, that for health representatives was a little bit overwhelming, and for us also to try and accompany them as much as possible and to also get to understand what was happening in the negotiations. So basically we developed this training package that is very useful for negotiators coming here with a health mandate or interested in health, to understand which are the entry points, basically, to make sure that health can be integrated into the different work streams, and which are the most impactful ways of doing this. Next slide. Thank you. So with this, I think it would be just basically the most important bit is just to hear from you. I don't know if you have any recommendations for how we can integrate health within this debate. If you want to share any comments, any views, that is more than welcome. First, please.
Yeah, thank you. I really enjoyed this session, and I mean, coming back to some of your last sentences, that you are overwhelmed, you don't need how to integrate health. This is my first COP here. I've been at other COPs, at WHO, Framework Convention, Tobacco Control, or ILO, etc. But this is my first climate COP, and I have the same impression. Moreover, I have the impression, and I'm kind of disappointed, that health is really not where it should be. And I think we really need to more strongly put forward the health voices, like with this letter, etc. We have also, in relation to the WHO recent release of the new air quality guidelines, we have kind of provided strong support for that and had published a commentary that was signed by more than 150 international societies. That includes the UICC, American Cancer Society. So probably if you count all the members and they represent, it also amounts to 45 million. I have not dared to count that. But what I think I have two kind of issues. The one issue, of course, the first slide that you had started from the self-report some 15 years ago already. But even in kind of later developments, I think it's still a little bit too kind of narrow-minded. When it comes, for example, I just make one example. When you talk about the obesity and perhaps sustainable food, I think we need to see it broader. We know that the kind of meat consumption is also related to cancer. We have established that. So, and the meat production is related to deforestation. So I think we really need to see the broad perspective on what needs to be brought in, why health is so important. So this is my first point. Even your last slides are going in the direction I would like to see, really. And given that, from my perspective as an NCD expert, it's really primary prevention that counts, and that needs to be in all there and all over. And of course, I understand we also need resilience, etc. But if you then think in terms of the GBD estimates, the single most important environmental risk factor for diseases is air pollution, indoor, outdoor. And that is very closely related, of course, to climate crisis. So I think that must be one focus. And then my second issue is more on how can we kind of change. Probably I was not aware even of these, your ECC learning tools. How can we have a stronger impact that the COP27 has health sitting at the tables? It's not a topic, it's not a theme. We have these little events here with 10, 15 people, and it was in the first place difficult even for me to find that these exist here. I'm happy I found it, and I moved between the Science Pavilion, the SDG Pavilion, and this pavilion. But we need to be on the main tables, and because the health voices are important and are heard. Somebody else said, the health voices are the most trusted voices. So we need to kind of take our policy influence and bring it there. In another session, Maria Nera said, this is our COP1. Yes, but we need to jump forward and really make sure we're a center stage on future COPs.
Perfect. I think it was super useful, and all your comments are very relevant. This was a short presentation, but some of the key points that you've raised are already included in the broad view that we are promoting. But I would like to hear from others, what do they think about how we can put health at the center, because, yeah.
Thank you. Yes, I come from a legal background, and this is the second health session I've attended, and it seems I'm not seeing much focus on the law, because litigation, not necessarily litigation. For example, I come from Africa, I'm from Zimbabwe. I've been Googling on the internet, haven't seen anything on public health law or any university that offers public health postgraduates just to train. Like, first and foremost, we don't have the lawyers who are going to deal with public health law. And firstly, we don't have institutions that are going to teach public health law. And as the gentleman next to me said, health should be mainstreamed. It's because for example, we can use the law. It's a constitutional right to say everyone's got the right to a clean and healthy environment that does not cause damage to their health. We start from there. How can we include the legal field into the health sector and to mainstream it into the COPE? Thank you.
This is very important, and something that I would like to mention is that it is being raised in litigation cases. So, for example, the Netherlands, Portugal, the UK even. So basically, thanks to the right of people to life and to health, those cases were won. And I think this morning we were discussing about another one, I think it was in Indonesia, where the country decided not to even appeal it because they recognized they have a work to do and they will not even, so that's an important, I think more has to happen with regards to public health law, but at least this is being recognized somewhere, and there are important cases that should be promoted even more because there is an opportunity for change.
Sorry, if I can also add something to that. In our case in Africa, we've been promoting a couple of projects on reducing the indoor air pollution. So we're trying to bring those stakeholders from different ministries to shape those policies and those legislations that will further promote those practices and translate them into action through the legislative framework. But very, very useful. Thank you.
Thank you. I am here representing MedAct, which is a kind of British-based organisation of medics, which looks at social justice and anti-militarism as a kind of key element. My background is community education, so I'm a lecturer at the University of Western Scotland. So, but I'm also part of the People's Health Movement, and my interest here is how we define the climate issue, and especially how we centre climate justice within this discourse. And if we don't mention the word capitalism, if we don't talk about the structural, development funding, that map we saw, that map is like that because of what the IMF, the World Bank, and the World Trade Organization do. That is one of the key factors. And if we are not willing to speak that truth now, of all times, we should have been speaking it for decades. But if we listen to indigenous voices, we listen to the Latin American countries, which again have been hit by this ideological drive, they will talk about capitalismo, they will talk about how this is ideologically driving. Now we see the market still saying we're going to have net zero, we're going to offset, we're going to green the, it's still profit driven, it's still growth driven. So what as leaders, anyone involved in health, anyone involved in education, anyone involved in the human rights needs to be calling out the core ideological problem at the heart of what we're facing. And the clock is ticking. It amazes me that, very intelligent people. There's a brilliant book called Strategic Ignorance that I would encourage people to read, and it talks about how world leaders, they don't talk about militarism, which is one of the key damaging waste of resources, and yet the money pours into that, taken away, killing people every second of every day. Sorry, but you get my you get my point.
Yeah. Hi. Coming back to, well, my name is Andrea. I work for ISO, the International Standards Organization. And when you were talking about we need to include this in the law and the regulation, I think that's where standards play a role, because we can define things and say how we're going to measure, what we're going to measure, and to validate those measurements. So I think it's hand in hand, voluntary standards in one hand, and then the regulations to advance this. Other way, I don't see a way forward. Thank you.
Thanks for sharing.
Okay. Thank you. I'm Anthony from Kenya, and I really want to appreciate the effort which has been put in giving climate change and health the visibility is starting to get. I want to say that, and I can only talk about the perspective I have, is that there is some effort, yes, but it's not getting the due attention. And I want to say, like, for example, even though there's some effort, we can do much better. For example, when it comes to supporting the various from different agencies that can support implementation of specific activities, actually has been lacking. And let me say, for example, like to be here in the first place, the effort WHO has put to actually say that they will even bring delegates here is good enough, because like where I come from, the visibility at the policy level has been quite minimal, though at the ground we find some activities, like we have come up with some training manual for community health workers on indoor air pollution, but yet at the national level you don't feel about it. We would like to have a forum where you're able to advocate for it and be able to show the common citizens on how their omission or commission actually direct or indirectly contributes to climate change and overall to the health. And I think I would only say that I think we are starting to get some light at the end of the tunnel. And I believe by the time we come to next year, I hope and I'm praying that we get more visible and have a solid foundation for it. Thank you.
Thank you very much. I think he was first. Okay. Yeah. And then.
Sorry, how my friends say, I think from now it's better to see how to get the better way to send a message for the representative of the scope to the moment of the closure or the finish the situation to presentation should be in condition to explain something about health and the need of engage on the health. Even this timing, suppose so many president, honorable president, minister was here, and it should be better emphasized on health and their commitment again together to the health. The WHO should see or should think how to send the message to get this way for people to understand directly the need of health support on this matter against the climate change. With the representative of the COP now, on the time to speak, should emphasize on health with the group of minister, of president, those things, because this is how my friends say. Every time the WHO try to do something, but it's not so emphasized. And this time, how so many ministers, so many presidents came, the representative I, representative of the copy, should explain more about the health to understand better the situation. Thank you.
Thank you very much.
Hi. I just wanted to kind of echo the thoughts from over here. So I'm a population health researcher and also a registered nurse. And I've struggled to find health being on the platform, even though it's supposedly supported by the presidency. I think from what I've seen from the Health Pavilion, there's a very strong case for linking the direct effects of rising temperatures with specific conditions, and also kind of building healthcare systems. But I think there's quite a big recognition within certainly the health research, population health field, that healthcare systems aren't the biggest determinant of health, and that perhaps linking health equity and climate justice on these, zooming out into the actual causes of the causes would be a much more powerful way of trying to get health on the agenda than saying, if we can keep the temperature down, people won't suffer this heat stress. Of course, that's important, but I liked one of the other days, one of the presenters here was talking about people suffering from heat stress, and the way into solving that at that point in time was basically workers' rights, giving them time to rest, adequate water and breaks and these things. And that's maybe something that's missing a little bit, I think.
Thank you so much. My name is Ebo. I'm coming from Zambia. I just want also to talk a little about the impact of climate change on the water resource, because I feel this is a very important resource, water, and a big number of people around the world, especially those from developing countries, have got challenges, accessing clean water, and also issues to do with sanitation. So probably maybe we could also look at that aspect in regards to access to clean and safe drinking water. And in the SDGs, that's SDG number 6. I think a lot of literature is available, and there's quite a lot of data out there. So perhaps we can link climate change related issues with SDG number 6 that talks about access to safe and drinking water. Quite a number, like in my country, I think over 80% of diseases and illnesses at government health facilities are actually related to water. So with flooding due to heavy rains, those that utilize water from the shallow wells are really impacted due to underground water pollution. So it's something that I feel we should really talk much about during our stay here.
Very much.
If you allow, I try to be brief. Thinking strategically and thinking forward, what are the kind of the best, next, and most efficient steps? Do we know how many health ministers are on the delegations? Should WHO, for the next World Health Assembly in May, prepare a statement that all countries should also send their health ministers, that should put health on the stage for the COP27? What are the most efficient steps of getting us there where we all think we should be to make a difference?
I'm a little bit negative, basically because everything has happened already. This year there is no much health ministers, but they've been here before. And again, we've been following the negotiations for many years. And we've been trying to get health into the agenda for many years. This has been debated at the World Health Organization, at the regional committees. But even when there is health representation here, it is difficult to get health into the agenda, because first, it is difficult for the health representatives to get to a point where they are listened, how they should be listened by colleagues in other sectors, and those especially the Ministry of Environment who have the real positions, no? Before coming here, they have to negotiate their positions. And then again, apart from that, I think what we've been discussing before, we all have a different role to play, no? WHO is very strong in dealing with ministers of health because this is our day-to-day. The civil society can push in a different way that WHO cannot to their stakeholders, and then basically we have to continue doing everything that we all know how to do, no? The health people to their own delegations, the water people to the health people, the transport people, and again, it's what you mentioned about people dying in some countries because they are exposed to these temperatures. So we have to work with the labor ministries to make sure that certain rules are followed, just to, again, strategic, I don't know, just to keep on bothering people.
I don't want to dominate, but I mean, I go to various presentations like World Meteorological Organizations. They report on mortalities from extreme weather conditions. So health is there. It was in this morning session on just energy transition about cleaner, safer energy, less coal miners, safer jobs, healthier jobs. So it's somehow there, but it's not brought up by us, and some others occupy that, and
I think there is a qualitative change because before it was just us with a few events, with a few ministers. Now it's everybody talking about health. And I think this is the most powerful way of really getting health into the agenda. For us as the health community, and I think this is the thing we really want to do, we all know that climate change negotiations are a nightmare because there are too many interests at stake. All the oil producers, of course, they want to get something, because if they stop producing oil, what they are going to do? Everybody has their populations, everybody has to think about what next. I mean, it's what you mentioned, of course. I have to stop buying dresses, I have to stop buying, I don't know, hamburgers. No, we all have to change the way we live. But then we have to make sure that there are no big losses for those that are going to make drastic changes to their economies, and this is something that has to happen. Something that we are convinced from the health community is that the health argument is the only one that can get countries to commit and to be ambitious. Because if you think about everybody that is dying from exposure to air pollution, how much does it cost? Again, it's sad, but we have to talk about how much that it costs to your economy. Because if you subsidize fossil fuels and all your people is dying and you are providing health care, you are losing money. So it's as sad as that. But this is the argument that we think can make things change. And this is the only thing, that's why we want to get involved into this, because we really think health is the argument that can convince people things should change. Sorry. Yep.
Just to add that one of the entry points actually could be, to push countries that they include health issues in their NDCs. I don't know when next we'll have the review of the NDCs. So that's 5 years from now. Okay, so obviously we can't wait for that long. But to those countries that are still developing their national adaptation plans, I think this is the best time to approach them, so that we can lobby for the inclusion of healthy in their national adaptation plans.
Yes, actually, I would like to follow up from your point, and also to maybe highlight how these commitments and the COP26 health commitments have already assisted countries to further advocate for the role of health within national policies. So we have been encouraging countries, and we have seen that this has given already fruits to utilize those commitments signed by the highest level at the Ministry of Health and integrate health within the national adaptation plans and elevate the issues of health within the national policies. That is one point I would like to mention. And the second one, going back to climate justice, and specifically for Africa, I would like to say that I don't know about climate justice, but as this slide showed, we can define climate injustice, at least for Africa and at least for health. So at least we have a definition of what is unjust and of what we need to move forward with. Thank you.
Any additional comment? I think it's the last one because I've been reminded that the time is almost over.
Thank you. It's okay? Thank you, Anna. Thank you, Antonio. Thank you all. My English not very well, but I do the effort. Elena show the objective of COP and the link of objective of health group, health. But my question is, the last commitment in Gabon for the SID, Small County in Development, that I talk about Cape Verde. I'm Julio, I'm from Cape Verde. You know, Cape Verde is a small state in development, and the island are a specific relationship between health and climatic change. And the commitment was empowerment. As my colleague said, empowerment, Minister of Health for to show, to understand the impact of climate change and on health, empowerment. Other question is resources. Other question is evidence. We haven't evidence, for example, the vulnerability studies. It was no sustainable. And the other is implementation. For the implementation, we are necessitated, we need to show the evidence. And we need to empowerment the Minister of Health. And we do the link between the 11 step that you show and the commitment for a small state in development as Cape Verde. Thank you.
That's a very important point. There is a full initiative on climate change and health for small island developing states. It's a little bit broader than just climate change because, of course, SIDS have their own challenges. If you think about procurement in small islands and then all this COVID, I mean, they really need to be supported in a different way. Something that I would like to say about the prescriptions, we can promote them as a health sector, but not all of them are within our responsibility. So everybody, again, at their capacity, should push as they can, no? Working with other sectors, trying to ensure, because there are things that we can promote, but they are not really the responsibility of the health. For example, stop subsidizing fossil fuels. We all know this shouldn't happen, but we have to lobby, no? Again, as we can, to make sure that they understand why we are saying this. And with this, I think it's over. Yes. So thanks so much to all of you. I will give then the mic.
Thank you, Elena. Thank you, Antonio, as well, for stepping up and giving a great intervention on the state of play in Africa. You were excellent teachers. I don't know if it's your first time, but you're naturals. So thank you again for that. Thank you as well to all of you. I asked you to take over in the second half, and you certainly did that. That's exactly what we want these classrooms to be like. We want them to be dynamic. We want them to generate thought, to generate discussions. And you all did a brilliant job of really bringing the classroom to life. Just in case any of you are interested in learning a little bit more about climate change and health, or going a little bit deeper into the topic. As Elena mentioned, we do have a couple of courses, online courses that UNITAR has developed in partnership with the WHO. One on climate change and health, one that looks more on the negotiations aspect of climate change and health. So they're both available on the UNCC eLearn platform for free. They're self-paced, which means you can take them at any time, wherever you are. So please feel free to check them out or to share them with any other colleagues if you think they might be interested. I did say we have one more in-person class this week. If you enjoyed, or next week, should I say, if you enjoyed today, that will be next Tuesday at 2 p.m. at the SDG Pavilion, which I think, yeah, I think it's over there. I've walked around 100 times. I still don't know where anything is. I think it's in that direction. Yes, exactly, exactly. Pavilion number 6. That will actually be on changing the narrative of climate change. So looking at the term climate change, whether it doesn't always connect with people in the way that we want it to, the meaning, the use of language to really promote climate action. So that will be next week. And then finally, as I said, if you have time, just let us know what you thought of today's class. There's some evaluation forms just on the side just there. And if I would like to see you before you go, we do have a small memento just to give you for being such brilliant participants and for making it to the end and for not checking your phones. I don't think I saw anyone checking their phones, which I think is the biggest miracle of COP. Thank you again. Thank you, Elena. Thank you, Antonio. Enjoy the rest of your afternoon.
to welcome you to this session at COP26 on climate change, migration, and health. We're going to be talking about how we transform tomorrow, and we're going to be calling for action. So I'm delighted to have our panelists at COP26 in Glasgow and to welcome colleagues and guests from around the world attending the event. I'm delighted to see the number of people that have joined us, and I'm looking forward to a very exciting discussion on, for me, the critical elements of how we save the planet. Ultimately, climate change is about the lives of people and humanity, and there's nothing more important to health than saving lives. So if we do not do the actions necessary to mitigate the impact of climate change and to avert the disaster that we face, then we would be making the biggest health mistake. And climate change is absolutely, therefore, the biggest threat to health. It is natural and normal that the first reaction of most humans when faced with a serious threat is that they look forward to moving elsewhere to mitigate the effect. So migration and climate change are inextricably linked. I'm therefore delighted that we have an excellent panel of experts from key agencies around the world and organizations who will be starting that discussion today with us. And it is my great pleasure that we'll be lucky to attract a leading player in this field from a place that is directly affected by climate change in the Caribbean. We have the person of Dr. Joy St. John, who is currently the Executive Director of the Caribbean Public Health Association Agency, CAPA. And Dr. St. John was previously an Assistant Director General at the WHO, and before that has held numerous positions in the Caribbean and elsewhere in the world, leading health and health policy and health measures. It's my absolute delight and pleasure to welcome Dr. St. John to give the opening remarks for this meeting. Over to you, Dr. St. John.
Thank you very much, and good evening to all. A call to action, how ideal. As the head of a regional organization, CARFA, with the intergovernmental mandate for serving the health needs of the small island developing states and continental land masses with low-lying coastal regions of CARICOM, the Caribbean community. The impact of climate change on health and its transformation of how life must be lived is tangibly significant. CARFA does not have the luxury of not planning for a hurricane or two every year, as larger metropolitan countries do. Neither can the CARICOM countries have the temerity to omit vector control from their budgets as northern climes can. Many funding agencies have focused on the gross domestic product we achieved through the heady days of a robust pre-COVID-19 tourism industry, due, ironically, to our warm climates. And these funding agencies have graduated us from regular funding, resulting in the limited resources the Caribbean has to fight climate change. We really have not attractive funding for the significant effects of climate change on health. In the CARICOM region, each member state probably contributes a fraction of 1 percentage point to the emissions which cause climate change. However, we have the greatest impacts from severe weather events and shocks to our GDP of the order of several percentage points, year after year after year. In recent years, migration into the CARICOM space is not all tourism-based and transitory. The entire island chain is now seeing migration from other countries in our hemisphere and beyond. So for us, the linkages between climate, health, and migration are real. And the call for action has been heard long ago. And we are acting without resource programs in pragmatic ways in order to preserve the health status of the CARICOM region. In the last decade, we have seen unprecedented floods, hurricanes, and even the loss of coastal lands with increasing frequency. And in the last years, the sargassum overgrowth and toxic smell has even caused issues with tourists who frequent many of our beaches. These all have health and economic impacts, but also impact on migration because they affect livelihoods, thereby forcing people to migrate for better living conditions. So for us, we have immigration, often illegal, and emigration of the Caribbean people. The ecosystems that we knew when growing up are so changed as a result of human activity that some do not exist anymore. And the loss of marine biodiversity, especially, is affecting coastal integrity, the fishing industry, and tourism. As a result, CARFA's Environmental Health and Sustainable Development, Vector-Borne Disease, and other technical departments have embarked on a number of partnerships to conduct system strengthening activities to mitigate the impact of climate on environmental and human health. Making the systems more climate resilient can only be accomplished by responding in a collaborative way. CARFA continues to collaborate with many sectors and funding agencies, working on projects such as the Pilot Project for Climate Resilience with PAHO, funded by the EU. The CATS GIZ Partnership for Water Quality Assessment, Coastal Settlements Wastewater Solutions, and other things such as watershed management. The EU CARIFORUM project, which looks at water and sanitation baseline assessment surveys, the impact of climate change on water and sanitation, development of early warning systems, climate resilient water safety planning, and also capacity building and leadership in climate change and health. And then there's training in hurricane and vector-borne disease preparedness and management of evacuation shelters. And we are very proud of the Caribbean Health Climatic Bulletin, which is a joint collaboration between CARFA, PAHO, and the Caribbean Institute for Meteorology and Hydrology, and aims to help health professionals identify and prepare for favorable or inclement climate conditions in the Caribbean on a quarterly basis. One of the activities which we have developed, which could have relevance in supporting safe migration in COVID times, is the development of evacuation protocols, which we did during the La Soufrière volcanic eruption in St. Vincent and the Grenadines. This eruption created an avenue to have documented guidelines in the event of any climatic event demanding evacuation. In the region, we have seen displacement of some migrant population settlements as a result of devastating hurricanes. And these evacuation protocols can serve as a preparedness tool. Attention must be paid to the mental health impacts as well, for these are also real and often more debilitating. In cases of forced mass migration, as happened in Barbuda a few years ago, as a consequence of severe climatic events, no effort should be spared to preserve the mental health of these populations. The issues of impacts of migrant health on populations is not unique or new, but happens across the Caribbean. Because of the negative public health impacts that non-provision of health to migrants can have on populations, consideration should be given to the health of all, rather than separating the health of migrants from the usual population. The need for adequate data collection, consistent monitoring of the migrant population, as well as the development of an evidence base to make a case for climate change, can significantly advise decision makers of the impacts of climate change on health and migration, all while protecting the public health. It is now time for all to act to protect humanity from this scourge of climate change. And so in closing, I want to say that the negative impacts of climate change, health, and migration will continue to contribute to the achievement of all of the SDGs unless we utilize our strength in numbers and act more cohesively to push world leaders to act now. I thank you. Over to you.
Thank you very much, Dr. St. John, for that really eloquent, clear intervention. We're really grateful for those wise words. Almost everything you say would be entirely consistent with, I'm sure, what we would wish to happen in the planet. I am looking forward to a very fruitful discussion, and we're really grateful that you joined this event and you'll be joining our follow-up event next week. Thank you. I'd now like to move us to the next part of the discussion, which is the panel. We're really lucky to have eminent speakers representing the key UN organizations that have a major role to play in this, as well as important parts of civil society that are contributing to the nexus of climate, migration, and health. We have Dr. Santino Severoni, Director of Health and Migration Program at the World Health Organization. Santino has decades of experience in this field, previously running the European program and now running the global program within the WHO. A pleasure to have you, Santino. We have Dr. Jacqueline Wiekes, the Director of Migration Health Division at the International Organization for Migration, the UN's migration agency. And for, again, decades, Jacqueline has had experience of dealing with migration health at various levels in different parts of the world. Really lucky to have you here, Jacqueline. We have Stephen Cornish, the Director General of the MSF Operational Center. Stephen also has got a background of over 10 years in multiple countries around the world in emergencies, tackling serious challenges that are relevant and exemplify the effects of climate on society. We have Gautam Narasimhan, the global lead and advisor, senior advisor to UNICEF on climate, energy, and environment, who has got extensive experience in this field, and we're going to get an intervention from the perspective of children who are going to bear the brunt of migration and health. And then we have Runa Khan, the founder and executive director of the Friendship NGO in Bangladesh, which serves over 4 million people on the ground at the cutting edge of what we need to do to address the challenge of climate change. We're lucky at the end we would have some closing remark from Annelise Dupont, director of the Vichot Villamé Public Health Center in Paris, Berlin at the University of Paris, and I'll introduce her more fully before she gives the closing remark. I'd now like to move us into the first part of the panel, which is a question that I would like to pose to Santino. So Santino, from your extensive experience in this field, dealing with policymakers, I want you to reflect on the policy and political implications of the nexus between climate, migration, and health, and what you think the main disconnects and challenges are around policy, practice, and academia.
Good evening, Ibrahim, and thank you for having me with you tonight. Indeed, this disconnect or the interconnection probably need a bit of analysis of the situation. When we look at the global policy landscape around migration, health and migration, climate changes, the situation is changing almost on a daily basis. If we turn and look at the past 10, 15 years, we see that 2017, the SDG 2030 agenda was adopted with a clear goal on health, migration, climate changes, followed by Paris agreements. And then 2016-18, the two global compacts on refugees and migration were negotiated and then adopted. We felt as a WHO important to fill or to strengthen the engagement in the health sector. So a global action plan and resolution was adopted in 2019, promoting the health of refugees and migrants. So if we look at all these policy and initiatives and frameworks, the situation is looking not that dramatic in reality. A lot of tools, a lot of instruments, a lot of consensus, because all those frameworks have been adopted by member states. So the point is, why we are still not satisfied, or the question might be, is this enough? What we can do more? Well, indeed, what we have done is important, is a lot, but probably not enough. My first observation is that probably in all these policies, we were not able to transmit the sense of urgency of action, but we tend to take a long span to change the situation. The concept, probably we didn't transmit enough the sense of shared responsibilities among countries, among partners, and among stakeholders, and the inter-country collaboration and cooperation as a fundament for success against those challenges. Indeed, climate changes, migrations, and the implication of those two phenomena have tremendous repercussions on the health sector, but those are common challenges for the world in the millennium. Allow me to make a digression and touching upon the lesson learned from COVID-19. What we learned on COVID-19 that the public health approach, the rational approach, using evidence, research to analyze and to face challenges is not semantic, is not rhetoric, but it's really the only way to go out. And a coordinated approach based on solid facts and mutual support and cooperation among countries is absolutely vital to win the challenge posed by the SARS-CoV-2 virus. And pandemic, at the end of the day, has been dramatic, has been tremendous, but we start to see the light out of the tunnel since vaccine been made available. The situation in relation to climate changes, the situation in relation to migration, we know what's supposed to be done, but we don't have a vaccine. We need only to engage into actions. And the paradox is that the actions are very well known by all of us. So if I'm going to look at from the angle of migration, in the interest of migration, it's paramount that we encourage countries to integrate human mobility scenarios into the climate changes policies, plans, and actions. It is not just at the level of global or regional framework, but really as a concrete actions at the country level. And again, COVID-19 experience showed to us that to have inclusive systems which are able to provide service for everybody are possible, and they are manageable from the financial and capacity point of view. Then provision, keep providing services in acute phases to make sure that during crisis there is access to essential basic services, but then to shape our health systems in the way that inclusions, responsiveness are a fact, a real fact, daily fact for everybody. Resources. COVID again told us that without serious investment, could be vaccines, could be preparedness, could be the entire pandemic response, but without financial investment, we are not going to go out from the crisis. And in this case, again, it's absolutely paramount that we start to dedicate resources in order to respond and to address those millennium challenges like climate changes and migration. Last but not least, not to forget to do something very essential, to monitor progresses and to adjust our policy and actions on the basis of the evidence we are collecting from the monitoring and studying and analyzing the progress, and to adjust our policy, to adjust our reactions. Last point to mention is related to research. Research also have been seen, particularly in the area of health and migration, but also on climate change, an enormous development in the last decade. But what is missing really action at country level with a strengthening of national information system and collection of data which can support fact finding, walking the talks, and concrete actions. Thank you.
Thank you very much, Santino, and thank you very much for keeping to time. A really comprehensive summary and a robust answer to the policy implications. So I'd like to move now to Jacqueline. Jacqueline, Santino has alluded to the policy implications and the political implications of this nexus of migration climate change on health. I'd like to ask you to draw on examples from your extensive experience to think through for us issues around governance, around rights advocacy, and around policy of this nexus of issues. Are you able to give us your reflection on that?
Okay, thank you very much, Ibrahim. Hope you can hear me well. You okay? Yes? Just checking. Okay. Thank you for having me here today, Ibrahim. I'm really honored to speak to you on behalf of IRM on this very critical topic. Actually, it's a very complex question that you're asking me. Lots of sectors involved and layers, and with many challenges and opportunities. As we heard, people who migrate or are displaced in the context of climate change may be exposed to health risks, including mental health risks, before, during, and after the journey. And their access to primary care and continuity of care is often disrupted during the migration continuum, including due to fragile or damaged health systems. We often think of those who have been forcibly displaced as a result of rapid onset climate change impacts and their exposure to health risks. But we must not forget those migrants who have been living in a community prior to a climate change impact, nor those unable to move for economic, social, or cultural reasons like disabled persons, elderly, minors, so on, and who remain basically trapped in degraded and dangerous environments. The communities within which they are hosted may already have weakened health systems and reduced resilience, and migrants often, in addition, have limited or lack of access to adequate health services due to their status as migrants. So once a disaster hits, these communities have very little protection or safety nets, and the vulnerable groups in these communities are at a double disadvantage. Which was the case for thousands of mainly Asian migrants who worked in agriculture, fisheries, and construction along the shorelines at the time of the Indian Ocean tsunami of December 2004. While tourists affected by the disaster eventually had the means and support to be moved out of the affected area, irregular migrants, for instance, had greater difficulties accessing, including healthcare and restricted means to safely to return home. In this respect, we can learn from relevant past non-climate change disasters and strengthen support to the most climate change affected countries, including small island developed states, their populations, including migrant communities. A concrete example of how IOM contributed to the resilience of host communities and migrants already present in areas affected by climate change can be seen in Bangladesh. In 2020, to put an end to the frequent power outages in the formal settlements of Cox's Bazar, IOM installed solar panels in its primary care centers and wash facilities, which provide vital health services to the Rohingya community, including outpatient and inpatient consultations. Thanks to the solar panels, each center can provide uninterrupted services, including hygiene and sanitation measures to mitigate spread of diseases as COVID-19. Another good example can be found in the Philippines' response to the Typhoon Haiyan in 2013. As part of the National Response Plan, the Philippine Health Insurance Corporation declared it would subsidize the healthcare costs of typhoon-affected individuals and also allow delivery of hospital reimbursements, advance of claims to enable the rebuilding of affected health. Now, looking forward, ensuring migration health is addressed climate change discussion in the COP26 is crucial to ensure policy coherence between the different global frameworks related to migration, like the Global Compact Migration, climate change, the UNFCCC, Sendai Framework, and health, like UHC, Universal Health Coverage. So concretely, since the adoption of the Cancun Adaptation Framework, joint technical collaboration with the UNFCCC and Observer IOM and other partners to address the challenges posed by climate change for human mobility led to the inclusion of migration and displacement in the 2015 Paris Agreement. And the Paris Agreement also established a task force on displacement under the Executive Committee of the Warsaw International Mechanism for Loss and Damage, to which I am a founding member. Equally important is to ensure climate change angles are included in migration and health-related topics. So on the health side, the overarching universal health coverage principles in 3.8 and also reflected in the mentioned WHO Global Action Plan for promoting the health of refugees and migrants, provide a very critical entry point for this nexus. Likewise, on the migration side, the GCM objectives underlining migrants' rights to health offer such entry points as well. Moreover, at the global migration governance level, the UN Migration Network, for which IOM is the coordinator and secretariat, provides a platform to foster joint efforts towards coherent migration governance advocacy for migrant rights, in particular through the thematic priority on climate change and migration, and the working group on access to services, including health services. Looking at the immediate future, the first International Migration Review Forum in May 2022 will review the status of the implementation of the Global Compact on Migration, including gaps and emerging issues like, of course, this one. And it will provide another very concrete opportunity to bridge domains that are at stake here, as well as development for action. So opportunities exist, as already was said, and IOM stands ready to enhance the policy across already mentioned frameworks, working closely with member states and partners like you here today around the table, and translate efforts into regional and country level action. Thank you very much. I'll stop here.
Thank you very much, Jacqueline. Absolutely clear. There were some sound challenges, but hopefully we'll add a transcript to the recording for those that could not hear the excellent intervention and specific examples that are being articulated by Jacqueline addressing this question. Thank you indeed. So I'd like to now move us back to the conference center in Glasgow. And I wonder if Stephen Cornish, Executive Director at MSF Operations Center, can hear us. Stephen, I'd want you to tell us from the perspective of MSF why this nexus is consequently an urgent issue to address now. And perhaps using examples on the ground that MSF has encountered, can you illustrate what the impact already is in operational terms of climate change on migration and health? Over to you, Stephen. Can you hear me, Stephen? We can't hear you yet. Technology problems. We still can't hear you. While we're waiting for the microphone to work, I'm really pleased and delighted to see all the comments from around the world. It's impressive. We have people from every corner of the planet. Hopefully this will be a true call to action, and that our findings and conclusion from this discussion can then impact policy. Great. Sorted. Technology problem sorted. Over to you, Stephen. Did you hear my question?
Yes, we'll come back then. Okay, so you can hear me now? Excellent.
Yes.
Sorry about that. So absolutely, I'd love to give some field examples and expand this nexus. MSF has been working in the nexus between disaster, disease, conflict, and displacement for a long time, but now we're seeing both in disaster, disease, and in conflict, increasing migration, both as a temporary measure and as a permanent measure, affecting the populations that we work with. In Somalia, for example, this past year, we've had flash floods, cyclical droughts, and a locust epidemic, which has ravaged livelihoods. It's wiped out the cover that the herds need to survive. The herders, therefore, are having to move further and further away, bringing them into conflict with other communities. It also lowers the nutrition status of the children, rises disease level amongst under fives, and really arrests the ability of those herders to be able to be in a position to be resilient and to recover. In Honduras this last year, we saw 2 Category 4 storms, Iota and Eta, very late in the season. They caused tens of thousands of people to be displaced, a big increase in vector-borne disease and in dengue. We also see, of course, the migration, which we typically link to violence or search for a better life across Central America going up into the US. But what's interesting is when you take some time and you speak to many of those migrants on the road, you ask them, when did these problems begin? And they'll say, well, several weeks ago or several months ago. And so then you say, well, what changed? Why is it that the violence only started then? And they'll say, well, actually, over the last several years, on our farms and in our villages, we've been unable to know when to plant. We've had reduced harvests, and we're just simply not able to continue our livelihoods. And as a result, we migrated into the city. The city is where we found the violence related to gangs. And then we took this road up to hopefully find a better life in the US. It's also changing where we work, because now we're working in many of these hotspots where migrants are being pooled, whether in Greece or Lebanon and Mexico. And what's happening actually is we are re-traumatizing these people. We are making deterrent policies, rising the level of fences and border security, and externalizing migration and asylum policies, which basically make migrants, asylum seekers, and refugees have to take ever more perilous journeys. And they become exposed to ever more violence. Many of them already fled conflict or fled the violence that I've spoken about already, but then the system itself is re-traumatizing them along the way. And there we see extreme levels of sexual violence daily. We see mental health challenges with people not knowing where to go, how to get there. And this has changed the way that, in many cases, that we work, because normally we'll be providing vaccinations and under 5 nutrition and inpatient wards and surgeries. But the migrants on the move who are subject to these policies don't want to stay. Even when they have underlying conditions, they're so anxious to move on that we're providing them more with sexual and gender-based violence support, sometimes termination of pregnancy, hygiene kits, mental health support and information to help them along their way. And once they get to destination cities, or in cases like in the Middle East, where they can't get any farther out of North Africa, we're ending up opening centers to treat the torture that these people have undergone, and centers to treat the sexual violence that these people have undergone. And these additional traumas and this additional violence, we bear some responsibility for that. And we call it a migration or a refugee crisis, but the reality is we really have a reception crisis in the US, in Australia, in the EU, those countries that are often most responsible for the effects of climate change. And we've made promises of transferring technology and of transferring assistance and helping countries adapt. And in many cases, I think this migration discussion, while so fundamentally important, has been turned around by commentators, by media, by sometimes far-right extremists who have made us rise our borders and rise our defenses a little bit the same way we've seen with COVID, where we focus on our own problems rather than on assisting the global world, of which we have a responsibility to do. And migration, make no mistake, is definitely going to be a part of the answer, whether it's localized, regionalized, or in some cases internationalized. But there's a very interesting study which was just published by Vinke and Rotman, done in Burkina Faso, which studied men who migrated seasonally when the crops came under extreme weather pressure, and also their families who were left behind. And this study is actually challenging the notion that in all cases we will find a better life. In fact, it shows that the psychological difficulties, the mental health stress, and also the much sought after improvements in nutrition and in way of life don't necessarily occur. And this isn't to negate the need for migration and more open arms, but it is important that we don't maybe jump ahead of our other responsibilities of providing the adaptation, the technology, the basic needs. Many of people in the world, millions of people around the world, still don't have access to basic healthcare or the basic building blocks of life. And we have to approach this in a very holistic manner. But I think that study is interesting to look at. And while I was reflecting last night about what I would say today, I went to an event last night and I met 2 young people. Joy from the Philippines, who had been an activist, and Carlos from Islas Canarias. And both of them told me how the young people of their generation are dealing with mental angst and a climate grief that's permanent. For them, they don't see the ability to have a better life. And so we absolutely have to come up with legalized channels for healthy and safe migration. And I'll just finish on that. The World Refugee and Migration Council has been working on just that, to try to make a climate right to migrate and a whole category of climate refugees, and is really running up against the West and difficult powers to be. And so I think it behooves us all to respond in the field where migration is happening, along the routes. It behooves us to reduce the barriers that we're putting into place that's re-traumatizing people along the way, and to work out safe legal protection for the climate migrants and refugees and asylum seekers to come. Thank you.
Thank you very much, Stephen, for that. As always, MSF is right there on the ground and for the concrete reflections on what happens at the cold face. I'd like to now move to our next speaker. We all know that our failures to act today would have the greatest consequence on children, and there's no better organization or entity than UNICEF to respond to this. So I'm delighted to be asking Gautam Narasimhan to reflect on what the implications of climate change would be on children and child health in relation to migration and displacement and population movement, perhaps using the examples from your experience and from UNICEF's wider experience dealing with children and their future.
Thank you very much. And much of what I'm going to say is probably going to be was said before by Stephen, but perhaps far less eloquently. And you put your finger on it, as distinguished chair. The confluent children bear the brunt of the impacts of climate change. So UNICEF, recently we released some research where we tried to, it's a truism that said children bear the biggest brunt, children are our future, but where are children affected? What are the impacts that they face? How big is the problem? And the results are shocking. Virtually every child on Earth is exposed to at least one climatic or environmental shock. Over 1 billion children are exposed to the kinds of shocks that make them highly vulnerable. And if you look at the countries and the places where UNICEF works and where children are the most affected, the numbers are shocking. So in Bangladesh, it's something like, and overall, first globally, we're looking at close to 9.8, 10 million children last year alone that were displaced as a result of climatic shocks. And that translates to something like 27,000 children each day. And you come into countries countries that are the most affected. Bangladesh, where 12 million children live near river systems that are at risk of flooding. Bangladesh, where 3 million children live in farming communities that suffer from regular drought, which is expanding. And in terms of the impacts, I mean, much as Stephen said, when you interview migrants that traverse the corridor from Guatemala and into the US, 70% of children, particularly from indigenous communities, already suffer from malnutrition. And this malnutrition is becoming worse as a result of climate change, with children being the worst impacted. And second, as Stephen also mentioned, one is the scale of the problem and the level to which it's increasing. And the second issue is that where are these children moving to? They are often moving to places where health systems are already under stress, where health systems are already unable to cope. For example, if you look at when we were speaking about Bangladesh, each year a city like Dhaka receives something like 400,000 new migrants into the city. Many of them, most of them, end up in slums. 93% of the slums in Dhaka don't have adequate access to healthcare centers. The third and then when you look at what the impacts that are there on children, it's almost no surprise that, something like the children suffer from diarrhea for most of their childhood, an average of 14 years, leading to diarrhea and malnutrition, which are already leading causes of death and under 5 mortality being exacerbated. And the third issue, first, from the scale of the problem is increasing. The second, children often end up moving to areas where health systems are finding it hard to cope. Stephen, as you said, our migration laws are not keeping up. So already, without regular safe pathways for children and families impacted by climate change, many have no choice but to adapt. Whether we like it or not, adaptation Migration is a climate change adaptation mechanism. And these means that migrants moving in the context of health and climate change often end up as irregular migrants, with their access to health even more compromised. And now, and this was all before COVID-19. With COVID-19, this is further constraining options for migrants, especially children. And also, it is also, as borders close, it is disrupting seasonal migration patterns, which again often pools migrants in areas with even worse health services. So it's a bit of a perfect storm. And then, but leading back to what Dr. Savaroni at the beginning said, whether we choose to call it a paradox, whether we choose to call it, we know what works. We know that we have to plan, prepare, and map. We know, and there are great examples of where this has already been done. You take Indonesia, where there's a disaster risk index map, and which is already being expanded into other areas. In rural Pakistan, where we look at drought forecasting and the impacts that it has on migration. We know that mapping, planning, and preparing is necessary. We also know that we need to strengthen resilient health systems. And we know that we have to adapt our adaptation and migration tools, like as much as was said. And finally, we need to partner with young people on the move, because these are the people who not only are impacted the worst, but also often will have the best solutions for what needs to be done. So I'll leave it at that.
Absolutely clear. And to the point, we must do more, and we must look after and look out for our children. Otherwise, the planet has no future. I'd now like to move us to the last panelist to give her intervention. It'd be really interesting to hear from someone on the ground at the cold face of it in Bangladesh. I wonder, Runa, if you can reflect on what the main challenges are in Bangladesh that we face regarding climate change, migration, and health. Over to you.
Thank you very much. Good evening, good morning, good afternoon, wherever you are. And I'm very, very happy to be on the panel today with our guests here. So Bangladesh is a delta built of silt, It's 7th on the Global Climate Risk Index, battered more and more frequently by climate disasters, and is faced with submersion within decades if the world keeps warming at its current rate. We are really on the front line. A country of 170 million people on 148 square kilometers of land, 1 meter rise means 1/5 of the country goes underwater. 42 million people are at high risk by 2050, thus becoming foremost in the number of people to be impacted. Let me take you to the shores or nomadic islands on the rivers and coastal belts, which really face the brunt of the climate impact yearly, daily. Imagine there is an island 2 kilometers by 2 kilometers. Due to impermanence of the land, no electricity, shops, schools, or healthcare. Sometimes not even a boat to carry people to safety. Lands continuously eroding, shifting, remaking. Home to millions. Each migration makes them poorer, more vulnerable, further away from access to any basic services. And suffering, it really has no statistics. I'm the witness of a child being burned, crying for 3 days, no boats to take her to access pain relief, not even a drop of oil or an egg in the island to ease her pain. A mother coming to me to ask, should I kill my child? People are saying there is no hope. It was a child with cerebral palsy. And there, in the coastal belt, the process of salinization, exacerbated by rising sea levels, embankments broken, drinking water contaminated, leaving over 33 million people at risk today, with health problems like preeclampsia or acute respiratory infections. There was Mashkura, ostracized by her family due to 3 miscarriages, came to a friendship clinic, and after switching to safe drinking water from our water treatment plant, her 4th child was born safe and healthy. IIED found that the rural poor in Bangladesh were spending an average of $2 billion a year to address the impacts of climate change, more than the government and the aid agencies' spendings put together. Despite striving for a pluralistic, decentralized healthcare system, truth is, like in many third world countries, Bangladesh has most of its healthcare systems and medical personnel located in cities and towns, regulated and controlled by private sectors having quite unequal treatment between social classes. And even in Dhaka, having 20 million residents, we are seeing over 2,000 migrants arriving daily. Infrastructure, goodwill, plans does not necessarily always make impacts. Internal displacement, unlike intercountry migration, which everyone addresses, is totally silent and invisible. Simultaneous with poverty, inaccessibility, lack of knowledge in migration results in migration, and then climate impacts becomes a human disaster. Then things like pandemic happen. 24.5 million new poor and an increased poverty rate of 42% in Bangladesh. 20 years I have worked with millions of IDPs, witnessed the brutality of climate impacts on communities who were never even given a chance to hope. Recognizing that permanent healthcare infrastructure was really impossible to serve migrant communities, we remodeled the service delivery and started a mobile system for delivery of health to the migrants. So we started the first ship hospitals with a 3-tier healthcare system, curative, preventive, and behavior changed. And then we saw results. EPI coverage went from 37% to 98% in 2 years. Maternal health from 20% to over 70% in 5 years. But we realized that just health itself was not enough. We made 4 promises. One was saving lives, climate actions, poverty alleviation, empowerment. For climate, migrants need everything. A platform of services to start and restart life. And only then can healthcare be said to be effectively delivered. I have a short film, 2 minutes, on problems and solutions and the impact of holistic interventions. Please play that. Thank you.
And the technical team play the video. Good.
Since 20 years, 100% of Friendship's core function is working with climate displaced persons. Siloed themes for challenges which are interconnected truly can't work. And at the core, ensuring that human dignity is never at stake as a result of our actions. Today, 7 million people directly access the Friendship services, all migrants. Thank you.
Thank you very much for that, Runa. Thank you. Always important to see what's happening on the ground and where we can make a difference. So the next part of the discussion before we conclude is I'd like to give a chance to each of our panelists to, in a sentence or two, try to articulate what they think we need to do when we talk about action, because that's the purpose of this event. I'd like to start with you, Santino.
To Ibrahim, I would be very telegraphic. In a tweet, depoliticize the narrative around the actions needed and focus on country actions in the interest of everybody.
Excellent. Thank you very much for that, Santino. Can I move to you, Jacqueline? Again, in a sentence or two, can you tell us what you think needs to happen?
Okay. We should learn from our prior experiences in responding to slow and rapid onset emergencies which have triggered displacement and exacerbated health system challenges. Also important to consider the different level of vulnerabilities within communities affected by climate change impacts and the fact that not all will have the same coping mechanism. So only by ensuring no one is left behind will we be able to protect the human rights and dignity of migrants and ensure resilient communities and responsive health systems. Thank you.
Thank you. Stephen?
Well, I think we need to do a few things. One is we must get much better at treating people on the move, and that goes from everything from mobile medical records to grab bags of medicines that are linked to non-communicable diseases, things that we can help people with during this treks that they're taking. Second, we have to start to ensure that there are safe passage for migrants everywhere. We have to put an end to this Fortress Europe mentality, Fortress US mentality. And third, we need to codify that into policy through a change to the Refugee Convention that would allow a category for climate refugees.
Thank you very much for that. I'd like to now ask Gautam.
We have a lot of words that we use, refugees, migrants, but we should remember the most important words. These are children. These are children who deserve care and they have the right to do so. And to do that, we need to do many of the things that you just eloquently said. We need to ensure that we know where the children are vulnerable. We need to understand where they are moving to and strengthen health services, often in ways through mobile clinics or more innovative ways. And we need to adapt our laws so they can keep up, because these are children.
Excellent. Thank you very much indeed. And last, Runa, any final words before we move on to the concluding part?
Thank you very much. First, to understand that there is a gap between wanting, understanding, and actually doing it and the impact. Thus, addressing very fundamental issues that IDPs, internal migrants, need to be dealt with, not in the same modality as it works always in the country. They need a different modality of intervention for it to be working and for them to actually have, have impact. And also to look at the micro and macro both together, what we need to do ourselves and what we need others to do who do not, whose impact is happening on us. For example, in the case of the climate and in the case of the country, but also the individual responsibility, I think, is very important.
Thank you very much, Runa. So we now move to the last part of the event, and it's my pleasure to introduce Annelise Dupont, Director of the Vacaville Public Health Center in Paris, Berlin at the University of Paris. Annelise has extensive experience in the area of information and communication sciences, researching activities around media coverage of crisis, including environmental degradation, climate change, and migration, and therefore is well placed to articulate the concluding remarks to this important discussion. She's extensive experience of doing similar things in multiple international events, whether it's the World Health Summit or previous COP conferences. Annelise, we are delighted to have you here to give the closing remarks to this meeting. Over to you.
Thank you so much. So I am so grateful for everything we learned during this session, and I really want to thank all presenters and all participants. I'm glad that we could gather today so many experts from major international organizations around this emerging issue, and I am happy that this crucial topic made its way to COP26. Although migrants' health and climate-induced migration are known to be major challenges at present, few attempts have been made to consider the complex associations that unite climate change, migration, and health in a comprehensive nexus. Therefore, it is essential to highlight the linkages between these three dimensions and encourage new research about how planetary health is concerned with and within this three-pronged nexus between climate change, migration, and health. It is a great opportunity that a scientific journal like The Lancet offers a window for publication that encourages research articulating these issues. Without such framework, research agendas are likely to expand in different directions and policy responses to develop in an inconsistent fashion. Because migration is not automatically an indicator of vulnerability, it can also be an adaptive response to cope with the effects of climate change, and not just in low-income countries. Moving to a new location might avoid the hazards from extreme weather events and damage physical environment, improve health suffering from undernutrition or freshwater shortages, and eventually enhance access to healthcare. Migration, in this case, can improve human security and constitutes a form of health-seeking behavior. However, as is the case with refugees, many of the regions that receive migrants prompt to move by climate change are located in developing countries, where public health resources are lacking or inadequate. Thus, the health risks associated with climate-related migration are becoming a key issue and also a source of disability, morbidity, and loss of life. Furthermore, migration itself is often a dangerous journey that presents high risks for the health and the lives of the migrants. Since 2014, according to IOM's Missing Migrants Project, 45,000 migrants have lost their life in the course of their migration journey. Many have died at the border, trying to cross the Mediterranean Sea. Others have suffered violence from smugglers, the police, or the Coast Guards. Their dangerous journey also bears a huge toll on their mental health, which is usually not looked after. How we will address this issue is of crucial importance. Scholarly communities working on the climate change, migration, and health need to coordinate to bring together the data, methods, and expertise. Planetary health demands new coalitions and partnerships across many different disciplines to meet the pervasive knowledge failures. Together, climate change and migration will have a multiplying effect on health that we should not ignore. It is now time to address these three dimensions together rather than two at a time. This approach will require the design of joint research agendas, methods, and projects across scholarly communities. The concept of planetary health can prove a very welcome instrument to achieve such connections and inform meaningful and consistent policy responses. Thank you very much.
Thank you very much indeed, Annelies. That's excellent. So it remains for me as chair to close the event, but before I do so, I have three important tasks. The first is to say to those that have asked questions that remain open, that because unfortunately we've run out of time, we'll respond to you using the contact details you provided, and there will be a recording of this event for those that have missed it that you can listen to subsequently. The second is to make an announcement about the remainder of events that we have. You may know that this particular webinar is part of a series of events at COP26, jointly organized by the Lancet Migration Initiative, which is an initiative co-hosted by multiple academic institutions, including UCL. together with the journal The Lancet, the International Organization for Migration, and the WHO. And this is one of several events that we are organizing jointly. The next series of events would be on the 9th of November next week. And in the morning, GMT, between 10 to 11 a.m., there's another event on the same subject, but looking at interconnected challenges for the 21st century, to be hosted in the French Pavilion that would include a more political level of intervention with the leadership of the UN Ban Ki-moon, former leadership of the UN Ban Ki-moon, Dr. Tedros from the WHO, Antonio Vitorino from IOM, coordinated by Jocelyn Clark, and a series of government ministers intervening in that event. So please do join that event. We also have another event later that day. Again, the subject of that event is the health argument of climate change, the COP26 health program, which is at 6:30, 18:30 GMT on the 9th of November. It now remains for me to thank all of our panelists, our speakers, and the attendees for an excellent webinar. I'm delighted that we have had a very productive discussion, and I look forward to the subsequent event at this meeting. Finally, thank you very much for the individuals behind the scene who made this possible. Rita, Miriam, Elenia, Alice, Rifat, and colleagues from IOM and WHO. Thank you very much indeed. Have a good evening and goodbye.